PCE.
PCAC.
Ayan, loud and clear. Naririnig ko po na. Ayan, so by the way, ayan, update lang po na sa ating COVID, guys. Siyempre, part kasi ng ng protocol po natin today, we have the BLS na plus the COVID protocols po. So as of this morning, yeah, total cases ng COVID na po all over, okay, let's say all over the world, we have 252,400,461 cases. And then total deaths of 5,086,742. Okay, all over the world na po yan. Hindi lamang siya Philippines na. Wait lang, hahanapin ko lang. This is based on John Hopkins kasi. Ayan, for a while. And then for the Philippines po, total cases ng Philippines is 113,016. Total deaths in the Philippines, 4,645 na yun po, na based on John Hopkins. Kasi for me, ano po, very kasi accurate po yung John Hopkins po natin. So again, we have the three kinds of life support. We have the BLS, ACLS, and then we have the PCAC. Now, with your BLS, you need to be licensed there. Your ACLS also, kailangan license ka din. And of course, if ever kung, let's say, master ka na sa BLS, master ka na din sa ACLS, then maganda po yung prognosis ni patient. Now, when we talk of BLS, guys, this is the basic life support. And this usually happens on a pre-hospital setting. Pwede siyang mangyari, di ba? Pwede sa school, pwede po sa restaurants, pwedeng sa church, pwedeng sa mga malls. So if ever you saw someone, let's say, di ba, biglang unconscious, no pulse, no breathing, then you can perform your BLS or the basic life support. Now, when we talk of ACLS kasi, this usually happens on an intra-hospital setting. Siyempre, dala mo na ang patient, di ba? Kasi nag-activate ka ng 911 kanina. So from outside hospital, siyempre, idadalhin na po siya sa what? No? Sa ER or sa emergency room. So ang tawag natin doon, we have the ACLS. And then inside the ICU, from the what? Let's say ER, i-refer na po natin ang patient sa ICU. Then ang tawag doon, it's the post-cardiac arrest care. So from the word itself, post-cardiac, meaning after a cardiac arrest. So after a cardiac arrest po, there should be continuity of care, to prevent the occurrence of stroke. Because usually po, after a cardiac arrest, after, di ba, let's say, nag-heart attack ang patient natin, expected po, tapos pangit yung na-deliver natin na care, expected na magugulay ang patient natin. Pag sinabi kong magugulay, magkakaroon po ng stroke to our patient. Okay, now, if I may ask, sino ba yung mga doctors po natin, mga physicians in the house? Ayan, can I see some heart reactions po? Doctors, physicians? Meron po ba? Ayan, nurses. Can I see heart reaction for the nurses po? Ayun, madami-dami. Midwives. May mga midwives po ba tayo na present? Okay, madami-dami din. Kahapon po, kaka-release lang po ng result ng mga midwifery boards natin. And I'm really happy po kasi I'm one of the lecturers din, let's say for NLE, for the Nurse Licensure Examination, and for the Midwifery Board exam. And then for my students po, we got two top notchers, isang top 5 at saka isang top 6. And then the rest po, mas happy ako syempre sa sa passing rate po namin, which is 100%. Pero syempre bonus na yung top 5 at saka top 6 po. Nakaka-happy lang, nakaka-happy. Na ito yung mga na-predict na din namin na magta-top talaga sa board examination. Nakaka-proud. And so we have the BLS, now we have the ACLS, and then we have the PCAC. Now, let's continue na po. So to begin, we have the first word known as the emergency. Now guys, when we talk of emergency kasi, if that possesses a threat, if that possesses, number 1, a threat. Na sir, threat sa Sa life mo, of course, sa health mo, let's say sa status mo today, di ba? If that possesses a threat not to your life, not to your health, sa mismong status mo, sa mismong kalagayan mo today, then therefore that is an emergency. na including you, including the people around you, including your whole community, then therefore emergency yan. Now, based on book kasi guys, na ang pinaka-best talaga na definition ng tinatawag na emergency, if the person okay, thinks na that is an emergency. If you feel you are threatened, if you feel na at stake po yung life mo, then therefore emergency ang tawag doon. Kaya nga when someone okay, calls for help, you need to attend to that. Why? Kasi para sa kanya emergency yon. It's a matter of life and death. And feeling niya impending doom, 'di ba? Feeling niya may kamatayan okay mangyayari. Then you need to approach okay that patient. Okay po? So pwede mong sabihin, I'm a BLS provider, I'm a trained BLS provider, or I am a trained, let's say mamaya for the first aid, I'm a trained, okay, what? No first aider. Pwede po. No, or I'm trained in first aid. Then sige. No, kung gusto mong tumulong, walang problema. Now, as you can see, nasa pictures po natin, crowded po na ang place na to. Kasi ngayon, as part ng tinatawag na with COVID protocols, you need to limit kasi personnel. Ito kasi very crowded eh. 'Di ba? Ayan, pag may isa nag-positive, dire-diretso lahat quarantine. Kami sa Davao, kakalift lang po ng liquor ban po namin. For almost 2 years po kami, walang mga alcohol. Na pero syempre may mga nagpro-provide naman, may mga mabibilhan naman. Pero when you say you go out in public, no, wala talaga, walang mabibilhan po. Like for 2 years ha. Grabe no. Kaya nakaka-stress. Ang daming na-stress talaga sa liquor ban. Pero nung nilift na po ang liquor ban, syempre lahat ng tao ay nagbunyi. 'Di ba? Like sobrang happy lang lahat ng tao. Parang feeling mo parang nakalabas sa hawla talaga eh, na. Pero syempre dati kahit may liquor ban kami magulat ka na lang bakit may mga motor vehicular accidents. Tas bakit ano, the more kasi may liquor ban, the more kasi yung mga tao nagki-crave talaga ng mga beer, 'di ba? Ng mga tanduay, no? Whatever you call them, no? As in like, ayun po. Sa Bicol ba, meron bang mga liquor ban na naganap? Wala. Wala siguro na walang liquor ban. Kamusta ba ang COVID cases natin sa Bicol? Okay naman. Mr. Amandi, ayan, okay ba yung ano natin, ating mga COVID cases diyan, sir?
Okay naman po.
Ayan. So far, sir, so far so good naman. Pababa ng pababa or pataas ng pataas?
Baba po ng pababa.
Pababa ng pababa. Is Mr. Ariel Amandi a nurse or a doctor po?
Hindi po. Driver lang po ng ambulance.
Ng ambulance. That's nice. That's nice. Na, ayan. Saang hospital ba yan, sir?
PCMC po.
Sir?
PCMC. Philippine Children's po.
Philippine Children sa Manila, sir?
Dito lang po sa may Agam.
Sa
Quezon
QC ba?
City po. Quezon City.
Yeah, sa Quezon City. I'm all the way from Davao City pero kasi yung Philippine Children's na Hospital kasi syempre sa may QC yan sir, sa Along Irod ba yan?
Dito po sa may Agam po. Quezon Ave. Quezon
Ay,
Ave, corner Agham.
ayan, naalala ko yan. Sorry guys ha, yung pusa ko kasi. Ayan, naalala ko yung ano, Philippine Children. Meron din kasi akong alam na, Philippine Children is meron din sa,
Meron din po sa Irod.
sa Irod. Yeah, yung sa
Meron
Irod.
din
Yung
po.
nasunog ba yun, sir?
Iba pa po yun.
Iba din yung
Opo.
nasunog. Okay. Ayan, sige sir. So welcome to WePump. Akala ko kasi halos lahat ay from Legazpi, no? WePump kasi sir, na from Bicol kasi yan. So medyo majority po ng ano natin, ng mga trainees po natin na ay from Bicol. Yung iba naman from Davao. Ako all the way from Davao. Pero nung kasagsagan talaga at wala pang COVID, no, I do the face-to-face talaga. So from Manila, no, I go to Bicol na to have the training po. So with that, okay, picture guys. Pasensya na sa pusa ko. Masyado siyang chismosa. Yes, pusa po yan, hindi po yan daga. Baka yung iba kasi, Diyos ko, si sir, ba't parang may daga sa balikat niya? Pusa po yan. Madami po kasi akong pusa na walang mga balahibo. Na they are hairless. Ayan. Diyos ko. Ayan, we have where the choose now. So we need to choose, okay, syempre, na life, na over death dapat. Wait lang, gusto niya talaga makichismis. And we need to choose life, okay, over death po. So meaning to say, we value life dapat. Ayan na naman siya. Tinapon ko na, babalik pa rin. No? Parang ex ko lang. Tinapon ko na nga, pilit pa rin bumabalik. Wag na natin siyang pansinin guys ha. Focus na lang tayo sa slides po natin. Baka kasi matapon ko pa siya sa kabilang bahay. Ayan, so we have the life na of our patients. Na pag sinabi kasi natin okay life na of our patients po, syempre na we value life. Yun yung pinaka-importante. So every minute, 'di ba, counts, no? Every second okay matters po, especially in dealing, no? Kasi sa patient natin, kailan ba tayo nagsa-start ng tinatawag na high quality chest compression? Number one, na if the patient is pulseless or no pulse. Aside from that, na if the patient, 'di ba, is syempre walang breathing, 'di ba? If the patient has no breathing, aside from that, if the patient is, and can you give me one, ano lang, like 5 seconds lang wait lang. For ayan, pasensya na po, na ganun talaga, always na lang, like morning, kailangan niya talaga magpapansin na, like, hindi lamang siya sa balikat ko, but rather yung mga ano niya din, 'di ba? Yung mga, Diyos ko, ang sakit kaya, like, puno na ako ng ano, ng scratch ng ano, sa mga pusa. So again, now we have your, ayan, the life, 'di ba, over death po natin. So once again, when do we start ba high quality chest compression? That's the first question eh. Now, when are we going, okay, to start high quality chest compression? Sir, ayan, so we have your, ayan, when are we going, okay, to start? Number one, if the patient has no pulse. Next, number two, if the patient, okay, has a negative, okay, breathing. Or basically, the patient is unconscious. Tama po? Kasi syempre sisigawan mo yan. Hey, hey, are you okay? Hey, hey, are you all right? So if the patient has no response, then therefore the patient is unconscious. Now, aside from the negative pulse, the negative breathing, pwede rin kasing breathing but only gasping. Breathing, ayan, but only, ayan, gasping po. So pag sinabi po nating breathing, guys, na but only gasping, ito yung tinatawag na agonal gasp. Now, sir, when we say agonal gasp kasi, ito yung very obvious na sa mga patients na nagkaroon ng motor vehicular accident. Like yung mga nagmotor, na magulat ka na lang, ganito ang itsura ng patient na yan. Siyempre may dugo, naduguan siya, tapos biglang gaganon ng patient mo, gaganon lang, na very shallow ang respiration niya, pero the patient is gasping. Ang tawag doon, agonal gasp. Now, you need to start with your high quality chest compression there. So ulitin ko ha, so we have the negative pulse, negative breathing, breathing but only gasping, or simply your patient is unconscious. Now, we do have an updated kasi, especially in checking for the what, the patient's responsiveness. Dati 'di ba, dalawang hands 'yon. Hey, hey, are you okay? Hey, hey, are you all right? Alam niyo ba ang pinakabago is that before na approaching a patient, you need to wear your mask na. Why? Because ayan, your BLS kasi, or let's say your CPR na is an aerosol generating procedure. When we say aerosol generating procedure, you can actually acquire the said virus. So therefore, before approaching a patient, you need to wear your mask. And then, na before, let's say starting, let's say yung checking of the responsiveness, you need to what? No? Let's say put a mask dapat sa patient mo din. Okay po? So you need to wear your mask, first. To be followed by, you need to what? No, put a mask na sa nose or saka sa mouth, covering the nose and covering the mouth of your patient then. Why? Kasi habang nagko-compress ka, habang pinipress mo yung or kino-compress mo yung chest ng patient natin, na bumubuga syempre, 'di ba, ang mouth ng patient mo at pwedeng lumabas ang virus doon. Alam niyo ba ang virus pwede po siyang masuspend sa air for about 10 inches? Kasi nga this is an aerosol generating procedure. The moment na kino-compress mo ang patient is the moment na Ayan, no? Nasa air po ang virus natin. So, ma-acquire mo talaga siya. Malalanghap mo talaga siya. Kaya nga nung kasagsagan po na ng COVID, syempre takot na takot ang mga, syempre lahat na ng medical practitioners, 'di ba, nurses, doctors, na name it, na name them as in like takot lahat. Lalo na yung mag-intubate kay patient. 'Di ba? Kasi sila ang may direct talaga eh, 'di ba? Kung if they want to have the direct visualization, meaning to say, they are not commonly exposed. Kaya kung tatanungin niyo ako sino ba yung mga madaming namatay din, syempre mga anesthesiologist, kasi they want to intubate, 'di ba? The said patient na so yeah, na ang dami po talaga okay na ano na nasayang na mga lives na during kasagsagan ng pandemya talaga. Pero ngayon po no they're having the ano na eh, 'di ba, yung mga vaccinations ng 12 to 18 years old. Here in Davao po, nag-start na po sila ng 12 to 18 years old. 12, yeah. How about sa area nyo? Nag-start na po ba sa area nyo? Good morning po, Dr. Villanueva. Ayan. Sino pa yung mga doctors po natin dito? Ayan. Pa-PM na lang ha sa mga doctors po natin para ma-recognize po natin sila. Ayan. Sige po. So, ayun. No? So, when are we going to start high-quality chest compression? Again, if no pulse, negative breathing, breathing but only gasping, or simply unconscious po ang patient natin. Kasi ganito na ang technique po natin. Hello po, Dr. Ayan, good morning po, Dr. Kope. Ayan,
Good
Dr.
morning.
Jose.
Good
Good
morning.
morning, Doc. Good morning po. Welcome to We Pump, Doc. From what hospital po si Dr. Kope?
From Dr. Amando Copy Memorial Hospital.
Ayan, good morning po, Doc. Ayan. So, we have your... Doc, saan yung ano po, yung Kope Memorial Hospital?
Sa
Is it in
Tabaco
Bicol?
City.
Sa Tabaco. Yeah, sa Bicol nga. Ayan, nakakamiss lang talaga yung Bicol. Okay, so, ayun po, let's continue sa ating slides. Ayan, the perfect definition kasi of your basic life support, na it also needs, di ba, aside from immediate, okay, high quality chest compression, it also needs the immediate defibrillation. Because the compression without, okay, defibrillation, it will all be useless. But again, this is a case-to-case basis po. What if you have a shockable rhythm? So pag shockable rhythm, that requires, okay, immediate and early defibrillation. What if non-shockable? When we say, okay, non-shockable, no need for you to, okay, defibrillate, okay, your patient po. All right. Now, let's begin. To begin with your, okay, the basic life support, we need to give, okay, emphasis po on the what we call as your the BSI. BSI is your the body substance isolation, commonly known as your the PPEs or the PPE. Ayan, or the personal protective equipment, and then we have the PPD or the personal, okay, protective devices po natin, such as your gloves, no, your gowns, right? Ayan, your goggles, okay, your mask, no, yung mga N95, okay, mask po natin. All right? Ayan. So, sir, ayan, to continue, let's discuss, okay, the principles, okay, of your high quality chest compression. If you have your ball pens with you, then mas maganda yon. Kasi you need to take down notes in order for you to pass na your post-test, okay, later. Now, when we talk of principles, so we have the principles, okay, or basically the standards, now with your high, ayan, quality, okay, CPR. So starting today, guys, it's not CPR, but rather high quality CPR. Kasi we need to be ideal dapat eh. Na by following the principles, by following the standards, then you can actually push through a 100% po na survivability rate na ng patient po natin. So mas maganda ang prognosis ni patient. In case lang if ever kung tama ang pagka-perform ng tinatawag na high quality chest compression po natin. Now, with the principles of high quality chest compression, okay, ayan, so I have my own mnemonic here known as for the mnemonic pucha. Letter P, letter U, letter C, letter H, and then we have your letter A. Now, for the mnemonic pucha guys, the letter P stands for you need to push hard and fast. Push hard and push fast of a rate of at least 100 to 120 compressions, okay, per minute po. So again, you need to push harder and you need to push faster of at least, now we have the rate of 100 to 120. It's 120 po or 120 compressions per minute. So pag ikaw lang isa, pwede bang sumobra, sir? Yes. Kasi ngayon, hands-only CPR, no? Pinaparating po ng American Heart Association sa madlang tao, madlang people, na if ever po, no, kung ayaw mo talaga magbigay ng rescue breaths, don't worry. Kasi ayaw nating magka-COVID eh. 'Di ba? Hands-only CPR na without mouth-to-mouth resuscitation is actually accepted. Why? You focus more of the compression na than okay, giving breaths. Kasi pag nagbigay ka ng breaths, what if positive ang patient mo sa COVID? Then congratulations, naka-jackpot po. Na sayang naman yung life po natin. Na so careful ulit tayo. Now, we have the push hard and fast of at least 100 to 120 compressions per minute. Next, we have the unnecessary. Ayan, the unnecessary interruption. Ayan, unnecessary interruption must be, okay, minimize. Must be minimized, okay, to not more than, not, okay, more than, 10 seconds po. Now, how do we count for seconds? You follow me ha. Ganito dapat ang pag-count ng seconds. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, up to 10, 1,000. However, kasi ang sabi dito, to not more than 10 seconds. Ayan, meaning to say, in checking for pulse, in checking for breathing, pwede po kahit 5 seconds. Walang problema yan. Okay? So 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. The patient has no pulse and is not breathing. Let's start high quality chest compression. Kaya again, unnecessary interruptions must be minimized to not more than 10 seconds. Sir, what are forms of interruption? Ayan, ano ba yung mga interruptions po natin? No, unnecessary, okay, interruption. Like for example, unnecessary checking for pulse and breathing. 'Di ba merong iba sa atin excited na bumalik ang what? Ang pulso ng patient. Hindi nga pinatapos no ang 5 cycles, excited pa, 'di ba, na mag-check ng pulse. Yung tipong friend, no, feeling ko habang nagko-compress no, makikichismis, 'di ba? Feeling ko bumalik na 'to, no, check natin. Ay wala pa friend, sige continue tayo, na feeling ko eto na talaga, no, wala pa. Diyos ko, no, interruption na 'yon. Meaning mas pumangit tuloy no ang circulation po ni patient. Ayan, so again, unnecessary interruption must be minimized to not more than 10 seconds. Next po, we have letter C, compression deafness must be adequate. Compression, ayan, deafness, okay, must be okay, adequate po. When we talk of okay, compression deafness, okay, must be adequate, we have the 3 patients here. Now, who are they? Number 1, we have an adult patient. Next to adult patient, we have the child patient. Next to child patient, we have the infant patient po natin. Again, guys, now with your compression kasi, we are still okay, following na po ha, the CAB na since 2010 onwards po, binago na po nila. From ABC, ginawa na po nilang CAB. Again, I am referring to unconscious patient. Guys, if proven po na unconscious si patient, you proceed with CAB. Pero if conscious naman ang patient mo, ABC pa rin. Okay po? Ulitin ko ha. When we say unconscious, it's the CAB protocol. Pero pag conscious si patient, it's ABC. It's airway, breathing, and circulation. Pero pag conscious si patient, no need for you to look, listen, and feel. Now, you check the circulation agad, you start high-quality chest compression, to be followed by airway, to be followed by breathing. Pero in the advent kasi of, let's say, COVID, nakakatakot po ang airway and breathing. Na mas maganda ang what? No, hands-only CPR or the high-quality chest compression. Na you can delay, di ba, airway, you can delay, okay, breathing. Na kasi number 1, no, syempre we value life din mismo sa atin. Kasi if ikaw nagka-COVID, malamang no, damay-damay na din ang whole family po natin. Kaya extra careful. Ayan, ako naging vaccinator ako ng City Health. So, ang dami talaga, ang dami nagpa-vaccinate din, pero madami ding ayaw. kasi feeling nila mamamatay daw sila ng dahil sa vaccine. Even may mga kakilala akong mga doctors may mga kakilala akong mga nurses na ayaw talaga magpa-vaccine, no? Kaya sabi ko, sige, syempre you have your own beliefs naman din no? Sino ba naman ako para pilitin silang magpa-vaccine? What if, 'di ba? May mga nangyari sa kanila, no? So who's to blame? Baka ako pa. Kasi may mga kakilala din na talaga ako, guys. After vaccination, no? May mga loss of vision. Meron talaga akong kakilala, guys. Nawala talaga yung vision niya right after vaccination. Like, mga 1 day after vaccination. As in, bigla akong nataranta din at natakot na, ayan. Pero kasi, syempre, hindi naman kasi inamin din ng nag-complain na sila sa DOH, no? Pero, syempre, nag-sign kasi ng mga wave 4, di ba? Yung mga natin, mga consent, na. So, ayun po. So we have the adult patient. Now, how do we say na adult ang patient natin? Guys, if that is an 8 years old, okay, and above, considered as an adult patient based on American Heart Association. Now, right now, I'm following po the 2021 no, American Heart Association protocol. Every day, every week, every month, nag-update po no, ang American Heart Association. But again, we pump is under American Safety and Health Institute. So whatever, okay, let's say, no, yung mga certificates natin, yung mga cards na marireceive nyo, magagamit nyo po yan abroad. No, yun yung kagandahan. No? Kasi legit po ang aming training center. Okay? So aside from the 8 years old and above, that's for the adult patient. Pag child naman po, na 1 to 8 years old yan. And then, okay, for the infant po, we have the 1 month to 1 year. Considered as, okay, an infant patient. Okay? Ayan. So, meaning to say, pag adult patient po, sir, so we have the modifier. So, we have the word at least. Ayan, at least 2 inches, but not more than, okay, more than 2.4. Ayan, 2.4. Ayan, inches po. So we have at least 2 inches but not more than 2.4 inches. And that's for the adult patient. Next naman, we have the child. We have about, ayan, it should be about 2 inches. That's for the child. And for the infant naman po, it should be about 1.5, ayan, inches. Meaning to say, pag sinabi natin at least, pwede kang sumobra ng 2 inches. Pero dapat hindi ka susobra ng 2.4. Sir, how will I know? Diba yun yung question How will I know na may ruler ba tayo? Usually guys, on the first attempt talaga na magko-compress ka, parang feeling mo mababali ang ribs ng patient mo. Na feeling mo talaga yan. Meaning to say, lalo na yung mga first timer talaga na na-compress talaga si patient, first time nilang ma-CPR, then feeling mo ikaw yung reason kung bakit, wait lang, ako ba yung reason kung bakit siya namatay? Kasi the guilt will always be there, na especially after performing the high quality chest compression, that's normal. Even kahit pag first aider ka, na kasi para makarelate po mamaya sa ating topic, na at exactly, 'di ba, 1 o'clock po. 1 o'clock po yung first aid po natin later, ha. Ang first aid po natin is basic first aid, na the heart saver, basic first aid po natin. Meaning to say, ayan, no, we will be dealing with yung, 'di ba, warning signs of stroke, no, yung burns natin, yung bleeding you can't see and bleeding you can see, na yung diabetes mellitus, madi-discuss din po, lalo na pag may mga signs of what, na let's say, biglang nag-hypoglycemia ang patient natin. So madi-discuss din po yan later, na so iba po yung approach natin. It's the heart saver na first aid based on American Heart Association. Hindi lang siya okay, more of the bandaging, na hindi. Iba ang first aid natin mamaya, na kasi baka yung iba mag-expect ng mga triangular bandaging. No, na basic first aid tayo. Na let's say, what if may nag-seizure, na as a first aider, ano ba ang gagawin po natin? 'Di ba? Breathing difficulties such as with choking, no, ang patient natin, na what if may mga allergies na or very bad, okay, allergic reaction ang patient po natin. So yun po yung mga topics natin mamayang hapon. Na? And then meron din tayong special topics like for example, when are we going to administer an IM na with your EpiPen or epinephrine pen. So mamayang hapon yan. So ulitin ko lang, we have the adult, we have the child, and then we have the infant patient. Now if you're going to ask me, sir, saan ba yung exact location? Ngayon kasi, if that's an adult, if that's a child, it should be at the center of the chest. Now, sir, paano ba natin malalaman kung nasaan yung center ng chest? May mas mabilis po na way, guys, na ayan, hawakan mo lang yung kilikili or the axilla of the patient and then you slide and then dito na po. Again, axilla and then ayan, brush ka lang at the center, then that is the side. Mabilisan siya na technique. So brush sa axilla and then ayun na, no? Diyan ka agad ko-compress po. Syempre, pag adult guys, both hands. Sige nga, kayo nga i-perform niyo nga axilla and then brush sa center and then ilagay mo yung heel of the hand mo and then you start high quality chest compression. So that's the perfect site po natin. However kasi, if ever kung infant naman, at the center of the chest below the nipple line naman siya. Let's say below the nipple pero center pa rin ng chest and that's for the infant patient. Now, pag adult, both hands dapat ang gagamitin mo. So pwedeng ganito, you interlock digits or pwede rin ganito. Ilalapat natin na ang ating kamay. Ulitin ko ha, pwedeng ganito, you interlock digits or pwedeng ganito. May kita po later sa video na kung paano mag-perform ng high quality chest compression. Sir, bakit binago from here na bakit ginawang ganito? Kasi pag nag-interlock ka ng digits tapos may long fingernails ka, baka pwede kang mag-cause ng scratch no, ng trauma sa skin ng patient mo. Tas yung iba may mga nail art pa. Diyos ko, kamusta naman yung chest ng patient, sugat-sugat tuloy. So instead of doing this, pwede naman ganito. Ang importante naka-gloves ka para hindi masyado nagsa-slide na. Ayan. So we have the adult, the child, and then we have the infant patient. For child naman, one hand technique lang tayo. One hand. Tapos pag infant po, ayan, infant natin, ayan, 2 fingers na. Ayan, or yung iba, 'di ba? Yung iba din na whole nila. Ayan, let's say whole hand nila pero more of the fingers yung iba. Kasi yung iba feeling nila mababali na yung 2 fingers nila. Kaya yung iba pwede po yung ganito ha. Either ganito or ganito. Wag lang yung ganito. Iba 'yon na. So ayan, waitin ko lang. Ayan, pwedeng ganito. Ayan, no? Or pwedeng ganito po. Ulitin ko lang ha, that's for the infant patient. Although may mga videos naman tayo. Yun yung pinaka-importante na para ma-demonstrate talaga siya properly. Now, aside from compression deafness, must be adequate po. We have your, letter H and letter A. Your letter H po, there should be, now let's say has an obvious, ayan, chest, ayan, recoil. When we say obvious chest recoil, kunwari this is her chest. 'Di ba? Pwedeng baba, pwedeng taas. Ayan, meaning to say, hindi puro baba lang ng baba lang ng baba, na let the chest rise din. Okay? Tapos babalik sa normal na what? Na let's say na posisyon. Hindi kasi parang nanggigigil ka na hindi mo na pinapa-expand or binabalik yung chest na sa normal position niya, bawal yon. Meaning absent ang chest recoil. So meaning while you compress, you let the what? Na let's say the rib cage goes back to its normal position. Huwag manggigil ha. Kasi baka ex mo yan, tas gigil ka lang talaga, na wag po, na dapat ibalik po siya sa normal position. Now, aside from that, kasi ganito yan, what if wala po tayong chest recoil? That only means na baka may rib fracture ang patient mo. Delikado ba pag may rib fracture? Yes, an absent chest recoil that signifies a rib fracture. And for patients suffering from rib fracture, pwede niyang tusukin ang heart mo. Ay, not tusukin ng heart, but yes, pwede ang heart na, pero focus muna tayo sa lungs po ni patient. Kasi pag naano guys, na-puncture po yung lungs ni patient, that can cause tension pneumothorax. Na kaya pala sir, pag check natin na tinatawag na breathing, kaya pala absent ang breathing ni patient, absent breath sounds. At nung pag chest x-ray, no, may mga signs of tracheal deviation ang patient natin. Tapos if ever kung ang patient mo biglang na okay, biglang nabuhay, magko-complain ang patient mo ng what? Na severe chest pain, na tapos parang may difficulty of breathing bigla ang patient natin. Mga warning signs na ayun, nagkaroon ng tension pneumothorax ang patient natin. Now, last but not the least, you need to avoid avoid excessive ventilation. Now, sir, I want you to focus on the word excessive ventilation. Guys, sabay-sabay nga po tayo. Everybody say excessive ventilation.
Excessive ventilation.
Excessive ventilation.
Ayan, thank you so much. Ayan, when we talk about excessive ventilation, it causes two things. Number one, it causes an increase thoracic pressure. Intrathoracic pressure. Aside from increased intrathoracic pressure, ayan, it causes also an increase intra-abdominal pressure po. Now, what happens, sir, if ever kung may increase intrathoracic pressure po tayo? Number one, there will be a decrease venous return. Aside from having a decreased venous return, expect po for a decreased cardiac output. Meaning, poor prognosis to your patient, because that only signifies na you're having a poor perfusion, na poor po ang circulation po natin. Now, aside from that, kasi iipitin kasi na tinatawag na lungs mo ang heart mo. Kaya nga intrathoracic. 'Di ba? Thorax kasi, andyan yung lungs po natin. So pag let's say, grabe yung ventilation mo, yung iba kasi pag nakahawak po ng BVM or ng bag, valve and mask, guys, do not call that one as ambu bag ha. Maling-mali po na tawagin siya ng ambu bag. Why? Ambu bag kasi is a brand name. So instead of calling that as your ambu bag, why not call that one properly? Address that one properly as the BVM, your bag, your valve, and your mask. So we have the bag, the valve, and the mask. That's the BVM. Diyos ko, pero may mga iba pa rin, no? Get an ambu bag. Diyos ko, hindi po ambu bag. Kasi hindi rin po ambu bag ang brand. Made in China po siya. Sa malamang, na? And again, guys, the BVM should be disposable, ha? Pero yung iba, Diyos ko, ilang months nang ginagamit. Grabe siya.
Reusable.
Yeah, biglang, yes, ma'am. No? Biglang naging reusable na dapat disposable, lalo na yung made in China. Na, ayan, so the ambu bag is commonly used na sa States po. Okay? So B, V, and M. No? Pero kasi meron ngayon na pocket po, na pocket size. I mean like, na siya, na-fold talaga siya. Tapos pwede mong ilagay sa pocket. Tapos pwede mo siyang i-expand. No? Ang galing talaga nun. Although nahanap ko siya sa Lazada. Kasi may mga friends ako na, let's say, mga EMTs na ginamit talaga nila yun. Na sabi ko, ang galing naman. Tapos nung nalaman ko magkano, nasa mga 8,000 na or 9,000. Pero ang galing lang, na kaya hinintay ko na lang si China na gumawa nun. Pero sabi ng friend ko, gumawa na daw ang China. Alam niyo magkano? Nasa mga 3,500 or nasa mga 4,000. See? Totoo nga ang sabi nila, God created the world and the rest is from China. Kaya if ever kung may mga gusto man kayong mga products, hintayin niyo na lang si China ang gumawa. Kasi for sure, mura na siya. Pero pag si States po ang gagawa, grabe, ang mahal lang. Pero syempre, tangkilikin pa rin yung mga magaganda yung mga quality. So we have the increased intra-abdominal pressure, guys. With your increased intra-abdominal pressure kasi that leads to backflow. Diba? The backflow, of GI contents. If there will be backflow of GI contents, then the patient is at risk to develop the aspiration pneumonia. Aspiration. Ayan, pneumonia. Now, sabay-sabay nga po tayo. Everybody say aspiration pneumonia.
Aspiration.
Pneumonia.
Ayan, thank you so much. Thank you so much. When I attended, guys, na seminar sa UST, along with my co-instructors, ang sabi kasi ng pinaka-head namin doon, na for aspiration pneumonia, guys, this is actually a form of chemical pneumonia. If this is a form of chemical pneumonia po, then 75% na pwedeng mamatay talaga sa patient. Only 25% pwedeng mabuhay ang patient po natin. Meaning to say, even doctors are having a hard time in managing aspiration pneumonia. Diba? This is a form of chemical pneumonia leading to pneumonitis kaya delikado. And are you aware that your aspiration pneumonia is really common to probable extremes? When we say probable extremes, this is really common for too young and too old patients. Pag sinabi kong too young, pediatric patients yon. Pag sinabi ko namang too old patients, syempre, mga geriatric patients naman. Kasi going back, 'di ba, sa developmental milestone, na for infants kasi the cause of death, the cause of mortality ng infant will be aspiration. Tama po? Suffocation, very common 'yan sa infant. Now, pag hindi ka namatay ng infant ng what? Ng let's say ng suffocation at saka ng let's say, 'di ba, yung aspiration natin, don't worry. Kasi nasa waiting list ka po pag ikaw na po ay tatanda meaning hinihintay ka ni suffocation at saka ni aspiration. Guys, i-emphasize ko lang yung yung wonders ng Panginoon po natin. 'Di ba nung kabataan mo, let's say nung infant ka, ang favorite mo stroller, 'di ba? Napansin mo ba? Syempre may gulong. Tapos pag tatanda ka na, syempre may gulong din. At ito yung mga wheelchair, 'di ba? Nung infant ka, gusto mong mag-crawl. Pero pag elderly, syempre hindi ka na makakalakad kaya nagko-crawl ka din. So babalik talaga tayo doon. Naalala mo ba dati, pag infant ka, ang makakaya mo lang is yung Marie na biscuit. 'Di ba yung Marie na biscuit kasi yan lang yung kaya mo. Tapos pag tatanda ka na, syempre wala ka ng ngipin, so Marie lang din ang kaya mong kainin. Yun yung mga wonders na like amazing lang. So babalik talaga tayo. Ayan, kaya nga we need to stay humble dapat kasi doon lang din naman tayo pupunta, 'di ba? Babalik tayo sa pagka-infant po natin pwera na lang kung ikaw talaga ay si Benjamin Button. So baliktad yung growth and development mo. Ayan. Kaya ako I honestly yeah, no, and I always po emphasize this to my students kasi right now I'm a full-time clinical instructor sa isang nursing school here in Davao City. Kasi syempre mas pinili ko muna kaysa sa mag-hospital po I always emphasize this to my students po na knowledge has to be improved, 'di ba? It has to be challenged and increased constantly, okay, or it vanishes. Tama po ba? Kaya ako in-emphasize ko din na kahit nasa academe man ako, every now and then kailangan ko ding mag-attend ng mga seminars. Kasi for me, once you stop learning, you stop growing. 'Di ba? Pangit din pag stagnant po, lalo na pag nasa comfort zones na po tayo. Yung comfort zones kasi sa mga comfort zones kasi natin, some of us will stay sa comfort zones. And alam niyo ba, pag andun lang kayo sa mga comfort zones nyo, it will make your life predictable. It will make your life boring din. Kasi nasa comfort zone ka na So you need to what? You need to explore, 'di ba? Explore the world, explore your profession dapat hindi lamang dapat stagnant kasi yung stagnant na life, boring ang life po if ever pag ganon. Pero wala namang sinabing party-party ha. Diyos ko Lord, party now, cremation later. 'Di ba? Ayan, grabe naman. Pero napansin ko kinompare ko ang life in Davao at saka life sa Manila at saka sa Cebu. Sa Davao walang mga disco. Kaya sa Cebu, may mga disco na pong nagaganap. Kaya sabi ko, immortal ata itong mga taga Cebu Tapos sa Manila din, bumalik na po yung mga bars na alam ko. I'm a party din kasi, party goer din kasi ako. Kaya bored na bored ako dito sa Davao, guys. Gusto ko mang bumalik sa Manila. Kaso kasi parang nasabi ko, this is not the best time. Na I stayed in Manila for almost 10 years kasi bumalik lang talaga ako sa Davao at nag-work po as a full-time clinical instructor last year na yung kasagsagan din talaga ng COVID na kung saan feeling ko parang wait lang, but parang wala na munang life. So balik muna ako sa Davao. Originally, I'm from Davao City. Pero I love the life in Manila na nagstay din ako sa Bicol for almost 1 year. Guys, nung pumutok po let's say yung pandemya, nasa Bicol po ako noon. Siyempre andyan kasi yung ex ko eh. 1 year din kasi kami nagsama. Pero naka-move on na ako guys na ayan, he's a doctor from from Legazpi. Pero naka-move on na syempre, na. Kaya pero kasi syempre, kaya close na close ako sa mga taga Bicol kasi ang dami kong friends talaga diyan. Aside sa pabalik-balik ako diyan, kabisado ko na yung SM nyo, 'di ba? Maliit lang SMY kasi pagpasok mo sa entrance, tanaw mo na ang exit. Kaya sabi ko, okay, pero ang importante at least na may SM. Pero ang pinakagusto ko lang dyan talaga guys, yung mga eat all you can nyo, tapos yung yung Starbucks nyo na. Although dapat may Starbucks kayo na na tanaw talaga si Mayon. Yun yung pinakagusto natin. Pero I miss the food, no? Sa Bicol, like sobra kong na-miss. And may na-adapt talaga ako guys, na lalo na the way I eat food po kasi kailangan madami ng sili. Diyos ko, yun yung na-learn ko sa Bicol. Na hindi na ako kumakain ngayon pag walang sili, no? Like hindi lamang isa but rather 8 na sili. Ewan ko ba? Yun yung na-learn ko din talaga diyan. And of course, ang magmahal na nang walang kapalit. Charm. Ayan. So we have here the avoid excessive ventilation. Kaya nga if ever kung babalik ako ng Bicol, dapat na ibang doctor na naman. Sige po. So we have your letter A, 'di ba? The pucha, sorry. Ayan, saan na ba tayo? Ayan, letter H, letter A. Yeah, sorry. Ayan, tapos na pala tayo sa letter A. So ganito guys. I'll give a scenario ha. I'll give a scenario. What if po, upon checking, the patient has pulse rate. Meron naman siyang pulso, sir, pero the patient is not breathing. So therefore, as a medical provider, as a trained BLS provider, you need to what? No? Let's say perform rescue breathing. Ang tawag doon. Rescue, breathing. Guys, when we talk of rescue breathing kasi, let's say adult patient. Next, we have your patient was hooked on an advanced airway. My next topic na in a while will be the airway management. Next, aside from the adult na advanced airway, we have the child patient. An infant, the same lang kasi ang manner na in performing the rescue breathing sa infant and child. Now, for the adult po, 1 bag, meaning 1 rescue breath. Isang, isang, let's say, pag bag mo, i-press mo yung bag po natin, full breaths. 1 rescue breath every, 5 to 6, seconds po. That's for the adult patient. Now, patients, for advanced airway naman, we have the 1 rescue breath, every 6 to 8 seconds. And then pag child and infant, yes, you heard me right, na? The same po yan. It's 1 rescue breath every 3 to 5 seconds po. Na-miss ko nga talaga si Mayon. Like sobrang na-miss ko siya. Like every morning, yung kagandahan ni Mayon. Like guys, so far ngayon, Mr. Guzman. Hello, Mr. Guzman. From Bicol ka din, sir? Naka-mute ka, sir.
Baras Rizal, sir.
Taga saan, sir? Taga?
Baras Rizal.
Iriga?
Baras Rizal, Antipolo Rizal.
Sa Antipolo Rizal. All the way from Antipolo Rizal. Kamusta naman ang mga kakanin natin dyan, sir? Yun yung pinakagusto ko dyan pag nasa Ayan, Antipolo Rizal. And meron din akong auntie dyan, na yung auntie ko dyan sa Antipolo Rizal. Yan, naalala ko din yan, na-connect ko tuloy. Kasi from Legazpi that time, no, nung naghiwalay kami ng ex ko, I traveled na from Legazpi going to Manila and from Manila going to Antipolo Rizal to fetch my grandma. Na, kaya nga ano, what a coincidence, no? From Bicol, tas si Sir from Antipolo Rizal. Tama ba, Sir Antipolo Rizal? Basta sa Rizal. Yeah. Na-miss ko ang simbahan niyo, na-miss ko din ang kakanin. Pero syempre yung auntie ko din na nandyan, na sobrang bait nun. So ayun po, we have her the adult patient. It's 1 rescue breath every 5 to 6 seconds. We have her with advanced airway, na 1 rescue breath every 6 to 8 seconds. And lastly, we have her the child. Again, we have her the infant, and that's her the 1 rescue breath, no, every 3 to 5 seconds po. For a while lang ha, i-mute ko lang. Ayan, kasi may mga naririnig akong feedback na nagfi-feedback kasi. So pa-mute na lang po guys ha, if ever baka na-unmute nyo lang. Okay, so again, ito po 'yon, no, mga rescue breathing po natin. Ayan, sige. So aside from that, na let's have the video presentation na po of your airway management. Full volume po tayo ha. Okay, full volume po tayo.
Managing a patient's airway is a fundamental life-saving skill, one that both basic and advanced healthcare providers should be able to perform well. Airway management is one of the key interventions for BLS and ACLS. It is critical before, during, and after cardiac arrest. The optimal method of managing the airway will vary based on provider experience, training, scope of practice, EMS or healthcare system protocols, and the patient's condition. We'll review effective bag mask ventilation using both single and two-person techniques. We'll review the steps of responding to a respiratory arrest and the recommended use of waveform capnography to monitor and confirm the placement of advanced airways. Before we get into the specific airway skills, let's review the recommended ventilation rate for cardiac arrest patients. For patients in cardiac arrest, provide 2 ventilations with the bag mask device after every 30 chest compressions. After inserting an advanced airway, healthcare providers should continue ventilations by providing asynchronous ventilations once every 6 seconds. If a patient is in respiratory arrest and has a pulse but is not breathing, ventilate once every 5 to 6 seconds. After 2 minutes, reassess the pulse. When giving ventilations, healthcare providers should avoid excessive ventilation or administering tidal volumes that are too large. Not only can this cause gastric insufflation and aspiration of gastric contents, but excessive ventilation also increases intrathoracic pressure and decreases venous return to the heart, so it lowers cardiac output and the patient's chance of survival. Tidal volume should be approximately 500 to 600 milliliters, enough to see the chest rise. This is about half a squeeze of an adult ventilation bag. Let's begin with basic airway skills. The first 2 steps in any airway management response involve opening and clearing the airway. First, open the airway by using a head tilt chin lift maneuver. Place one hand on the forehead and one on the chin, and push with your palm on the forehead to tilt the head back while lifting the jaw to bring the chin forward. This simple maneuver lifts the tongue from the back of the throat, opening the airway. This procedure is typically performed on patients without any evidence of head or neck trauma. In patients with suspected cervical trauma, a jaw thrust without head extension is used. In a jaw thrust maneuver, place your fingers just under the angles of the lower jaw and lift with both hands, displacing the jaw forward. If the jaw thrust does not open the airway, use the head tilt chin lift, because maintaining a patent airway is a priority. The second step is to clear the airway. Providers should suction the airway immediately if there are copious secretions, blood, vomit, or a foreign body. Use large-bore, non-kinking suction tubing and a large suction catheter with a rigid pharyngeal tip. High suction pressure may be required. Once the airway is open and clear, you may consider use of an airway adjunct to maintain a patent airway. There are two types of airway adjuncts: the oropharyngeal airway, or OPA, and the nasopharyngeal airway, or NPA. OPAs are commonly used for patients who are unconscious and have no gag reflex. NPAs may be used for conscious, semi-conscious, or unconscious patients with or without a gag reflex. The OPA is a J-shaped, single-use, disposable plastic device. OPAs are available in various sizes, with the most common adult size ranging from 8 to 10. Here's how to choose the correct size OPA. Place the OPA against the patient's cheek. When the flange of the OPA is at the corner of the mouth, the tip is at the angle of the mandible. A properly sized and inserted OPA results in proper alignment with the glottic opening. To use the adjunct, insert the OPA so that it curves upward, with the tip pointing to the hard palate. As the OPA passes through the oral cavity and approaches the posterior wall of the pharynx, rotate it 180 degrees into the proper position. Alternatively, the airway can be inserted sideways and rotated 90 degrees into place. Once properly inserted, the OPA holds the tongue away from the posterior wall of the pharynx. It also provides access to the throat for suctioning and prevents the patient from biting an advanced airway. OPAs that are too large may obstruct the larynx or cause trauma to the laryngeal structures. OPAs that are too small or inserted improperly may push the base of the tongue posteriorly and obstruct the airway. Healthcare providers should insert the OPA carefully to avoid soft tissue trauma to the lips and tongue. Remember to use OPAs only in unresponsive patients with no cough or gag reflex. If the patient has a cough or gag reflex, the OPA may stimulate vomiting and laryngospasm. Only healthcare providers trained in the proper use of an OPA should attempt its insertion. The NPA is a soft, curved, hollow tube that can be inserted through the nostril to facilitate ventilation and suctioning. Unlike oral airways, NPAs may be used in patients who are conscious, semi-conscious, or unconscious, with or without a gag reflex. In choosing the correct size, make sure that the length of the NPA is the same as the distance from the tip of the patient's nose to the earlobe. Before inserting an NPA, lubricate the airway with a water-soluble lubricant or anesthetic jelly. Insert the NPA through the nostril in a posterior direction perpendicular to the plane of the face. Using moderate pressure and a gentle spiral motion, push the device into the nostril. When inserted correctly, the NPA should reach beyond the nasal cavity to the pharynx, providing a clear path for ventilation and suctioning. If you encounter resistance during insertion, gently withdraw the NPA a centimeter or so, slightly rotate it, and gently try to insert it again. If you continue to encounter resistance, withdraw the airway completely. You may try inserting it in the other nostril. Use caution when inserting the NPA in patients with severe head or facial trauma because of the risk of misplacement into the cranial cavity. With a known basal skull fracture, an oral airway is preferred. Take care to insert the NPA gently to avoid complications such as tissue injury or bleeding. An NPA may also cause laryngospasm and vomiting. An improperly sized NPA may enter the esophagus and cause gastric inflation with active ventilation. After inserting either an OPA or NPA, it's important to check whether the patient is getting adequate ventilation by listening for breath sounds. During resuscitation, patient ventilation is commonly provided with a bag mask device. First, let's look at the device itself. A bag mask device is composed of a self-inflating or flow-inflating bag that is attached to a clear, cone-shaped face mask that covers the patient's nose and mouth. The edge of the mask has an inflatable cushion, enabling a tight seal around the nose and mouth when the provider applies pressure to the mask and lifts the jaw. Now, let's see how to properly use a bag mask device. First, position yourself directly at the top of the patient's head. Place the mask over the patient's face. Before providing bag mask ventilation, the provider must first perform a head tilt and then press the mask against the face while lifting the jaw into the mask. This is best achieved by forming a C with the index finger and thumb of one hand on the top side of the mask at the bridge of the nose. This motion firmly secures the mask to the face. At the same time, the 3 remaining fingers form an E and should be used to lift the jaw, opening the airway. While maintaining a tight seal between the patient's face and the mask and maintaining a jaw lift to open the airway, the provider should squeeze the bag, taking about 1 second to deliver 1 breath. For a patient who has spontaneous circulation but needs ventilatory support, the provider should give rescue breaths at a rate of 1 breath every 5 to 6 seconds. An effective breath results in visible chest rise. The most effective way to deliver bag mask ventilation is to use the 2-person technique. The first provider focuses on keeping the airway open and securing the mask, while the second provider delivers ventilation with the bag. The first provider uses both hands to seal the mask to the patient's face and lift the jaw. The thumbs and index fingers of both hands each form a C, ensuring a good mask seal against the face, with the 3 remaining fingers of each hand forming the E, lifting both sides of the jaw into the mask. The second provider squeezes the bag enough to cause visible chest rise. When using a bag mask device, whether there are 2 providers delivering breaths or just 1, be careful not to press too hard on the mask, which could push the patient's jaw down and obstruct the airway. There are several possible indications for insertion of an advanced airway. These include difficulty providing effective bag mask ventilation, patients with actual or potential airway compromise, particularly with long transport times, or the need to isolate the airway. With careful attention, trained healthcare providers can use an advanced airway to safely provide ventilation that is as effective as bag mask ventilation. Advanced airway devices offer many advantages. These include isolating the airway and reducing the risk of aspiration and gastric insufflation. After inserting an advanced airway during CPR, providers should deliver 1 breath every 6 seconds without interrupting chest compressions. Unfortunately, insertion of some advanced airway devices, like an endotracheal tube, may require interruptions in chest compressions that last longer than 10 seconds. These interruptions may reduce survival rates for VF arrest patients. It should also be noted that there is no evidence that advanced airway measures improve cardiac arrest survival rates in either in-hospital or out-of-hospital settings, so providers must carefully consider all these factors before performing the intervention. There are other advanced airway devices that healthcare providers can often insert without interrupting chest compressions. These include supraglottic devices such as the laryngeal mask airway, the laryngeal tube, and the esophageal tracheal tube. Healthcare providers who use advanced airways within their scope of practice must maintain their skills by using them frequently. The American Heart Association recommends that you become familiar with a variety of devices, but master one primary method of advanced airway control. If you're unable to establish an advanced airway, continue ventilation with a bag mask device. The laryngeal mask airway is a supraglottic airway device that healthcare providers can insert without visualizing the glottis. In addition, it can be inserted during CPR while chest compressions continue uninterrupted. This makes training easier and insertion more reliable. The laryngeal mask airway is a tube with a distal inflatable cuff shaped like a mask that is placed in the patient's hypopharynx. Place the laryngeal mask airway in the open mouth with the opening of the mask facing the patient's tongue. Advance the device to the back of the tongue. In a smooth motion, use your index finger to press the laryngeal mask airway against the roof of the mouth and guide it downward. Continue advancing the device until you feel resistance, which indicates the distal end of the tube has reached the hypopharynx. Withdraw your finger and inflate the mask. Once inflated, the laryngeal mask airway will center itself in the mouth. If placed correctly, oxygen will flow through the lumen of the device and into the trachea. The laryngeal tube is a supraglottic device that can be inserted in an unconscious patient. Providers can insert the device during CPR while chest compressions continue. The device can also be inserted without visualizing the glottis. The laryngeal tube is a single lumen device with two cuffs inflated through a single inflation port. The distal tip of the tube is angled and beveled to easily slide into a collapsed upper esophagus. The design also reduces the likelihood of tracheal insertion. When the tube enters the esophagus, you should feel resistance. Inflate the cuffs with a single syringe. The esophageal tracheal tube is a supraglottic device that providers can insert during CPR without interrupting chest compressions and without visualizing the glottis. The esophageal tracheal tube is made up of two lumens permanently joined. Each tube can be used to provide oxygenation and ventilation, depending on how it's inserted. The longer blue tube, marked with a number 1, provides ventilation through 8 small side openings of the lumen in the pharyngeal section. The shorter clear tube, marked with a number 2, provides ventilation directly through the lumen to the end of the tube. Once the tube is in place, use the large blue syringe to inflate the pharyngeal cuff through the port labeled number 1. Then use the smaller syringe to inflate the distal cuff through port number 2. The distal tip of the device will rest in either the esophagus or the trachea. If the tube rests in the esophagus, which happens most frequently, the cuff blocks airflow in and out of the esophagus, and ventilation occurs via lumen number 1 and through the small side openings into the trachea. If the tip of the tube comes to rest in the trachea, however, the rescuer can use lumen number 2 to deliver ventilation directly into the trachea. Caution: it's critical to confirm the proper placement of the esophageal tracheal tube, because if ventilation is delivered to the incorrect lumen, it will prevent adequate oxygenation and ventilation and result in severe hypoxia. Incorrect delivery of ventilation to the esophagus will also produce gastric insufflation that will complicate ventilation. The endotracheal tube was once considered the optimal method of managing the airway during cardiac arrest. However, intubation attempts by unskilled providers or by providers who use it infrequently can produce serious complications, such as trauma to the oropharynx, incorrect placement in the esophagus or right main bronchus, and prolonged interruptions in compressions and ventilations. Despite the risks of intubation in inexperienced hands, there are many benefits to endotracheal intubation. These include keeping the airway patent, allowing suction of the airway, speeding the delivery of high concentrations of oxygen, providing an alternative route for some drugs when intravenous or intraosseous routes are not available, and, when using a cuff, potentially protecting the airway from aspiration. The endotracheal tube is a single clear lumen with a single cuff. To insert the endotracheal tube, place the patient's head in the sniffing or neutral position. Insert the laryngoscope blade into the patient's mouth. Lift the laryngoscope vertically up and away to expose the vocal cords and glottic opening. Insert the endotracheal tube directly between the vocal cords and into the trachea until the cuff passes the cords. Once the endotracheal tube is in place, inflate the cuff and attach a waveform capnography monitor to confirm proper tube placement. When choosing to use an advanced airway, you need to be confident that it is inserted correctly and that you're providing effective ventilation while avoiding excessive ventilation. Watching for chest rise, checking for bilateral breath sounds, and listening for gurgling sounds coming from the stomach can help you confirm the placement of an advanced airway. Beyond these clinical assessments, there are several devices that can help you determine whether you have inserted the airway correctly. Waveform capnography monitors how much carbon dioxide is exhaled by the patient. The American Heart Association recommends using waveform capnography to confirm and monitor the correct placement of an endotracheal tube. Scientific studies have not yet validated waveform capnography as a method of confirming proper placement of supraglottic airways. However, effective ventilation through these airway devices should produce a capnography waveform. A normal end-tidal CO2 waveform looks like this. The measurement of the amount of end-tidal, or exhaled, carbon dioxide can be shown as a waveform, where the carbon dioxide level goes up when we exhale and falls back to zero when we inhale. Even when healthcare providers are properly ventilating the patient, chest compressions will produce a low end-tidal CO2 reading because even the best CPR produces cardiac output and pulmonary blood flow that's about 25 to 30% of normal. In contrast, ROSC can cause an abrupt increase in end-tidal CO2. Waveform capnography devices that display both a waveform and a number will give you the most comprehensive information. Connect the monitor between the advanced airway and the bag or ventilator. Waveform capnography provides a graphic demonstration of the carbon dioxide exhaled with every breath. Humans with healthy lungs have a characteristic waveform that is divided into 4 phases that occur during inspiration and expiration. When the patient first begins to inhale, the curve falls sharply to 0. As the patient continues to inhale, the reading on the monitor should remain at 0. When the patient first exhales, the initial portion of the breath consists of the air in the dead space from the breathing tube and the trachea. As air from the alveoli begins to empty into the circuit, carbon dioxide levels start to increase. This is shown as an upward deflection at the beginning of the exhaled carbon dioxide curve. As exhalation continues, carbon dioxide continues to pour out of the lungs until the next breath is initiated. The highest value in the curve is called the end-tidal CO2. For patients with normal perfusion, an end-tidal CO2 reading of less than 35 millimeters of mercury indicates hyperventilation. A reading of more than 45 suggests hypoventilation. In the patient with adequate circulation, the key uses for waveform capnography include the placement and monitoring of an advanced airway and the management of ventilation support. In cardiac arrest patients, waveform capnography reflects the effectiveness of chest compressions during CPR, and a sharp increase in end-tidal CO2 signals the return of spontaneous circulation. The higher the end-tidal CO2 pressure, the higher the cardiac output is during resuscitation. An end-tidal CO2 of less than 10 millimeters of mercury suggests that the cardiac output is insufficient to achieve ROSC. If the CO2 readings are low during resuscitation, the team should optimize CPR quality by minimizing interruption in compressions, delivering compressions at a depth of at least 2 inches and at a rate of at least 100 but no more than 120 compressions per minute, allowing complete chest recoil and avoiding excessive ventilation. Sudden changes in the waveform should trigger immediate reassessment of the patient. When the waveform jumps up during resuscitation, this may indicate ROSC. A sudden drop in waveform of 20 points or more could indicate a sudden, severe decrease in cardiac output that might be caused by a pulmonary embolus, acute blood loss, or a life-threatening arrhythmia. A decrease to 0 indicates no gas exchange or no carbon dioxide delivery, such as occurs with a displaced endotracheal tube, or the sudden stopping of blood flow, such as occurs with ventricular fibrillation. A rising baseline in the end-tidal CO2 waveform suggests that carbon dioxide is re-entering the side stream sampler during the inspiratory phase of ventilation. This reading might indicate that the patient is rebreathing carbon dioxide. This waveform has a prolonged phase 4, or inhalation, section. This suggests that there's air entering the trachea beyond the entryway that's being monitored. This happens if the cuff on the tube is deflated, or if the tube is too small for the patient. In both arrest patients and post-cardiac arrest patients, ventilation and perfusion must be optimized to prevent lung injury, cerebral ischemia, and cardiogenic shock. The use of waveform capnography can dramatically enhance your ability to manage cardiopulmonary patients. Another type of CO2 detector, the colorimetric end-tidal CO2 detector, simply changes color when it detects CO2. One additional confirmation device is the esophageal detector device, or EDD. The EDD is a bulb that providers compress and attach to the endotracheal tube. If the tube is in the esophagus, the bulb will not re-expand and fill with expired CO2. An alternative model is a large aspiration syringe attached to the tube. If the endotracheal tube is properly placed, providers will have no difficulty retracting the plunger. Esophageal placement will prevent plunger movement. Airway skills are fundamental to successful ACLS. Proper training, frequent practice and use, and logging both successes and complications can help build your skills and lead to more comprehensive, successful patient care.
Okay, at this point in time, let's have the the 20-minute break. Okay, break po muna tayo, guys. Para ma-relax po yung mga mata po natin, you eat your breakfast. We will resume at exactly 9:45 po. Sige. While having the break po may mga ipi-play lang ako ng mga videos regarding COVID na kasi for sure yung iba ayaw din mag-break ng iba. May ipi-play lang ako. So 9:45, I'll see you po. We'll resume.
This is SARS-CoV-2. It belongs to the family of coronaviruses named for the crown-like spikes on their surfaces. SARS-CoV-2 can cause COVID-19, a contagious viral infection that attacks primarily your throat and lungs. What actually happens in your body when you contract the coronavirus? What exactly causes your body to develop pneumonia? And how would a vaccine work? The coronavirus must infect living cells in order to reproduce. Let's have a closer look. Inside the virus, genetic material contains the information to make more copies of itself. A protein shell provides a hard protective enclosure for the genetic material as the virus travels between the people it infects. An outer envelope allows the virus to infect cells by merging with the cell's outer membrane. Projecting from the envelope are spikes of protein molecules. Both a typical influenza virus and the new coronavirus use their spikes like a key to get inside a cell in your body, where it takes over the cell's internal machinery, repurposing it to build the components of new viruses. When an infected person talks, coughs, or sneezes, droplets carrying the virus may land in your mouth or nose and then move into your lungs. Once inside your body, the virus comes in contact with cells in your throat, nose, or lungs. One spike on the virus inserts into a receptor molecule on your healthy cell membrane like a key in a lock. This action allows the virus to get inside your cell. A typical flu virus would travel inside a sac made from your cell membrane to your cell's nucleus that houses all its genetic material. The coronavirus, on the other hand, doesn't need to enter the host cell nucleus. It can directly access parts of the host cell called ribosomes. Ribosomes use genetic information from the virus to make viral proteins, such as the spikes on the virus's surface. A packaging structure in your cell then carries the spikes in vesicles which merge with your cell's outer layer, the cell membrane. All the parts needed to create a new virus gather just beneath your cell's membrane. Then, a new virus begins to bud off from the cell's membrane. Now, with the virus spreading in your body, how can you develop pneumonia symptoms? For this, we'll have to look into your lungs. Each lung has separate sections called lobes. Normally, as you breathe, air moves freely through your trachea or windpipe, then through large tubes called bronchi, through smaller tubes called bronchioles, and finally into tiny sacs called alveoli. Your airways and alveoli are flexible and springy. When you breathe in, each air sac inflates like a small balloon. And when you exhale, the sacs deflate. Small blood vessels called capillaries surround your alveoli. Oxygen from the air you breathe passes into your capillaries, and then carbon dioxide from your body passes out of your capillaries into your alveoli so that your lungs can get rid of it when you exhale. Your airways catch most germs in the mucus that lines your trachea, bronchi, and bronchioles. In a healthy body, hair-like cilia lining the tubes constantly push the mucus and germs out of your airways, where you might expel them by coughing. Normally, cells of your immune system attack viruses and germs that make it past your mucus and cilia and enter your alveoli. However, if your immune system is weakened, like in the case of a coronavirus infection, the virus can overwhelm your immune cells, and your bronchioles and alveoli become inflamed as your immune system attacks the multiplying viruses. The inflammation can cause your alveoli to fill with fluid, making it difficult for your body to get the oxygen it needs. You could develop lobar pneumonia, where one lobe of your lungs is affected, or you could have bronchopneumonia that affects many areas of both lungs. Pneumonia may cause difficulty breathing, chest pain, coughing, fever and chills, confusion, headache, muscle pain, and fatigue. It can also lead to more serious complications. Respiratory failure occurs when your breathing becomes so difficult that you need a machine called a ventilator to help you breathe. These are the machines that save lives and that medical device companies currently ramp up production for. Whether you would develop these symptoms depends on a lot of factors, such as your age and whether you already have an existing condition. While this all sounds scary, the push to develop a coronavirus vaccine is moving at high speed. Studies of other coronaviruses led most researchers to assume that people who have recovered from a SARS-CoV-2 infection could be protected from reinfection for a period of time. But that assumption needs to be backed by empirical evidence, and some studies suggest otherwise. There are several different approaches for a potential vaccine against the coronavirus. The basic idea is that you would get a shot that contains faint versions of the virus. The vaccine would expose your body to a version of the virus that is too weak to cause infection, but just strong enough to stimulate an immune response. Within a few weeks, cells in your immune system would make markers called antibodies, which would be specific for only the coronavirus, or specifically its spike protein. Antibodies then attach to the virus and prevent it from attaching to your cells. Your immune system then responds to signals from the antibodies by consuming and destroying the clumps of viruses. If you then catch the real virus at a later stage, your body would recognize it and destroy it. In other words, your immune system is now primed. Collecting evidence on whether this will be possible, safe, and effective is part of what's taking researchers so long to develop a vaccine. It's a race against time to develop a vaccine amid a pandemic. Each step in vaccine development usually takes months, if not years. An Ebola vaccine broke records by being ready in 5 years. The hope here is to develop one for the new coronavirus in a record-breaking 12 to 18 months. While all of this will take time, stay home if you can, to protect the most vulnerable. And don't forget to wash your hands for at least 20 seconds and as often as possible. This video was a collaboration between Nucleus Medical Media and the What If channel, where we usually dive into hypothetical scenarios about the human body, humanity, our planet, and the cosmos. Check out our channel by visiting the link in the description below.
Shopee fam, payday na! Kaya, i-check out mo na yan.
It's Some time.
Symptoms of coronavirus, COVID-19. Novel coronavirus, or 2019 nCoV, is a new strain of coronavirus which was first detected in Wuhan, China in December 2019. The disease caused by novel coronavirus is named as COVID-19. Fever, tiredness, and dry cough are the most common symptoms of COVID-19. Some infected people may also experience aches and pains, nasal congestion, runny nose, sore throat, or diarrhea. Symptoms of COVID-19 are usually mild and begin gradually. Also, surprisingly, some infected people don't even develop symptoms and don't feel unwell. It is estimated that more than 80% of people recover without the need of special treatment. but it is also estimated that 1 out of 6 people suffering from COVID-19 will become seriously ill and will develop difficulty breathing. Also, people with underlying medical problems like high blood pressure, heart problems, or diabetes, as well as older people, are more likely to develop serious illness. It is advised by WHO that people with fever, cough, and difficulty breathing should seek medical attention. Protective measures against coronavirus, COVID-19. Washing hands frequently. Washing your hands with an alcohol-based sanitizer kills viruses and thus stops the spread of COVID-19. Maintaining social distancing. When someone infected with COVID-19 coughs or sneezes, they spray small liquid droplets from their nose or mouth, which may contain the virus. Social distancing is deliberately increasing the physical space between people to avoid spreading illness. Avoid touching your eyes, nose, and mouth. As our hands touch many surfaces, we may accidentally pick viruses from there. Now, if we touch our eyes, nose, or mouth, we may transfer the virus. The virus can enter our body from there and get us infected. Practice respiratory hygiene. An infected person can help protect people around him if he practices respiratory hygiene, like covering his mouth and nose with his bent elbow while coughing or sneezing. Coronavirus myths. Myth number 1. Eating garlic can help avoid infection. Consuming garlic has its advantages, but as per WHO, it does not protect us from COVID-19. Myth number 2. Drink water every 15 minutes. There's no evidence to suggest that this virus can be flushed out of the system by drinking a lot of water. Myth number 3. Don't eat ice cream. It is being believed that not eating cold food and thus keeping the body heated will make it difficult for the virus to survive. This is not true. Myth number 4. Drinkable silver. Some are suggesting drinking tiny particles of silver suspended in liquid. It is risky to do so, and it is not shown to cure COVID-19 nor boost our immunity. Myth number 5. Holding breath. If a person can hold breath for more than 10 seconds, then one can avoid infection. Experts say this is simply not true. Myth number 6. Use of vodka as a hand sanitizer. This is not true because it does not contain enough alcohol to kill the virus. What is a coronavirus?
It is an alien which is haunting all of us.
Oh, some. Coronaviruses are a large family of viruses. They're found in animals as well as humans. Some of them are known to infect people and cause illnesses such as Middle East Respiratory Syndrome, as in MERS, and severe acute respiratory syndrome, as in SARS. Novel coronavirus, or 2019-nCoV, is a new strain of coronavirus which was first detected in Wuhan, China in December 2019. The disease caused by novel coronavirus is named as COVID-19. Here, CO and VI are taken from the word coronavirus, while D stands for disease and 19 stands for year 2019. Some people might suffer from mild symptoms like runny nose, sore throat, cough, and fever because of the virus, while some might experience severe symptoms leading to pneumonia. For some people, this disease has also proven to be fatal. Research is still on, but the animal source of the novel coronavirus has not yet been identified.
In this scenario, the healthcare worker undertaking aerosol generating procedure is using a coverall, an FFP3 mask, eye protection, and non-sterile gloves as personal protective equipment. Perform hand hygiene before donning on personal protective equipment. Ensure that you are bare below the elbows and wash your hands with soap and water, or use an alcohol-based hand rub. Put on a coverall that is the appropriate size for you. Do not apply the hood of the coverall, as there is no requirement for airborne transmission. Also, we recommend putting it on back to front, as it is safer to remove afterwards. Your buddy can zip up the back of the coverall. Next, put on the FFP3 mask. Ensure this is the model of mask you have been fit tested with. Perform a fit check. Next, put on eye protection. If using the visor, ensure it fully covers your face. Lastly, put on gloves. Ensure the gloves cover the cuff of the coverall. The healthcare worker is now fully donned. When you have finished the care activity, personal protective equipment must be promptly removed. It is imperative that you protect the mucous membranes of your eyes, nose and mouth. While inside the room, remove the gloves first, as these are the most contaminated part of your personal protective equipment. Do not touch the outside of the gloves, as this is contaminated. Dispose of them in the bin and then perform hand hygiene. Next, step outside into the amber zone. Close the door and perform hand hygiene. Areas where aerosol generating procedures are taking place, such as the spinal cord injuries unit and CHDU, are recommended to have an amber zone where there is not a lobby. The amber zone is where the staff member stands to remove their coverall, FFP3 mask and eye protection. This is marked with yellow tape and has a clinical waste bin inside the zone, and hand hygiene is accessible. In the amber zone, your buddy will be needed and should be wearing aprons and gloves. Ask your buddy to unzip the coverall. Then carefully remove the coverall from top to bottom, touching only the inside. Dispose of it properly and then perform hand hygiene. Next, remove your eye protection. Do not touch the front of the visor or goggles. Dispose of it properly and then perform hand hygiene. Lastly, remove your FFP3 mask. Do not touch the front of the mask. Dispose of it properly and then perform hand hygiene.
Hi, let's resume na po. So our next topic will be more of defibrillation na po tayo. Okay, so let's have the next topic known as the defibrillation. So guys, pag sinabi po nating defibrillation, pwede kasing manual. Now we have the manual defibrillation or defibrillator. And then meron din tayong tinatawag na AEDs po natin. So we have the manuals, and then we have the AEDs po, or also known as the automated external defibrillator. So this is your automated external defibrillator po natin. Ayan. So, when we say manual, ito po yung nasa hospitals po natin. Pag sinabi naman po nating AEDs, ito yung kinikerry po, na let's say, 'di ba? Once you activate kasi an emergency response system, dapat may dala po siyang AED. Yung AEDs po natin guys sa airport, may po, na sa mga fast food chain meron din. Ang alam ko McDonald's po sa vegan, yes, meron sila. Pero sa Legazpi, hindi ko pa nakita. Pero kasi ang nakita ko talaga sa McDonald's Legazpi, yung pindot-pindot nyo, yung social nyo na monitor. Doon ko talaga first na experience yun eh. Na medyo ano pa ako nun, medyo ignorante pa ako that time. Ayan, no? And then, yeah, let's discuss na po. Now, to discuss acute defibrillation, guys, so we have our number 1, we have the shockable rhythms. When we say shockable, they need immediate po na defibrillation. Then what are they? Number 1, we have the ventricular fibrillation to be followed by pulseless. Ayan, the pulseless ventricular tachycardia. So again, we have the shockable rhythm. Example po, we have the ventricular fibrillation, we have the pulseless ventricular tachycardia. Sir, ano bang itsura nila? Ano bang itsura ng VFib natin saka pulseless ventricular tachycardia in a monitor? Kita ko lang ha ang ating itsura po. Okay, right in front of you, no? In your screen po, I'm actually projecting a normal sinus rhythm. So if this is a normal sinus rhythm, to normal patients po like us, no? Or to your normal patients, di ba? And this is for the normal sinus rhythm. However kasi, what if biglang gumanito? Then the patient suddenly experiences the sudden cardiac death experience, also known as the ventricular fibrillation. Now this is the VFib. Kaya nga pag VFib po, no, we defibrillate the patient. Pero kasi before defibrillating the patient, na you need to perform the immediate CPR or high quality chest compression po natin. Next po, we have the ventricular tachycardia. A while. Okay. Now, right in front of you is your ventricular tachycardia po, or known as the VTAC. However, this should be pulseless. Lahat naman kasi, let's say pag sinabi po natin, if you want to defibrillate that patient, make sure na unconscious po ang patient po natin. Sino ba naman ang gustong kuryentehin? The electrocution yon, na? Ay another problem naman yon, no? So dapat unconscious ang patient mo kasi ang defibrillation kasi, ganito ang ang purpose niya. Ikaw na unconscious, pwede ka tang maging conscious, kukuryentehin kita muna. Pero pag ikaw na conscious, guys, kinuryente ko, magiging unconscious ka. So baliktad ang magiging mangyari. Kaya nga dapat, we need to make sure na dapat unconscious ang patient niya. So we have the pulseless ventricular tachycardia and then we have the ventricular fibrillation po. Next, guys, aside from shockable, we have the non-shockable. They don't need defibrillation, but they need high quality chest compressions. What are they? Number 1, asystole. Next to asystole, we have the pulseless electrical activity known as the PA. It's the pulseless electrical activity po. Your pulseless electrical activity, also known as the PA or the PEA. Now, your PA, ganito kasi ang situation ng PA. At first, may sinus bradycardia ang patient niya. Next, nag-arrest si patient, nagkaroon ng VFib. From VFib, nag-asystole ang patient. From asystole, akala mo bumalik na sa life ang patient kasi may PQRST siya. So sabihin mo, Doc, buhay na po ang patient. Pero syempre si Doc ay diskumpiyado. Sabi ni Doc, okay, nurse, please check the pulse of the patient. 1,000, 2,000, 3,000, 4,000, 1,000, 5,000. Doc, wala pong pulso ang patient. Na? So, ang nakikita po nating PQRC, or artifact lang, meaning to say, hindi pa talaga buhay ang patient natin. And imbes na ilagay mo siya sa recovery position, syempre wala na. Kasi pulseless pa rin si patient natin eh, na. So, ayun po. Nangyari din 'yan sa ano, sa isang duty ko, let's say mga 15 years ago. Like 15 years ago, na I can vividly recall nangyari to sa ano, sa barkada ko. Why? Nag-duty kami sa ER. Syempre tandem kaming dalawa. Tapos alam niyang nangyari, syempre may ginawa na 'no, may ginawa 'no. Tapos sabi niya, "Doc, ano po, ang patient po ata natin ay nag-PEA." Ayan, tapos nagalit si Doc 'no, honestly nagalit si Doc. Sabi niya, "Ba't mo naman sinabi na PEA?" 'No, ayun na, siyempre nag-explain siya 'no. Yun lang, yung sad part lang is medyo napahiya siya na in front ng mga watcher na, in front sa other patients, napahiya po siya, yung barkada ko. Alam niyo yung ginawa niya, guys? As in like, nag-mark talaga yung mga words na sinabi sa kanya. No? So, ayun, naging doktor talaga siya. Kasi nasabihan siya ng ano eh, bakit doktor ka ba? So, ayun, na-hurt talaga siya, sobrang na-hurt siya. Sabi niya, okay, sige. So, nag-doktor siya. So 15 years ago, so malamang doktor na siya ngayon. And he even topped na the board examination ng Physician's Licensure exam. Na top 3 po siya sa board examination nila. So grabe yung ano niya, yung comeback niya. Comeback is real talaga. Na? So kung saan kami na hospital nag-work, doon din siya nag-work ngayon. Nakahappy ako, sobra akong proud sa kanya. Ako dati pinangarap ko din talaga maging doktor, no? Kaso nagbago na yung isip ko sa buhay. Ito na lang yung ang maging kabit ng doktor. At least na hindi na ako mag-aaral. Chos. And we have the shockable and then we have the okay, shockable rhythms po natin. Ipakita ko lang yung video natin regarding defibrillation po. AED.
Mrs. Williamson collapsed in the treatment room. Activate EMS.
Remove clothes from patient's chest. Peel white pads from gray plastic case. Attach pads to bare skin exactly as shown. Stay clear of patient. Analyzing heart rhythm. Shock advised. Stay clear of patient. Press the flashing orange button now. Shock delivered. Begin CPR.
AEDs are designed to be simple to operate. Voice instructions, lights, and screen prompts guide an operator through use. There are many different brands of AEDs, but the same basic steps for operation apply to all. Opening the lid will turn on the power for some AEDs. With others, simply press the power button. This starts voice instructions and readies the device for use.
Apply pads to patient's bare chest.
Pads must be applied to a bare chest. If needed, quickly tear away or use scissors to remove all clothing from the torso. Dry the chest quickly if wet. For a woman, remove the bra to provide better access for pad placement. Locate and pull out the defibrillation pads. The pads have pictures on them to show proper placement. Peel the pads from the backing sheet one at a time and place each as shown in the pictures. Place one pad below the right collarbone above the nipple and beside the breastbone. Make sure it adheres well by pressing it flat. Place the other pad lower on the left side over the ribs and a few inches below the armpit. Again, press firmly. Most AEDs automatically start analyzing once the pads are in place.
Analyzing.
Stop CPR. Movement can interrupt the analysis. Be certain that no one is touching the person. If defibrillation is advised, the AED will begin to charge for shock delivery.
Shock advised. Stay clear of patient. Deliver shock now.
Quickly look to make sure no one, including you, is in contact with the person before delivering the shock. For most AEDs, a button is pressed to deliver the shock.
Delivered.
Once a shock has been delivered, immediately resume CPR starting with chest compressions. In cases when a shock is not indicated by the AED,
No shock advised.
immediately resume CPR. AEDs are also designed to detect problems during use and guide you through corrective actions.
Press pads firmly to patient's bare skin.
If a troubleshooting message occurs at any time,
Insert connector firmly.
stay calm and follow the AED's voice instructions. Cardiac arrests involving children are likely caused by the initial loss of the airway or breathing. High-quality CPR with effective rescue breaths may be the only treatment required for successful resuscitation. However, conditions can occur for which defibrillation of a child or infant is warranted. The steps for using an AED on a child or infant are similar to an adult. Most AEDs have specially designed pads or mechanisms available that reduce the defibrillation energy to a level more appropriate for a smaller body size. For smaller children and infants, place one pad on the center of the chest just below the collarbones. Attach a second pad on the center of the back between the shoulder blades. Follow the AED's voice instructions to provide the appropriate care.
Walang QRS.
At the same time, the BLS assessment is a simple way to quickly identify if resuscitation is required. It is the same for all ages and is performed quickly. Before anything else, pause and assess the scene for hazards. Take standard precautions to prevent contact with blood or other potentially infectious materials. If it is safe, check for responsiveness. Tap or squeeze the person's shoulder and ask loudly, "Are you all right?" For an infant, tap the foot. If unresponsive, quickly look for signs of normal breathing. At the same time, check the carotid pulse in the neck. Normal breathing is effortless, quiet, and regular. Weak, irregular gasping, snorting, or gurgling sounds, known as agonal breaths, can occur early in cardiac arrest. These actions provide no usable oxygen. This is not normal breathing. For an adult, check the carotid pulse in the neck. Locate the bony Adam's apple with your fingers, slide them into the groove between the windpipe and the muscle on the side of the neck closest to you. For a child, check the carotid pulse or the femoral pulse in the leg. Place your fingers just below the middle of the crease where the leg and torso meet. For infants, feel the brachial pulse on the inside of the upper arm. Lay your fingers across the arm and compress inward. Take at least 5 but no longer than 10 seconds to assess breathing and pulse. If you are unsure, assume they are absent. If not already being done, tell another person to activate the protocol and get an AED. Relay what you have found so it can be passed on. Your assessment of the person and situation will determine the care you provide. If the person is breathing normally and uninjured, place her in a side-lying recovery position. Place the arm nearest you up alongside the head. Bring the far arm across the chest and place the back of the hand against the cheek. Grasp the far leg just above the knee and pull it up so the foot is flat on the ground. Grasping the shoulder and hip, roll the person toward you in a single motion, keeping the head, shoulders, and body from twisting. Make sure the head ends up resting on the extended arm. Roll far enough for the face to be angled towards the ground. Make sure there is no pressure on the chest that might restrict breathing. The recovery position helps protect the airway by using gravity to drain fluids from the mouth and keep the tongue from blocking the airway. Frequently assess and monitor the person's breathing. The condition can quickly become worse and require additional care. If the person is not breathing or only gasping, but definitely has a pulse, he is in respiratory arrest. The indicated care is rescue breathing, which is ongoing rescue breaths provided without chest compressions. If the person is not breathing or only gasping and does not have a pulse, he is in cardiac arrest. The indicated care is CPR, a repeating combination of chest compressions and rescue breaths. Always perform a BLS assessment to quickly determine the need for CPR. Ensure the scene is safe. Assess responsiveness. Assess for breathing and pulse. Activate the emergency response protocol for your setting and get an AED.
Okay, let's resume na po. So let's have the BLS sequence na. So i-apply po natin yung mga learnings natin from the very beginning, up to when are we going to stop high quality chest compressions na. Guys, kailan nga tayo magsa-start ng high quality chest compression? No pulse, 'di ba? Not breathing. Breathing but only gasping, or basically pag unconscious po ang patient po natin. So you need to go sa scene na po natin. You need to observe for scene safety. So if the scene is safe, then you approach your patient. However, before approaching your patient, PPEs on na po tayo. Meaning to say, personal protective equipment on na. The PPDs po natin, the personal protective devices. So mask, on na po tayo. Tama po? Kasi we will be dealing in starting kasi sa BLS po, we need to cater everyone as what? No, syempre, lahat po ay contaminated ba or infected ba, 'di ba? Contagious, na just to protect lang ourselves. Yun talaga yung unahin natin. Before approaching let's say before giving help to others, ayan, isipin po natin, is it safe ba? Na? Kamusta kayong surrounding niya? Baka may mga poisonous fumes, na? Or baka itong patient na to is what, na? Nag-contraction ng let's say ng COVID virus, no, COVID-19 po natin. So careful po tayo. Now, yan, putting the mask on, no, syempre sa'yo, and then putting the mask on na din kay patient din. Okay, mask on, ikaw yan, na you as a BLS provider, and of course mask on, no, especially to our patient. To patient din dapat. Ikaw at saka si patient dapat may mask. Pero unahin mo muna ang sarili mo and then lagyan mo po ng mask si patient po natin. Now, aside from your PPE on na po, you approach your patient. You check for responsiveness. You check for responsiveness. In checking for responsiveness, guys, you need to tap and shout. Hey, hey, are you okay? Hey, hey, are you all right? But again, ang technique po ngayon, like for example, shoulder ng patient natin, no? Ayan. Kunwari, shoulder ng patient. Kunwari, ikaw to. Dapat isang hand ka lang na nearest you. So, hey, hey, are you okay? Hey, hey, are you all right? Nakuha? Bawal na kasi yung both hands kasi na may expose ka lalo kay patient, na mas malapit ka kasi kay patient pag hey, hey, are you okay? Hey, hey, are you all right? Ngayon, isang hand technique na lang. Hey, hey, are you okay? Hey, hey, are you all right? Tapos make sure na may distansya, or else baka syempre makuha natin, no, ma-harbor natin yung virus na kay patient. So hey, hey, are you okay? Hey, hey, are you all right? So the patient is unresponsive. Hey, hey, are you okay? And then, hey, hey, now, are you all right? So if the patient is unresponsive, the patient is unresponsive, you call for help na po. So our, number 4 will be call for help. Guys, na in calling for help kasi, na dapat specific tayo. Kasi baka sisigaw ka lang, help, no? Activate the emergency response system and you grab an AED. Sabi mo kasi you, tas madaming tao doon. Siyempre malilito sila, lalo na pag maraming marites, maraming chismosa. No? Ako ba yun? No? Sino ba yon? Baka si ano yon, no? Si Christopher Min or si Lolit Solis, 'di ba? Or si OG Diaz, 'di ba? Madami kasi mga chismosa at marites ngayon, no? So you need to be very specific. Ikaw, sir, na naka-red, no? Na naka-shorts, na gwapo, kinumpleto pa talaga eh, no? So at least alam niya na siya, no? Tapos what if dalawa sila? No? Depende na lang kung feeling gwapo yung isa or gwapo talaga yung isa, na? So let's say ikaw sir na nakaputi, na naka-jeans, na nakasapatos. Sir, please activate the emergency response system or please call 911. Guys, ano nga yung mga numbers ng mga emergency hotline po natin? Memorize nyo ba? Ayan, can you name one? Yung hashtag 87000. Jollibee delivery yon. Hindi po yung 911. Ibang emergency po yun. Sa lahat ng emergency, yun yung gusto ko, yung pagkain. Lalo na yung mga friends po natin, di ba? Uy, friend, absent ako kahapon. Sige, libre kita. Call lang tayo ng hotline ng Jollibee. Na? Pero pag ayan na naman siya. Ayan na naman yung papansin kong pusa. Wag na muna natin siyang pansinin. I have 9 cats na wala po sila mga balahibo lahat. So you need to call for help, na? So, syempre help. Ikaw, sir, na naka-red, na naka-shorts, na please call 911. And if ever kung may AED po tayo, na or automated external defibrillator, pwedeng pakidala na lang po. Or if ever kung nasa barangay area ka, na tapos walang mga hotline, pwede po, sir na naka-red, na naka-shorts, sir, patulong naman po, baka may malapit po na barangay hall dito or let's say yung mga barangay center po natin, health center. For sure kasi may mga doctors diyan, may mga nurses, 'di ba? So pwede po silang mag-render ng care, okay, sa patient po natin. So you always call for help before starting to let's say check the pulse of the patient. Kasi the moment na mag-check ka na ng pulse at saka the moment na mag-check ka na ng breathing kay patient, dire-diretso na kasi yan. Dire-diretso na po yan. So you always call for help. Now, aside from calling sa tinatawag na help po natin, this is the time na we need to check. Ito na. Number 5 po, check for, dalawang i-check po natin. Number 1 for the pulse rate, and then check for RR or check for breathing. Guys, dapat simultaneous po dapat yan ha. Check for the RR and check for the breathing. Dati kasi, you check for the RR first. May look, listen, and feel pa. And then check for the breathing next. Check for the pulse rate next. Dati yon. Pero ngayon, we need to limit kasi yung mga tinatawag na interruptions po natin. So to limit interruptions, dapat sabay-sabay na po. Check for pulse and then check for breathing. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. No pulse, no breathing. Let's start high quality chest compression po. So meaning to say, paano nga ulit mag-check guys? Paano ulit mag-count? Sabay-sabay nga tayo. 1, 1,000. Sige nga, mag-unmute tayo. Start. 1, 1,000. 1, 1,000, 2, 1,000, 4, 1,000, 5, 1,000. Nakuha po? Ayan, yung iba kasi biglang nagpapanik pag nagka-count, no? 1, 1,000, 2, 4, 1,000, 3, 4, 1,000. Ano yan? Lazada, Shopee sale? Guys, if ever kung ayaw mo yung counting ko na ganon, may isang another way pa po. Pwedeng mag-count ng ganito. 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, and 5 Mississippi. Pero pag bulol ka, huwag ka na lang mag-ambisyon ng Mississippi. 'Di ba pag bulol ka, 1 Mississippi, 2 Mississippi, 3 Mississippi. Hanggang sa natawa na lang yung patient mo at nabuhay na lang, na kahit wala kang ginawang compression, nabuhay na lang siya bigla. Ano ba tong responder na to? Bulol. Ayan. So ayun po. So you check for pulse rate, you check for RR. Kasi if no pulse, no breathing, then this is the best time for us to start na with your high. Ayan. If ever lang kung no R, therefore we need to start your high quality chest compression. Okay po? You start na with your high quality chest compression. And yun yung pinakagusto natin. Now, if I may ask, sino na ba dito ang nakakompress? Sige nga. O, tanungin ko muna si Sir Ariel. As an ambulance driver, sir, na-try mo din bang mag-compress ng let's say ng victim po natin? Nakakompress ka na, sir, or wala pa?
po.
Never pa.
Never.
Ayan, alam mo ba, sir, na pinangarap ko din talaga maging ambulance driver? Kasi kaskasero ako eh. Kasi like pinangarap ko talaga. Gusto ko talaga mag-counterflow always.
Pag may patient lang po.
Yun lang talaga yung...
Pag may patient
Sir,
po pwede.
kaya sabi ko talaga, Diyos ko, pangarap ko din talaga. Kasi I have friends po sa Central 911. Di ba sa Davao kasi may 911 kami na Central 911. So, yung mga friends ko doon, mga babae ha, mga babae, kasi like chicks na chicks talaga, tapos mga driver ng ambulance, tapos mga kaskasera pa talaga. So, syempre, idol ko sila, no? So, naging kaskasera din ako, na kaya, yeah, pangarap ko din talaga. So may mga kaskasera pa rin ba dito? For sure meron din yung mga gustong maging ambulance driver, no? So tularan natin sila. Ako, honestly, gustong-gusto ko talaga 'yon. Okay, I'll be presenting muna the latest chain of survival. Now, the latest chain kasi of survival po, this is based po, no? Lalo na ayan, kung may mga COVID protocols po tayo. Alam niyo ba nagpapasip-sip talaga tong pusang to? Wanna know why? Kasi ayaw niyang ibenta. Nagbebenta kasi ako ng pusa, guys, no? And feeling ko kaya nagpapasip-sip siya para syempre ayaw ibenta, 'di ba? At dito lang siya sa bahay. No, kailangan ko siyang ibenta. Ayan. So we have the step 1 and that is to call 911. To call 911. Syempre ano bang number ng 911? Edi 911 na sa inyo ata may mga 117 na depende po yung mga hotline, emergency hotline po natin. Kaya nga, if I were you guys, na isulat po ang mga emergency hotline numbers po natin. Na lalo na pag nasa bahay po tayo. What if 'di ba ang natira lang yung mga kapatid nyo, yung mga bata? So ano yung mga tatawagan nila ng mga numbers? Yeah, kaya mamaya ma-appreciate niyo yan sa basic first aid, no? Yung mga ano ba yung mga dapat nating gawin, 'di ba? Pag nasa bahay, aside sa mga emergency kit po natin or sa first aid kit, dapat may mga hotlines tayo, may mga numbers din po tayo. I'm not sure kung free ba yung first aid po natin. Tama ba? Free seminar ba siya? Or package talaga siya? Ma'am Joy or admin? Is it a free seminar ba or part talaga siya ng package? Hindi ako sure eh. Kasi last time nagpa-free kami na
Part po
ma'am?
po yung first aid.
Okay, part talaga siya, ma'am. Na part talaga. So it's a paid talaga na na training seminar. Okay, mas maganda, na. So guys, do not expect na fracture mamaya, ha? Na I always begin with breathing problems, no, yung signs of heart attack, kasi I will be following the first aid heart saver from the American Heart Association. Hindi yung Red Cross na first aid, sorry. Baka kasi mga kravat-kravat yung mga ang i-expect nyo mamaya. Syempre hindi po, na yung basic first aid na nangyayari sa labas ng bahay at pwede ring inside our house or home po natin. Like for example, yung mga burns po natin, yung mga full thickness, partial thickness, yung mga first degree burn po natin, kung anong water ba ang pwede nating ibigay na i-flush po natin. Let's say kung may mga scalded burns po tayo. If you're familiar sa scalded burns, guys, everybody say scalded. Ayan, thank you. When we say scalded burns, these are hot water burns, which is really common, na? Anong mga ages po yung very common, guys, na kung saan malilikot yan? Ayan, 1 to 3 years old. Pag toddler po, na? Ang mga, let's say, mga clients po natin. Ayan, Ma'am Joy, ilang taon na nga ma'am, si baby natin, si baby boy?
2 years old, madam.
2 years old, no? Like, ang bilis lang ng panahon. Diyos ko dati, infant pa siya ngayon. Toddler na siya. Ayan, so aside from having your step 1, let's have your step 2. Kasi, di ba, this is a COVID-19 plus your adult, okay, high quality chest compression. So you cover your own mouth, no? And then you cover the person's mouth. Now cover the victim's mouth but using your pwedeng, okay, let's say, mask. If ever kung walang mask po, pwede po yung cloth. Walang problema as long as it's clean. Alangan naman ilagay mo sa mouth ng client mo, maduming cloth, amoy tae. Cause of death, tae. No? Namatay tuloy no, dahil sa madumi ang cloth na binigay po natin. And then lastly, no, 3 and 4 po natin. Syempre, when the help arrives po, we have the AED and it's for the defibrillation. And then lastly, na use an AED if ever. So guys, yung number 3 po natin na hands-only CPR. If ever kung, no, like magigilty ka, sir, bakit CPR lang? Bakit hands-only CPR? Kasi nga na baka na may COVID si patient. No need for you to have the mouth-to-mouth resuscitation. Bawal na bawal yan. Especially sa panahon ngayon. Na? And nakakasad lang ngayon kasi parang tapos na kasi ang target population ng mga middle adult, no, the average adult. Alam niyo ba kung sino na ang target na naman ngayon? Yung mga pediatric clients na kasi may recent na news po kahapon, isang 2-year-old na bata na niya nakuha niya ang COVID guys na after going sa mall. Kasi ngayon open na po ang mga malls. Here in Davao open na po ang malls sa mga kiddies na sa mga pediatric patients, they are allowed na to go inside the malls na po. Kaya tumataas na naman ang cases. Kaya careful na. Like sobrang careful dapat tayo. Okay. Wait lang ha. Continue tayo. Tapos na tayo dyan. So we need to discuss when are we going to stop high quality chest compression. Guys, everybody say stop. Ayan. So we have the mnemonic. Okay, stops. Okay po. Ayan. Sulat ko lang ang mnemonic na stops po natin ha. So STO. Okay, letter P. And then we have your letter S po natin. Now, you need to stop now with your high quality chest compression with your first letter S. And that's the spontaneous. We have the spontaneous return of circulation. Now, when we talk of spontaneous return of circulation, let's say the patient has pulse rate, the patient has RR already, or let's say ang patient mo may PETCO value, or the PET CO2, or the partial and tidal CO2, then those are signs of life na po. Pulse rate, RR, PET CO2. Next, guys, now your letter T. Ayan. Sir, if ever kung dumating na po yung 911, so i-turn over to 911 na po ang patient. Huwag mong ipagdamot ang patient na i-refer po natin sila sa 911. Now, kasi 'di ba kanina kasi sumigaw ka ng help. Si sir na naka-red na naka-shorts, please call 911 and grab an AED. Ang AED guys na if ever kung nasa mga eroplano ka, meron pong AED ang eroplano. Na like for example, Philippine Airlines, marami po silang AEDs, na pero sa Cebu Pacific, selected flights lang po ng Cebu Pacific, na selected only. Na if ever nga lang kung bumalik na yung mga flight na, kaso wala kasi kaming direct flight like Davao to Bicol, wala eh. Davao to Legazpi, wala. It's Cebu to Legazpi, Legazpi to Cebu, and then Cebu to Davao. If kung pwede lang talaga, no, gusto ko ding bumalik talaga ng Legazpi na of course ng Naga, 'di ba? Para makita yung mga friends ko, sila Ma'am Joy, no. Ayan, sa Sir Raymart, sa Sir Paul, no. Madami pa. Ayan, letter O. Yan, you can stop your high quality chest compression if there will be overexhaustion. Guys, pag sinabi po nating overexhaustion, like pag sobrang pagod ka na, 'di ba? Yes, the scene is safe. Na yes, naka-mask ka. Yes, pag put on mo ng mask kay patient, no? Hala, pagkakita mo ex mo pala to. So tanong ko lang, pag nakita mo tas ex mo, iko-compress mo ba or hindi? I-type niyo na lang yung mga sagot niyo. Kasi baka masampal pa kayo ng mga ng mga asawa niyo ngayon. At saka yung mga jowa niyo diyan, no? Syempre yung iba sasabihin nila, syempre sir, iko-compress ko pa rin lalo na pag hindi ka pa nakapag-move on sa ex mo, no? Or pag naka-move on ka na, sasabihin mo ay pagod na ako sa iyo, no? I'm done, 'di 'di ba? Hindi na kita i-compress, pero nakalimutan mo na medical provider ka. Safety pa rin ng patient ang pinakaimportante sa atin, 'di ba? Ayan, 'di ba, the passion or let's say, no, 'di ba, we have your 'di ba, may oath taking kasi tayo, yung oath po natin na to deliver, 'di ba, healthcare, 'di ba, or to deliver yung mga quality services, 'di ba? Part po 'yan, na part po 'yan. So again, no, kailangan pa rin po i-perform ang high quality chest compression. Pero pag pagod na pagod ka, depende daw eh. Depende kung gwapo pa rin si X, no? Or depende kung maganda pa rin si X. Pero pag tsaka na si X, move on na, 'di ba? Ayan, so we have our overexhaustion. Pero pag pagod na pagod ka, guys, you have the right po na hindi na mag-perform. Kasi again, here in the Philippines, no, wala kasi tayong Good Samaritan law. Familiar ba kayo sa Good Samaritan? 'Di ba, the Good Samaritan law? Your Good Samaritan law, that only means na you're not liable, you're not responsible sa kung ano man ang mangyari kay patient. Meaning safe ka. If ever kung namatay siya in your hands, safe tayo. However, wala po yan in the Philippine setting. Nasa States yan, nasa Middle East, but never at wala po sa Philippine setting. Whatever happens to your patient, pwede kang kasuhan, na pag na-videohan ka, pwedeng, na itaas yan sa korte at pwede kang, makulong. So, kawawa ka. Meaning to say, na if ever talaga kung wholeheartedly gusto mong tumulong at magaling kang mag-compress, then, so be it, di ba? Na of service, sige, no, tumulong ka. Pero pag alam mo yung hindi ka ready, di ba? Kasi nakalimutan mo yung sequence po natin. Kasi masyadong ideal po yung sequence natin. Iba kasi ang ideal, iba din yung barangay level. Guys, 'di ba ang ideal po natin, you check for hazards, look up and down, no? Mask, on, PPDs on or PPE on, and then you need to put, 'di ba, yung mask po sa patient natin. Tap and shout, "Hey, hey, are you okay? Hey, hey, are you all right?" Barangay level, "Sir, sir, sir, okay ka lang? Sir, 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 can you hear me ba?" Ayan, if ever kung wala, excuse me, wag po masyadong lapitan, medyo distansya lang po tayo. Si sir na naka-black, sir, patawag na lang po ng let's say nearest po na barangay. And then if ever kung may AED po, pwede pong pakidala na lang po kung meron po. Ayan, so checking for pulse and breathing, 1,000, 2,000, 3, 1,000. No pulse, no breathing. I'm going to start with my high quality chest compression. What if nakalimutan mo yung sequence? Ang pinaka-importante, guys, is that before ka mag-arrive sa scene safety dapat ang pinaka-importante. Isipin mo ang sarili mo, isipin mo ang pamilya mo, na kung uuwi ka man later, hindi ka acquire ng mga viruses, bacteria coming from your patient. And then whenever you start na with your high quality chest compression, dapat i-activate mo muna ang emergency response system. Yun lang yon. Sometimes kasi yung iba, ay shucks, nakalimutan ko yung sequence, initiative po, Although common sense is not common nowadays, pero syempre, you need to dapat quick thinkers kasi tayo eh. Dapat yung pag-analyze mo during a critical dapat na na mga scenario, dapat mabilis. Unahin mo ang safety mo muna before ang safety ng patient po natin. If na-determine mo na safe ka, pues ang safety na naman ng patient ang next priority po natin. Now, aside from overexhaustion, yes, pag pagod ka, pwede kang mag-say no. Pagod ako, stop ko na po yung high quality chest compression. Kasi pag nagpaka-hero ka, pagod ka, bigla kang nahimatay, si patient na buhay at hindi marunong mag-high quality chest compression, ikaw tuloy ang namatay ngayon. Wala pa namang mga rebultong ibibigay sa iyo. Ni certificate ni award wala. So kawawa ka, 'di ba? Ang magsasuffer tuloy yung family na naiwan mo. Tas wala ka pang PhilHealth, wala ka pang mga St. Peter Life Plan. Kasi ngayon na ko talaga, na-appreciate ko yung yung mga St. Peter, kasi yan yung mga mga practicality lang talaga, na wag puro Starbucks, 'di ba? Wag puro coffee shop, no? St. Peter Life Plan din. Pero hindi ako nag-work sa St. Peter Life Plan na. Doon ko lang din na-realize na ang value niyan at saka ang importance niya nung namatay yung father ko. Just siguro mga 4 years ago, na we were not let's say mentally ready, no? Financially ready. Siyempre, biglaan kasi siyempre accident yan motor vehicular accident. Sino ba naman mag-expect, na? So, ayun po, maging practical na po. So, PhilHealth, although may corruption naman sa PhilHealth ngayon. Pero sa mga, may matanong ko lang, sa mga nag-work sa government, no, may PhilHealth share pa rin ba or wala na? Ay, ayaw mag-divulge. May PhilHealth share ba, Miss Joanne? Kasi parang nababasa ko sa mga mata ni Miss Joanne. Si Miss Joanne po ba isang nurse or doctor po?
Nurse po. Sa private po.
Ma'am, saan kayo nag-work, ma'am? May PhilHealth share po ba sa inyo, ma'am? Government, di ba, ang may PhilHealth share? Tama ba ako? Ayun. Na kasi yung ex ko guys nag-work sa BRT. Diyos ko po ang PhilHealth share, 'di ba, ng mga doctors po natin naabot ng 50 plus. Ayan. Sino ba dito ang nakatanggap pa rin ng PhilHealth share? Kaya if ever kung may PhilHealth share siya dati guys, sobrang galante niya lang. Sinasabi niya always, mahal, mahal. Move on na tayo guys. Sabi niya dati, mahal, anong gusto mo? Sabi ko, ay, Diyos ko, nakatanggap to ng PhilHealth share Siyempre, gusto ko ng cellphone. Diyos. Pok-pok a girl. Ayun, kaya sabi ko talaga, sabi ko, syempre hindi. No, syempre, I can buy naman No? Kaso nga lang, may mga things talaga na hindi para sa amin. Na? So, ayun po. So, we have our letter P, we have the physician. We need to stop. If the physician assumes responsibility, Now, sir, pag sinabi po natin, assumes responsibility, and that is to pronounce that the patient is dead. Okay po? Pag sinabi ng physician na patay po ang patient natin, then maniniwala po tayo. Pero pag sinabi po ng nursing aid, time of death, syempre hindi po tayo maniniwala. Kasi si physician lang po ang may right na mag-declare na patay na po ang patient. Okay po ba? Bawal din si nurse na mag-declare na ng time of death. Dapat si doctor lang po. Again, nag-iisa lang po ba ang doctor natin today? Si Dr. Cope lang po ba? For sure meron pa yan, na? Si Sir Charlie, parang ito ata yung nasabi ko kanina, Dr. Charlie De Leon. Hello, Sir De Leon. Is Sir De Leon ba a doctor or a nurse?
Nurse po, nurse.
Ayan. Sino yung, ayan, hello sir. Ayan, saan ka na nurse sir? Saang hospital po?
Dr. Amando po, Cope Memorial Hospital.
Saan nga ulit yan sir? Sa may?
Tabaco City po, Tabaco City.
Sa Tabaco, no? Hello, welcome again to WePump. Ayan,
Thank
sino
you.
pa yung mga doctors po natin? For sure madaming doctors. Kasi every time na magte-training kami, hindi po bababa ng mga 5 doctors po. And nakaka-happy kasi yung iba parang 3 consecutive trainings na nila akong nakikita. Wag sana kayong magsawa. So, physician assumes responsibility. Guys, question lang, what are the signs of death? Ayan, we have the signs, of death po. Ayan, for the signs of death, we have the severe paleness, 'di ba? Ayan, we have the severe paleness, pero ito talaga, na if you're familiar with rigor, algor, livor, putrefaction. Ayan, faction. Next to putrefaction, we have the decomposition. Ayan, scission po natin. So once again, these are the signs of death. Itong rigor, algor, mortis. Now, when we talk of rigor, everybody say rigor. Diba? When we say rigor, that means rigidity. Sorry, nabura ko. This means rigidity or meaning stiffness. 'Di ba? Nanigas ang patient po natin. Usually 4 to 6 hours after, no? Nung dineclare po ng doktor na patay si patient, biglang maninigas po 'yan. That's rigidity. Now, algor mortis, that means a drop in the temperature. A drop in the temperature, meaning manlalamig ang patient natin. Of course, ang panlalamig po ay hindi lamang sa mga patay. Pwede rin sa relasyon nyo ngayon, napatay na ang relasyon. Kaya kailangang painitin ang relasyon. Na? Ayan, yung iba nakaka-relate doon. Kaya kasi, awit. Yeah, awit daw, no? Ew, ew. Kasi yung iba kasi guys, no, boring na kasi ang relasyon eh. No, naalala ko dati, 'di ba, yung kumain ka na babe, good morning, no? Kain ka na, ingat. Baguhin nyo kasi, no? Dapat ganito kasi oh. Oh, good morning. Nakatae ka na ba? Ilang ml ang tae mo ngayon? O sumuka ka ba ngayon? Ilang ml? 'Di ba dapat ganun baguhin nyo guys. Huwag masyado pa ulit-ulit na lang na kumain ka na. No, tulog ka na, malamang nakapag-reply pa, malamang hindi yan tulog. Alangan sa panaginip siya nagre-reply, 'di ba? Kaya minsan nakakasawa pag paulit-ulit na lang, no? Kaya ako dati, syempre may jowa ako, tawagan namin nget, no? Kasi tinawag ko siyang nget kasi pangit. Pero hindi talaga siya pangit, guys. Gwapo talaga siya. Pero siya ang tawag niya sa akin boy. Why? Kasi baboy, no? As in like niliteral niya talaga ako. Sabi ko, grabe naman. Like res ipsa loquitur talaga. The thing speaks for itself, no? Grabe. So we have a drop in the temperature guys sa manlalamig. Naalala ko to sa father ko. Yung pinaka first ko talaga na na syempre 'di ba, yung mga the care of the dying po natin na ano nga yung tawag natin doon guys, the postmortem care. 'Di ba after na pronounce po na patay si patient, no, postmortem care na. As in like grabe, no? Dito ko pa na-appreciate, no, yung mga rigor, algor, no? Kasi never pa ako naka-postmortem sa buong buhay ko while working sa hospital. Only sa father ko. At pinaka-worst na nangyari yon. For those na kompleto pa po ang family, you value life. Although may mga pagsubok no sa lahat ng let's say family po natin, iba-iba kasi eh. Iba-iba ang attitude nila, like sobrang iba-iba. You value life na you're so lucky na complete pa yung family nyo. Kasi pag nawalan niya ng isa, ang pangit lang ng family. Medyo ano na. Kaya for me, pag Christmas, yung iba happy pag Christmas. Pero yung mga nawala ng loved ones, no, medyo yung Christmas po ay isang pagsubok para sa kanila. Kasi that's the time na mare-recall nila yung mga yung mga tao na nawala sa buhay nila. Yung jowa kasi, well, may kita mo yan. Pero yung family mo, syempre hindi mo sila. Although, yeah, may mga pasaway talaga. Pero, well, family pa rin eh. Na? So, ayun po. So, we have the livor. Guys, for the livor mortis kasi, this is derived from the word lividity. Ayan, this is the settling down. Kunwari ito yung patient mo. Lahat ng mga dugo nasa likod ng patient. Kaya nga, as you turn the patient to sides, there is the settling down of the blood from the, let's say, upper parts ng body mo, no, papunta sa likod yan. Kaya, di ba, yung mga namatay na patient, i-turn to sides mo, lahat ng mga dugo andun sa likod. Ang tawag doon, livor mortis. That is derived from the word lividity. Ulitin ko lang, ang puwet pa talaga ng ng pusa ko eh, no? Nasa mukha ko talaga eh. Ay, Diyos ko. Ayun, pero I can't live without my cats, no. Nawawala lang talaga yung yung stress ko sa kanila, na lalo na pag sad ka, na ayan, pag lonely ka, you still have your cats with you. And then guys, for sure, no, halos lahat tayo ay medical professionals po, right? Yung iba, doctors, no, nurses, midwives, no, ambulance drivers, na madami pa, no, midwives po natin, medtechs for sure meron. Try to avoid the word depression kasi sometimes na iba kasi ang word na depress sa lonely. Iba din ang ang word na depress sa you're just sad. 'Di ba? Iba din po ang depress sa you're just alone, na? Yung iba kasi ngayon ang bilis nilang sabihin, "Ay, depressed ako." Oy, bakit? Nag-DSM-5 criteria ka ba? Na? Pasok ka ba sa DSM-5 criteria? Na? Pasok ka ba sa mga ano talaga, na mga sign and symptoms na you are really depressed? Na yung iba ang bilis lang nilang sabihin po, i-declare na depressed sila. Well, in fact, lonely lang sila or sad lang sila. Pero I just like to grab this opportunity po. Ang dami kong students ngayon, online ha, like first year, second year, third year, fourth year sa nursing, depressed and diagnosed talaga ng depression by a psychiatrist. So I hope if ever kung may mga kapatid kayo who are having the online platform, mahirap ang online platform. Kasi 'di ba internet ang katapat? Alam niyo ba pag biglang nawala yan sa internet, nagpapanik yan. So pwedeng ma-develop yung mga anxiety attack. If ever kung pagagawan man ako ulit or gagawa ulit ng ng thesis, gusto ko yung effects ng talaga ng let's say internet connection sa anxiety. Kasi ang dami pong nagpapanik ngayon pag nawala during discussion, 'di ba? Yung mga ganun na mga moments po. So, yeah. My heart really goes sa mga tao na talaga na diagnosed ng depression po. Madami mga estudyante ngayon, like sobrang dami. Walang pili, babae, lalaki. Yung iba nga nagkaroon ng general anxiety disorder, no? So next, you have the putrefaction. Now, when we say putrefaction, this means the bloating. Okay, this is the bloating. Ayan, ng patient po natin. So pag sinabi po nating bloating, 'di ba? Yung edematous po yung patient po natin. Ayan, and that's the putrefaction. Ayan, pa-mute na lang po muna ha. And then lastly, we have the decomposition. Sabay-sabay nga po tayo. Everybody say decomposition.
Decomposition.
Ayan, with your decomposition, expected po na may foul smelling. Siyempre, nag-decompose na kasi. Siyempre, so signs of death na yon. But if ever kung may friend ka na mabaho lang talaga siya, tanungin mo, nag-40 days ka na ba, friend? Grabe. Or baka nakalimutan niya lang kasi, na-drop niya lang kasi yung hygiene niya. Kaya yun. Sige po, so again, ulitin ko lang. These are the signs of death. We have the rigor, algor, livor. Siyempre, walang Edgar Mortis. Director kasi yon. So we have the rigor, algor, livor, mortis. We have the putrefaction and decomposition. So these are the signs of death. Aside from that, stops kasi yon. So we have your letter S. If the scene is unsafe. Guys, if the scene is not safe anymore, you need to stop high-quality chest compression. So, nakompleto ba natin ang mnemonic na stops? Yes or no? Sige nga, sabay-sabay tayo. Ayan, ano nga yung letter S natin? If there will be what? Spontaneous return of circulation. Great. Thank you, ma'am. Next, we have your letter T. Turn over to?
911.
911. Thank you so much. Letter O.
Overexhaustion.
Ayan, if meron tayong over-exhaustion, your letter P, if the or our lovely doctors assumes responsibility po. And lastly, guys, we have your letter N. If the scene is unsafe. Tama po? Ayan, sige. So, wait lang ha. Maipapakita ako to summarize everything po. Ayan, para review na po ito. Kasi right after this, you'll be having the the post-test na po. Full volume tayo, please.
Once you start CPR, you want to really make it count because patients are much more likely to survive if you perform high-quality CPR than if you perform poor-quality CPR. There are 5 major determinants of CPR quality, which we're going to discuss in some detail. The first is the rate of compressions. 100 to 120 is the rate that every rescuer should be aiming for. 2 is adequate compression depth. We want to go about 2 to 2.5 inches or 4 to 5 centimeters. 3 is continuity. You should be performing CPR for a minimum of 60% of your total resuscitation time, if not more. 4th is chest wall recoil. That's diastole in cardiac arrest, and that's what allows the heart to refill. So we want to make sure that we allow the chest to recoil so the heart can fill normally, making each compression count. And last is hyperventilation. Hyperinflating the lungs decreases cardiac output and is another variable that produces adverse outcomes in cardiac arrest. So let's start with compression rate. There have been a number of studies looking at rate, and this is one example. In this study, they looked at the mean rate of chest compressions among a large sample of cardiac arrest patients, and they found that the patients who had compressions at a rate of roughly 100 to 120 had the highest probability of ROSCE, which stands for return of spontaneous circulation, and they also had the highest probability of survival to hospital discharge, or having a longer-term positive outcome. So 100 to 120 is the rate you want to go for, and there's actual science showing us that patients are more likely to survive when we use that rate. Compression depth, we have a similar study looking at depth as an isolated variable. Again, for patients getting return of spontaneous circulation back, the optimal compression depth was just under 5 centimeters. And same thing for survival to hospital discharge. The optimal compression depth was just a little bit over 5 centimeters. And what they found in general is that any compression depth over about 4 centimeters or 38 millimeters produced an odds ratio of 1.91 of survival to hospital discharge, meaning that if you have compressions of greater than 38 millimeters across the board, you're twice as likely to survive. So it's a really important variable and a really easy one to optimize. This graph is about chest compression fraction. So in this study, they looked at the percentage of time in the overall cardiac arrest that the patient had active chest compressions being performed. And they stratified according to the percentage. So 0 to 20, 20 to 40, 40 to 60, et cetera. And they found, not surprisingly, a linear increase in the likelihood of return of spontaneous circulation as the chest compression fraction increased. So if you spend more time during the code performing CPR, you're going to get a better outcome and a higher probability of survival. This is the same data, but this is actually a survival curve rather than the group stratified data. And once again, chest compression fraction of 0.8, 0.9, or 80 to 90% of the time produce the highest likelihood of return of spontaneous circulation. In another study looking at chest compression fraction, the outcomes were a little bit different. In this study, they found that actually a 60 to 80% chest compression fraction produced the highest odds ratio of survival to hospital discharge, and that's what the current guideline recommends. So you want to be at a minimum of 60%, ideally closer to the 80% range for your chest compression fraction. The bottom line, though, is you're clearly never going to know numerically what your fraction is during the course of a resuscitation. You just want to make sure that your CPR is as continuous and uninterrupted as you can possibly make it. So chest wall recoil is a physiologically important variable, but there's actually no human studies on it that demonstrate improved survival because it's kind of a difficult phenomenon to study. But basically, the idea is if you lean on the chest in between compressions, you're going to increase the patient's inner thoracic pressure, right? You're smashing down on the chest, so that's going to raise the inner thoracic pressure. Well, we all know that positive pressure ventilation also raises the inner thoracic pressure. So if you cram more air into the lungs, you're going to raise the thoracic pressure. And the bottom line, what brings blood back into the heart during diastole? It's negative inner thoracic pressure, right? It's that negative pressure gradient that pulls blood from the periphery back up to the heart. So if you raise the inner thoracic pressure and make it not negative, you're going to prevent the heart from filling, and you're going to decrease your cardiac output by decreasing your stroke volume. The ultimate effect, again, is going to be impaired cardiac output, and that means less blood flow to the heart itself, less blood flow to the brain, and less likelihood of spontaneous circulation. So bottom line, high quality CPR is what you need to do to optimize your chances of survival. And the determinants, once again, are push hard, 4 to 5 centimeters, push fast, 100 to 120 compressions per minute, keep it going. You want to make sure your chest compression fraction is a minimum of 60%, if not more, during the course of the arrest. And avoid hyperventilation and chest wall leaning. If you do those 5 things, you're going to increase your patient's odds of survival. So, once you have really good quality CPR going, what's the next question you need to answer? You've already decided your patient is pulseless. You've already initiated compressions. What do you need to know now? The answer is, of course, what is the cardiac rhythm? And specifically, is it a rhythm that we can treat with electricity? Is it a shockable rhythm? So, shockable rhythms, like we said before, are more likely to survive. Patients who can be shocked are more likely to live through a cardiac arrest. But defibrillation is a very time-sensitive intervention, meaning the faster you do it, the more likely it is that your patient's going to benefit from it. So for shockable rhythms, we consider defibrillation to be more important than anything else you can do, more important than CPR, more important than ventilation, more important than drugs or IV access. It is the single most important thing that you can do. So if you have a shockable rhythm, you need to know early and you need to treat it early. Here's one of our shockable rhythms. This is ventricular fibrillation. It's very easy to identify. It's randomly fluctuating. It goes up and down. There's no pattern. There's no rhyme and reason. There's no QRS complexes. It's just a disorganized squiggle. The second one is ventricular tachycardia. Now, in VTach, there actually is organization to the QRS complexes, but they're wide and bizarre looking. So anytime you have a fast rhythm with wide QRS complexes, you should suspect that to be ventricular tachycardia. And by the way, these are the 2 rhythms that the automated defibrillators that you see in public places are looking for when they determine whether or not a patient should be shocked in cardiac arrest. So why do we only shock VFib and VTach? This frustrates a lot of students because you see on TV, everybody in cardiac arrest gets shocked and they all jump up and come right back to life, right? Well, it doesn't work that way in the real world because the whole goal of using electricity is to reorganize a rhythm that is disorganized. Now, when you are in a non-shockable rhythm like PEA, you have some major problems on the table, but electrical disorganization is not one of them. It's not an issue for patients in non-shockable rhythms. And at best, if you go and shock a non-shockable rhythm, nothing will happen. At worst, you could potentially hit the patient at the wrong point in the cardiac cycle, cause an R-on-T phenomenon, and ultimately precipitate a dysrhythmia like ventricular fibrillation. So the last thing you want to do in a cardiac arrest is take somebody who has a normal rhythm and turn it into VFib. That's clearly not benefiting anybody. So we don't perform defibrillation for any rhythm except our 2 shockable rhythms, VFib and VTach. I mentioned before that defibrillation is a time-sensitive intervention, and this graph clearly shows why. So as you can see, the more time that elapses as we move along the axis there, the lower the likelihood of survival for the patient. So for patients in shockable rhythms who are getting shocked within the first minute, you can see 35–40% of those patients are surviving. But by the time we get out to 6 minutes, it's less than 20% of the patients surviving. So we really want to make sure that as soon as we're humanly able to do so, we assess the rhythm and we defibrillate if we identify a shockable rhythm. Again, short time to defibrillation, high likelihood of survival. And as we go down to 2, 3, 4, 5, 6, and more than 6 minutes, you can see that the odds ratio, or the likelihood that the patient is going to survive the event, goes down consistently with every minute that passes. It's really key to do this quickly. All right. Now, once you've gotten your high-quality CPR going and you've assessed your rhythm and defibrillated if it's indicated, what do you want to do next? Well, this is when you can start thinking about respiratory support for your patient. So you can initiate bag valve ventilation in order to give your patient some oxygenation. You want to also coordinate your chest compressions with your breathing. So you're going to do 30 compressions followed by 2 breaths, 30 compressions followed by 2 breaths. You also, if you're in a hospital setting, are going to establish vascular access, and you're going to continue reassessing the rhythm every 5 cycles or 2 minutes for the duration of the resuscitation. Now, a lot of students ask me, Dr. Young, this is all great, but this is like basic stuff, right? What about the cool stuff like putting in airways and pushing drugs? Well, unfortunately, advanced interventions in cardiac arrest don't really make much of a difference. This is a study that came out of Scandinavia that really showed whether you're performing basic life support or advanced life support, your outcomes are very similar. So in these 2 cases, you can see the red line represents patients who got no IV access, no IV drugs, and no advanced airway interventions. And the green line represents patients that did receive those interventions. And you can see how very similar the outcomes for both groups were. So bottom line is that CPR and defibrillation is by far the most important element of your resuscitation. And all the advanced stuff really doesn't make as much of a difference as we'd like. So let's get back to our case. So we have our 58-year-old guy who collapsed at a sporting event. What are we going to do for him? Well, like we already said, 1, we're going to call for help as quickly as we can. 2, we're going to think CAB, so we're going to go to him and we're going to decide whether or not he's got a carotid pulse. If he doesn't, we're going to go ahead and initiate chest compressions. And then once we can get access to a defibrillator, which hopefully at a sporting event would be pretty quickly, we're going to put it on, assess the rhythm, and defibrillate if, of course, it's indicated.
Okay, so that ends our first part ng ating BLS. So guys, right after this, you'll be having the ano na po. We'll give you time para mag-aral like 5 minutes ba? Or basta isi-send na po namin yung link dito sa chat box po natin. Ma'am Joy, start na po sila ng ating post-test, ma'am.
Yes, madam. I-send po sa chat box yung
Yes,
BLS.
ma'am. So, I'll see you na lang, ma'am, sa ano po, 1 o'clock sa ating first aid.
Yes.
Thank you so much.
Thank you, madam. Excuse me po, sir.
Yes, ma'am.
Sir, ang ano po kasi ang sabi po sa amin, pag BLS lang daw po, sir, 8 to 12 lang po.
Okay. So, wala nang ano, walang, yeah.
Ano,
Okay,
sir?
okay. Sige po, ma'am.
Thank you po.
Ilan kayo, ma'am? Ilan kayo lahat, Miss Rina?
Ako lang po, sir. Sa ano po kasi ako, sir, sa lying in po. From
Okay.
Camp-Sir po.
Sige pa, on po ng mga cameras po nila. Mag-group picture tayo para masama po natin si Ma'am Rina. Ayan, group picture tayo, guys. On ng mga cameras. Tapos, syempre, pwede din kayo mag-screenshot dyan. Tapos, i-upload nyo sa Facebook nyo. Para sabihin ng friend nyo, ay, nag-update siya. Ay, matalino siya. Dagdag ano yon, plus points sa atin. Wait lang ha. Pa-on ng mga videos po nila. Ng mga cameras. Sige, at the count of 3. 1, 2, 3. Smile. Isa pa. Yung iba humabol. Habol na kayo, guys. Libre lang naman yung mga mukha po natin eh. Sige, 1. Ayun si Dr. Kope. Hello, Dr. Kope. Magandang umaga. 1, 2, 3. Smile. Thank you so much sa mga nag-BLS only. Na I hope na may mga na-learn po tayo ng mga bago today. Okay? Ingat po. And then get ready na po sa ating exam. I guess na-send na po yung BLS exam po natin. Good luck po.
Okay din po, sir.
Yes po, nasend na po yung BLS exam link. Paki-save na lang po nung link kasi pag nag-leave po kayo or na-disconnect po kayo sa Zoom, mawawala po yung previous conversation. So, paki-save na lang po yung Zoom link. And dun po sa mga BLS only, and after the exam po, pwede na kayong mag-leave. Pero if you want to extend or avail first aid or attend first aid and ACLS, pwede naman po kayo mag-attend until tomorrow. Wala po yung additional fees, pero wala lang po kayo makukuhang certificates. At least may nakuha po Yan, sa mga nagtatanong po, kung gusto po nilang mag-attend sa ating first aid, kahit hindi po sila enrolled, pwede po kayong mag-attend, wala lang po kayong makukuhang certificates for your accreditations. Yan. If you have any questions po, you can ask now po regarding yung certificates and the training program.
Ma'am, paano po namin makukuha yung certificate po, ma'am?
Yes po. Hiningan na po ba kayo ng admin ng name and email?
Opo.
Opo. Doon po sa pre-provide nyo pong name, training, and email address, i-email po sa inyo yung certificates and IDs. Ang kasama po sa package nyo is digital copy of your certs and IDs. So, i-email po yun sa inyo after the training po. Pero kung wala po kayong ma-receive na certificates after the training, kindly message our page po kasi minsan po nai-spam na po kami sa Google dahil sa sobrang messages or emails.
Okay po, ma'am. Thank you po.
Yan. Kung hindi pa po kayo nakakasend ng name, pa-chat na lang po sa chat box ng full name nyo, yung training nyo po, and yung email address nyo po. Sa magtatanong po kung paano po kung gustong mag-avail ng hard copy ng ating IDs, meron lang po tayong additional fee na 200 pesos po. Pero free shipping na po yun nationwide for your hard copy of your certificates and IDs. Pwede naman po yun to follow kung kailan you need yung hard copy. At least 6 months after the training. Dito po, Ma'am Rama Ruth, dito nyo po i-message po yung name nyo po sa Facebook, ay sa Zoom chat box po. Nag-send po ako ng sample. Ganyan po yung isasend nyo po sa chat box. Kung saan po i-email yung mga certificates nyo po. Or pwede naman po kayo sa Facebook mag-chat ng details nyo po. Kailan nyo po marireceive yung digital copy ng certificates nyo po and yung mga OR nyo po? After the training po, probably Sunday evening or Monday morning. Yes po, pero dapat po fully paid po kayo bago namin po ma-release yung certificates and IDs nyo po. Yes, ma'am, pwede nyo na po ngayon isend yung mga details nyo po. Pero lalong-lalo na po yung mga BLS only, dapat po ma-send po yung details nila and matapos po yung exam. Tapos kung ayaw na po nilang mag-attend ng ACLS, pwede na po Noted, Miss Loiza. Tama po yan. Please double check your spelling po ng mga names po natin for your certificates and your IDs. So if you don't have any questions po, you can take your BLS exam, have your lunch, and see you at 1 p.m. Thank you so much po. See you at 1 p.m.
Excuse me po. Excuse po.
Hi, good afternoon. Pa-on na po ng mga videos po nila for we are about to start na po. Okay, for this afternoon sessions po, we'll be having the basic na first aid po natin. Let's have the ano po muna, the introductory video po ng ating first aid. Okay, so good afternoon everyone. I am Mark Adlawan, no? Ako pa rin yung instructor po. Ayan, for the BLS and first aid and your ACLS. Yung ACLS po natin na magsa-start po siguro mga 3 o'clock. So if you have friends po na gusto pang humabol, ayan. And then for those na are BLS only, pwede naman po na mag-join din na up to your ACLS. However, wala nga lang kayong certificate. Na pero if you want to avail, na pwede naman pong i-contact talaga na ang ating WePump. Okay po, yung admin po natin, and of course si Ma'am Joy, which is the owner po no, ng ating WePump training center. All right. Now let's begin na po. So we have the importance of the first aid. Sabi nga kasi doon no, sa video po natin, no, first aid saves lives po. Whether kilala nyo ba, na whether hindi po natin kilala. Now, when we talk of first aid, everybody say first aid.
First aid.
Great, ma'am. This is actually the initial na assistance po na pwede po nating maibigay sa isang sa isang tao. Whether kilala nyo, whether hindi po natin kilala. Now, with that, initial assistance, whether injured ba no, ang taong yon, or aside from being injured, pwede rin kasing unwell. Now, when we talk of injury kasi, yung iba very obvious yung mga injuries po nila. Yung iba naman biglang nahihimatay. So basically they are not healthy, no, or feeling nila they're not okay, no, at that very moment po. So pwedeng unwell po sila. With that, feeling na unwell po, pwede kasi mga warning signs of heart attack, na pwedeng baka no, anytime soon baka ma-stroke ang patient po natin, or that can be na yung cool clammy skin po ng patient po natin, that can be a warning sign na baka may made-develop po na shock sa patient po natin. So again, the basic importance po na tinatawag na first aid is this is actually an initial assistance na to those who are injured and to those who are unwell in nature. Now, sir, ano ba ang priorities po natin when we talk of first aid? Sulat ko lang ha. So we have the priorities po natin. So first priority natin guys, and that is to preserve life. Because we value life na number 1, to preserve life. Aside from preserving life, na we need to alleviate suffering. Ayan, we need to alleviate suffering. Like for example, no, sa hospital po, 'di ba? We don't want the patient let's say to feel na parang neglected sila. Ayaw din natin na makaka-feel ang patient po ng intense pain. Ayaw natin yon. So we need to alleviate suffering. Even nga, 'di ba, up to na lang na mamatay ang patient po natin, it should always be a painless death dapat. Okay po? Kasi yun yung goal natin eh. And that is to assist, di ba, the patient towards a peaceful death. However kasi, kaya nga tayo may first aid para hindi po mamatay ang patient natin. Again, this is the initial assistance for those who are injured and for those who are unwell. And again, second priority will be to alleviate suffering. Now, aside from alleviating suffering, guys, this is to prevent worsening the condition. Ayan, to prevent the worsening, the worsening of the condition of your patient. Let's say, di ba, what if may mga warning signs ng stroke ang patient po natin? So like for example, yung facial droop, di ba, nagsag bigla ang kanyang face. So kailangan mag-start na dapat ng mga stroke, immediate stroke management. And that is to prevent the occurrence because time is critical here. Like for example, biglang may nag-bleed na patient. Ang pinakadelikado kasi pag nag-bleed si patient, guys, what if hindi po natin, let's say, nag-apply ng proper pressure, then from bleeding po pwedeng magkaroon ng hypovolemic shock ang patient natin. So from a very minor one, biglang naging major na problem po. From a very mild, na problem, baka biglang maging severe po yan. Like in the case of allergic reaction. Kasi meron tayo, di ba? There's a big difference between an allergy from an anaphylactic reaction. Kasi allergy is kind of simple lang. It's mild. Pero pag sinabi po nating anaphylaxis, that can lead to anaphylactic shock. Na kung saan hindi na po makakahinga ang patient po natin. Kaya delikado po yan. So again, the purpose ng tinatawag na first aid natin is to what? No, to prevent the worsening of the said condition. Now, aside from that, aside from preventing the worsening of the said condition, we need to promote recovery. Ayan, we need to promote recovery po. Guys, everybody say recovery.
Recovery.
Thank you so much. Part of the discussion later will be your hypoglycemic episodes. Let's say you're going to treat na patient suffering from hypoglycemia. So meaning to say, we need to promote recovery. Like for example, after drinking yung let's say mga colas, orange juice, let's say honey, then you need to assess the patient towards a parang syempre comfortable position po natin. Hindi lamang nung start ka, dapat up to finish din. So we need to promote recovery, which is very important. Okay po? So again, here are the priorities po in dealing with first aid. Again, we are following the American Heart Association Heart Saver First Aid po natin. And of course, in partnership with Red Cross din, na first aid. So again, number one, we need to preserve life. Next, you need to alleviate suffering of the patient. Next, we need to prevent the worsening of the said condition. And lastly, we need to promote recovery. Na yun yung pinaka-goal talaga natin. Now, before I begin, formally begin with our topic, guys, ayan, may mga kasi tayo. Let's say may mga spill kasi tayo. Like for example, my name, is ganito. I'm, a trained, ayan, I'm a trained, or I am trained. Na I am trained. Ayan, sulat natin. I am trained in first aid. So pwedeng, my name is Mark Adlawan. Na I am trained, in first aid. So in approaching a patient, ganun talaga. Pero before ka po na mag-introduce ng sarili mo, ayan, you always determine for safety. Because safety is always our priority here. Yung iba kasi nag-i-introduce na lang agad-agad, tapos without even looking, na Diyos ko yung kalaban pala, 'di ba? Nasa environment po natin, nasa surrounding po natin. No, yung tipong my name is ganito, boom, bigla kang binaril. Kasi yung may gunshot pala, 'di ba? May kalaban pala. And then syempre ikaw, threat ka na po din sa kalaban kasi syempre 'di ba gagamutin mo kasi eh. Na? So meaning, no, we always determine, for scene safety. Guys, sa lahat ng sa lahat ng oras, scene safety. No, hindi lamang yan sa BLS. Okay po? No, kahit sa first aid, you always determine for safety by checking for hazards, 'di ba? You look up and down. You look for what? No, let's say mga pointed objects, mga sharp objects before ka mag-approach kay patient. You need to look also and determine for poisonous na mga fumes, na mga gases natin. And then of course, yung mga let's say baka yung tao, no? Baka pwede kang atakihin bigla ng tao na yon, no? What if sa scenario, may mga nagdadala ng, let's say, ng mga patalim, no? Bigla kang na-stab bigla or bigla kang barilin. So you always think na ano po, na think outside the box kasi dapat, no? Dapat safety dapat, na check for hazards. If ever kung safe naman po ang environment, then that's the time magpakilala po tayo. My name's Mark Adlawan. I am trained, okay? I am in, okay, what? Na first aid po. How can I help you? If ever, kung sinabi ng client mo, guys, na ayoko ng help, are you going to respect that? Yes or no? Anyone from the group? Pag sinabi niya ayoko ng help, guys, anong gagawin mo? Ganito yan. If ever kung ayaw niya ng help, okay, no? You need to understand na naayaw na ng help, no? Pero pwede kang mag-activate pa rin. Let's say you call 911. Sa amin kasi dito sa Davao, agad-agad call 911. Na pag may mga aksidente, call 911. Sa inyo, of course, if ever, no, yun lang problema. Pag walang 911, saan tayo tatawag? If ever kung may malapit po na barangay, 'di ba? Pwede po lumapit sa barangay or sa pinaka-nearest na station. Yun yung pinaka-importante. Ang importante po ay ma-activate po natin. Kung ayaw niya ng help, and that's okay. Because always remember, guys, part po ng patient's bill of rights po natin, the patient has the right to refuse treatment. Kung ayaw niya, pues, sige, ayaw niya talaga. Sometimes kasi sa states po, na sa United States, meron kasi mga tinatawag na mga medical, okay, jewelry, na tinatawag. Pag madami, jewels, na. Guys, wala kasing word na jewelries ha. It should be jewels, na. Walang jewelries. Tulad ng rashes, walang word na rashes. Rash lang, okay? Walang rashes. It should be rash all over the skin of the patient. Because we will be discussing also yung mga allergic reactions po natin. Meron kasi mga medical, okay, jewels, okay, ang client, no? Pag nasa States, pwedeng may mga necklace, no? May nakalagay sakit niya, na pwede rin po na the medical bracelet na may sakit, na kasi may mga may mga clients, may mga friends ako na may mga patients sila na may mga medical bracelet, and nakita ko amazing. Yung iba like mga gold pa, no? Ewan ko ba, ang ano lang, na ang weird lang. Pero yeah, for me kasi for safety, kailangan talaga may ganon. Para in case po na bigla silang naging unconscious, no, tignan mo lang ang bracelet, ano nakalagay? Okay, diabetic pala ang patient natin. Na? Or let's say, meron nga akong nabasa na article, nangyari to sa Europe. They're about to na po sila, about to give compressions kasi biglang naging unconscious si client. Buti na lang, no? At inopen po, let's say inopen nila ang kanyang polo. Tas alam niyo ba kung anong nakalagay sa chest po ng patient? Do not resuscitate. DNR. Buti na lang talaga. Kasi if ever kung nag-resuscitate po sila, guys, anong mangyayari? Pwede po silang isu ng patient na yon. And amazing lang kasi hindi po siya medical na necklace, but rather pinatattoo niya talaga na sa kanyang chest, do not resuscitate. Doon ako parang okay, na may mga may mga countries pala na okay pala magpatattoo ng do not resuscitate. Siyempre, yung mga nagdo not resuscitate kasi ayaw na talaga nila. Na parang they are just enjoying their lives na lang po. Na if ever man, kung darating na yung point na mamamatay sila, na do not prolong their pain, do not prolong their agony. But then again, di ba by nature kasi and by definition, guys, if ever you will be dealing with DNR, na pwede bang magbigay ng pain meds? Yes, pwede po. Kasi di ba by definition, it should always be a painless death dapat kay patient. Pero pag sinabi mong mga, let's say, yung mga emergency drugs, bawal yon sa kanila. Only mga pain medications ang pwede para painless death. Meaning to say, na to die with dignity kasi ang pinaka-best na when you talk of death na sa isang patient. So again, my name's Mark Adlawan and I am trained in first aid po. So ganon. Once na-determine na po natin ang tinatawag na scene, safety. Let's proceed sa ating next, slide. Now, always remember guys, na in saving, lives kasi, we don't need, licenses for that. Ang importante, if you're just trained na sa tinatawag na first aid, then walang problema yon. Yung iba kasi, na they really thought na ano po, pag first aid, kailangan first aider, kailangan may certificate. No. As long as you are trained, no need na ano, let's say nakatapos ng 4-year course, no need. Na walang problema yan. Ang importante, trained po tayo, okay, ng first aid. Then, okay, you can approach a victim. You can approach a patient. Yung iba, sir, na elementary graduate ako, sir, kaya I'm not capable of ano po, rendering, okay, first aid. Mali yun. As long as, okay, trained ka, either Red Cross, either American Heart, na either American Safety and Health Institute, no, wala pong problema doon. Now, in saving lives, guys, usually kasi, na ang dapat nating i-emphasize dito will be the rescuer, okay, and victim safety. Sulat ko ha. So we have the rescuer and victim safety. Ikaw ba yung rescuer? Yes. Ikaw ba yung first aider? Yes. So ang tawag sa'yo, rescuer. Next, we have the patient's, okay, safety, or basically the victim safety. Now, sir, paano ba natin i-discuss ang rescuer and victim safety? Number one consideration, guys, you need to ask na pwedeng i-ask mo sa sarili mo, is there danger, okay, from the rescuer? Ayan. Do you think may danger ba? Saan, sir? From the rescuer, meron po ba? May mga hazards po ba? Okay, from the rescuer? If none, then push. Na? Diretso tayo. Next, is there any danger, sir? Okay, from the victim? Kasi if yes, na, then do not start. 'Di ba? Kasi since safety will always be our priority. Ulitin ko lang. On the part of the rescuer, if ever kung may mga hazards, do not perform first aid. Now, for the victim naman po, if ever kung may mga hazards tayo, then do not, okay, perform, okay, first aid. Kasi, na, ayan, double jeopardy, di ba? Doble lang po ang magkakaroon ng casualty. Now, aside from, okay, what? Na, aside from determining kung may mga danger ba from the rescuer, danger ba, okay, from the victim, now, ayan, are others, okay, around to help? Are others, ayan, inside, okay, or let's say, now within the said scenario, around to help? Are others, okay, around to help? Kasi if ever, kung willing naman silang tumulong, edi mas mapapa-okay po yung first aid po natin. Pero nung inutusan mo, no, na let's say you call 911 pero ayaw pa rin nila, yun yung problema. No? Nakichismis lang po ang mga tao na nandun. And ayaw natin yon, na kasi of course na-prolong kasi ang agony. What if nagbi-bleed ang client? 'Di ba? So mas lalo siyang magbi-bleed, mas lalo po siyang okay, hindi magiging okay. So mas delikado 'yun kay patient. Now, aside from that, you need to ask also how many people were injured. How many, ayan, people, okay, were, ayan, injured po. Ayan, so you need to ask, 'di ba? Pwedeng i-ask mo sa sarili mo or pwedeng i-ask mo mismo sa naka-witness. How many people were injured? Okay? Kasi meaning to say you need to assess talaga na holistically. 'Di ba? Pag sinabi kong holistically, the sum is greater than the whole of its parts. Na ayan, or basically mas importante talaga yung kabuuan. Na so aside from how many people were injured, guys, ayan, you need to ask also, no, how were they injured? Ayan, how, ayan, were, ayan, they, okay, injured po. Ayan, or basically the whole is greater than the sum of its parts na. Ayan, sorry. It should be the whole is greater than the sum of its parts. Kaya nga, no, holistic dapat yung approach po natin. Kasi, ayan, na think of the bigger picture dapat. Okay? So we have how, okay, were they injured po? Now, aside from how were they, okay, injured, is it from fall ba? Kasi usually pag fall, na, we always suspect for spinal cord injury. Guys, everybody say fall.
All.
Ayun yung dog yung nag-participate na. Ayan. So pag sinabi po nating fall, saan kaya nahuhulog ang tao? Sa pader or sa maling tao?
Sa maling tao.
Awit na naman. Sa maling tao na naman.
Sa maling tao.
Pag maling tao, guys, mahirap pong i-first aid yan. Diyos ko po. na wala pong gamot diyan, 'di ba? Kahit limot ay hindi mo kayang magawa, no? And for life po pag nahulog po tayo sa maling tao. Ayan. If ever man kung magmamahal man ako ulit, sure ako na dapat nasa tamang tao na. So we have our A, B, C. Ayan, letter E. Now, where is the nearest telephone? You need to consider this also. Where, okay, is the nearest, ayan, nearest, okay, telephone. Wait lang ha, isulat ko lang. The nearest, ayan, okay, phone. Why? Kasi pwede po nating utusan yung iba na, ma'am, pwede ka pong tumawag ng 911, 'di ba? You need to activate po the emergency response system. And then lastly, letter F. Ayan. What is your location? What is your location? Kasi paano ka magsusumbong, 'di ba? Tatawag ka ng 911. Ni ikaw mismo hindi mo alam kung nasaan ka. Okay po? Ayan, alangan naman sabihin mo, basta ma'am, malapit po ako sa sari-sari store, no? Andito po ako sa daan ngayon, ma'am, no? Na marami pong mga jeepney dumadaan, no? Diyos ko po, you need to tell us the exact location, na? Kasi usually guys, no, ang tanong ng mga dispatcher, let's say sa mga taga 911, no? Ayan, kunwari tumawag ka, no? 911, speaking, tanong ng 911 ganito, is the patient conscious? Is the patient breathing? Na? Did you perform already your high quality chest compression? Ayan. Do you have your AEDs with you? Na? Pero before kasi tatanungin kung conscious, breathing, CPR, na, AED, tatanungin nila, what's your name? Na? Where is your exact location? Kaya again, importante din po na malaman natin na kung saan ba, na, saan ka ba located ngayon. Now, aside from that, na, aside from, 'di ba, let's say, no, yung rescuer and victim safety guys, by asking, no, may danger ba from the rescuer, may danger ba from the victim, or others around to help, no? Kung sa community mo ba willing sila? How many people were injured? How were they injured, na? Where is the nearest telephone and what is your location? Yun yung mga primary natin na dapat malaman as a first aider. Now next guys, we'll be finding the problem na po. Ayan, finding. Ayan, the problem. Now guys, in finding kasi na the problem is that number one, you always check na naman na for scene safety. Just ko masusuka po tayo sa word na scene safety mamaya. No? Starting now, always scene safety. Next, you always check, okay, for responsiveness. Na, by tapping, 'di ba? Sir, na. Ayan, I am Mark Adlawan and I am a trained na ayan personnel, okay, with na let's say first aid na. Sir, can you hear me? Ayan, sir, I am willing to help. If ever po the patient okay responds, kunwari lang nag-respond. Pwede rin kasing unresponsive patient. So we have our patient okay responds na, or pwedeng responsive, isulat mo. So pwede pong responsive ang patient mo, or pwedeng okay responsive si patient po natin. If ever po nung sinabi mo, I am Mark Adlawan and I am trained okay in first aid. Now, if the patient is responsive, meaning to say nakakapagsalita ang patient mo, you ask the patient, ma'am or sir, can I help? If sinabi niya po, no, I can handle this, then it's okay. Kasi pag pinilit mo pa ang what guys, no, yung help mo, anong mangyayari? Ha? Anong mangyayari? Pwede kanyang kasuhan. Kasi walang consent coming from the patient. Na pwede kang kasuhan, na ang daming pwedeng ikaso sa iyo, 'di ba? Ayan, na so aside from okay, 'di ba? If the patient okay sumagot siya, yes, na you can. Then you ask, ma'am, what is the problem? Sabi niya, I feel dizzy right now, na and then wala pa kasi akong kain, ma'am or sir. Na meaning to say, okay, na ma'am, may mga history po ba tayo, ma'am? Ano po yung sakit po natin, ma'am? Sinabi niya, sir, ma-diabetes kasi ako, sir. Okay? Hypogly ang patient natin. When we say hypoglycemia kasi, bumaba po ang sugar level. Because 'di ba the normal sugar level should be 70 to 110. Ito yung normal, 'di ba? Blood serum, okay, glucose po natin, 70 to 110. Usually kasi pag less than 70, na, ayan, yung ibang patient diyan ay nanghihina na po. Na pero pag mga severe hypoglycemia talaga, like let's say no less than 40 na talaga, delikado na 'yan. Ano ba ang pinaka-problem natin pag may diabetes mellitus ka? Is it ang pagtaas ng sugar mo or ang pagbaba ng sugar mo? Anyone from the group? Anong mas pinaka nakakatakot, guys? Hypoglycemia or hyperglycemia? It's the what? Although both naman kasi delikado. Pero kasi if you are hypoglycemic, that leads to what? Irreversible brain damage. So you cannot shout, 'di ba, for help. Kaya nga yung iba, bakit siya comatose? Kaya nga 'di ba yung sa ER po, na pinapakunan agad ng mga magagaling natin ng mga doctors na, wait lang, bakit unresponsive 'yan? Kunan niyo nga ng ng HGT, kunan niyo nga ng blood sugar level, Diyos ko, no? Less than 20, 'di ba? Less than 10 na lang, naggrabe no ang kanyang hypoglycemia. Kaya that leads to irreversible brain damage po. Now, aside from, no, what if naman the patient is unresponsive? Guys, everybody say unresponsive.
Unresponsive.
Ayan, if the patient is unresponsive daw or does not respond, now we need to phone for help. Okay po? Ayan, the first aid approach to ha, the first aid approach. Next, you need to open the airway. However, kasi that opening of the airway is controversial, lalo na in the event of your COVID pandemic. We need to limit exposure. So again, this is based on, this is actually depende yan sa inyo if you want to open the airway. Now, how do we open an airway? And that's where the head tilt, chin lift. Diba? We have where the head tilt, ayan, chin, head tilt, okay, chin, okay, lift. When we say head tilt, chin lift, guys, if ever kung magli-lift kayo ng chin ng patient, huwag ganito, mali yan. Look at me sa video nyo. Guys, if you're going to lift na tapos mag-add ka ng pressure dito, you're obstructing, okay, further, okay, the airway of the patient. Dapat chin talaga. You lift the chin. Kaya nga head tilt, chin lift. Walang sinabi na dito. No, mas worse kung sa may throat na area. You're blocking the airway. Now, ano bang purpose ng tinatawag na opening the airway? That is to check for, diba, the patency, to maintain patency ng airway po natin. Kasi guys, if you are not going to lift the chin of the patient, yung tongue mo mismo magfo-fall backwards. If your tongue will fall backwards, meaning nasa baba siya, further causing an obstruction. So therefore, to maintain an airway patency, you need to prevent, diba, yung tongue mo para mag-fall backwards by lifting the chin. And that's where the head tilt, okay, chin lift po natin. Now, aside from that, you need to check, okay, for normal breathing. You check for normal breathing. Kasi sometimes yung may mga obstruction po, medyo noisy po ang kanilang breathing. Usually baka may stridor ang patient natin. Na aside from that, you need to look for bleeding. Kasi bakit unresponsive ang patient mo? Guys, you need to look for bleeding ha. You need to watch out for bleeding. Pwedeng, okay, baka may bleed at the back of the head, at the back of the neck of the patient, or let's say mismo sa likod ng patient natin. Kaya you always look for signs of bleeding. Now, how will I know, sir? Even without checking ha, kunwari ayaw mo mag-check. Magulat ka na lang bakit mabilis ang pagtibok ng puso ng patient. Tachycardia will always be the first sign of bleeding. May I just remind you that vital signs is really, okay, what? Vital, and they are really essential and they are important. Okay po? Now, aside from that, since they are unresponsive, they cannot talk, they cannot do the conversation, so you need to look for medical, jewelry po natin. Look for, medical, jewelry. Ang term kasi nila is the medical jewelry. Ano yung mga example, okay, ng medical, okay, jewelry po natin? So number 1, we have the medical, okay, bracelet. Aside from the bracelet, we have the necklace. The necklace po natin. So we have the bracelet and then we have the necklace. And then nakalagay kasi ang what? Ang condition ng patient natin doon. Only if hahanapin mo talaga. But here in the Philippine setting kasi, hindi po uso ang medical bracelet sa atin. Diyan ba sa Bicol, uso ba ang medical bracelet? Sa Manila, uso ba ang medical bracelet? Siyempre wala pa akong wala pa akong naririnig na mandatory na yung mga medical bracelet. Sana pwede naman 'yan 'di ba? Sayang lang din, Sa bagay, mask nga, hindi natin masuot-suot. Medical bracelet pa kaya? Necklace pa kaya? Wedding ring nyo nga, hindi nyo masuot-suot lalo na pag may maganda at gwapo, 'di ba? Medical bracelet pa kaya? Medical necklace pa kaya? So, yeah, Pinoy finest talaga, But I cannot blame you for for doing that. Syempre, tao lang din naman tayo. Okay po? Now, let me, showcase na po, Let's proceed na sa ating, let's say, mga slides. So, as you can see, we have the first aid kit here. Guys, alam niyo ba ang rule ng first aid kit? 1 out, dapat 1 in. Nakuha? Meaning to say, kung ano yung kinuha mo, i-replace mo dapat agad-agad yan. Why? Kasi if you're not going to replace that one at nakalimutan, what if may emergency? Then, you lack already the speed, Kasi you need to act quickly dapat pag may emergency. Paano ka maka-act quickly? Yes, you act quickly. However, kasi kulang-kulang naman lahat ng mga gamit mo. Naalala ko to. Siyempre nag-date kami ng ex ko sa may Sorsogon. Saan nga yung ano nga yung guys, yung mga where villas meet mountains. Ano nga 'yon? Sa may yung kay may kay Heart Evangelista na meron siyang villa doon.
Sir, Hacienda.
Saan ma'am?
Hacienda.
Sa Hacienda del Sol, ayun ba 'yon?
Del Amor.
Del Amor. Oh my God. Naalala ko 'yon, Diyos ko Lord, Ang social lang ng area na 'yon. Tas ang mahal, 'di ba mahal? So syempre si consultant nilibre ako. Syempre mansa rin namin 'yon, Sabi niya mahal, punta tayo ng Hacienda del Ayun ba 'yun ma'am Hacienda del Amor? Ay, yeah.
Yes, sir.
Yes, Hacienda del Amor, So syempre andun na kami. So syempre nagulat ako, sabi ko, oh my God, ang mahal, nasa mga 15 to 20,000 per night, Syempre na-pressure ako bigla. Tapos sabi ko, hati ba tayo? Tapos nung sinabi niyang hindi, sabi ko, oh my God, thank God, at hindi ako makakahati. Paghahatian namin yun, tig 10,000 kami. Sabi ko, Diyos ko, ang dami ko pang mabili sa 10,000. Tapos sabi ko, sige, ilibre na lang kita ng breakfast tomorrow. Tapos alam niyo ba kung saan kami nag-breakfast? Syempre, lumabas kami doon. Ang mahal kasi ng breakfast joke. Pero syempre doon kami, Syempre trinit ko siya. So syempre mura lang ng breakfast. Ang ginastos sa breakfast nasa 500. Sabi ko, wag na tayong masyadong mag-breakfast. Kasi masyadong heavy baka masuka lang tayo. Pero honestly guys, ang mahal ng breakfast. kuripot si Sir Pero grabe, ang ganda lang ng Hacienda del Amor. If ever kung babalik talaga ako doon, yun talaga ang babalikan ko din, Sobrang ganda. Ay, nakakawala ng stress. Yung tipong paglabas mo sa sa villas nyo, may sarili kayong pool, like Bali feels na parang ganon. Ay, na-miss ko talaga yon, Diyos ko. Hindi yung ex ko but rather yung yung feeling talaga sa like sa Sorsogon, sa Bicol, Ayan. So, ayun guys, we have the first aid kit here. Now, with your first aid kit kasi, dapat may checklist po tayo. Ano ba dapat ang inside ng tinatawag na first aid kit po natin? Again kung may kukunin ka, dapat may ibabalik ka din. Okay po. Sa States kasi, mas improvise yung mga first aid kit nila. Why? May mga epinephrine pen. Ang kanilang mga first aid kit. Amazing nga may EpiPen talaga. Kasi EpiPen kasi guys, ito yung mga ina-IM po, lalo na pag may mga allergic reaction si patient po, na EpiPen, yung mga bee stings, 'di ba, etc. So we have the checklist po, check po natin yung mga bandages natin, the skin tape, the triangular bandage, etc. Na yung mga nakikita nyo dyan, they should be present dapat na sa ating, okay, let's say, first aid kit po. Okay po? Ayan, sige. Pwede na ba akong mag-advance? No need for you to copy this. Pwede nyo namang picturean. Pwede nyo namang picturean po. Mr. Ariel Amandi, taga saan ka sa Manila, sir?
Ito po, Quezon City sa may Fairview po.
Sa Farview. Malayo nga. Diba ang tawag nila, sir, it's the Farview, Fairview, Farview. Like parang malapit na kayo sa may sa may NLEX na, tama ba? Diba sa may
Sa
NLEX
may Commonwealth.
Yeah, sa may Commonwealth, no? Na kung saan traffic every day, na from morning okay until gabi traffic pa rin. Dati nagstay din ako sa may Commonwealth na area sa may saan ba 'yon? Basta sa subdivision doon. Sa Pablo, something ganon. Basta, yung bahay nila Jaya at bahay nila Gerald Anderson. Doon banda. Na, syempre sa boss ko. Don Antonio pala. Don Antonio Village po. Doon ako nakatira na, ayan. Pero syempre sa boss ko yon na bahay. Nakitira lang ako guys. Meaning, aliping sa gigilid lang ako doon. So, ayun po, na. So, we have the PPEs, na, or the PPE or the PPD. We don't call that as PPEs kasi equipment lang po ang plural ng equipment, ha? Walang equipments. Mali yung equipments. It should be equipment alone, okay? So, personal protective equipment or the personal protective devices, na, such as yung mga goggles natin, yung mga gloves po natin, na, yung mask po natin. Ito yung mga basic natin na PPE. However, kasi may mga advanced tayo ngayon. Like for example, di ba, dahil meron tayong COVID pandemic po, hindi tayo ang mismo may COVID. Diyos ko Lord, no, nakatakot yon, na. So mas naging advanced na po ang ating PPE, okay, PPDs or PPE. Di ba, we have the bunny suit, na. Meron tayong mga biohazard bags with you, lalo na in case kung may mga tooth injuries, na, or let's say yung mga amputation na pwedeng ilagay, like mga finger amputation, toenails, na pag biglang natanggal po yan, pwede po nating i-wrap, ibalot po, ilagay po sa biohazard bag po natin. They are part pa rin po ng tinatawag na first aid. And of course, no, yung natin, yung gloves natin, pinaka-importante talaga. Why? We need to limit ourselves from being exposed po sa fluids coming from the patient. What if pala ang patient natin na may HIV, 'di ba? Tas hindi ka man lang nag-gloves, no? And what if hindi ka nag-goggles tas biglang nag-spatter ang dugo sa mata mo? So pwede ka pong mahawaan. Again, may mga blood-borne pathogens kasi tayo na we need to consider. Yes, no? They can be prevented, pero like for example, yung HIV, 'di ba? Hepa B, yung mga syphilis, no? Pag if ever kung nasa blood na po natin 'yan, mahirap na talaga, no? Kasi they can be prevented, pero again, no, sad reality, they are incurable. Wala pang gamot sa Hepa B, wala pang gamot sa HIV. Okay, mga blood-borne pathogens ang tawag diyan. Okay, our topics, ayan, na topics pa lang na meaning introduction pa lang po tayo kanina. Wala pa pala yun, sir. Yes, introduction pa lang po yun. So we have the topics, guys. We have the choking problems. We have the bad allergic reactions. Now we have the chest pain, heart attack po natin. Next, we have the fainting. Now, fainting is di ba? The medical term for fainting is what? Syncope. Nahimatay. Next, we have the diabetes po natin. Everybody say diabetes.
Diabetes.
Sabi pa ni Ma'am, diabetes, tas kakakain lang ni Ma'am. Yan yung problema sa diabetes din, Ma'am, no? Kain lang ng kain, 'di ba? Ako aminin ko, diabetic ako eh. Na syempre DM type 2 ako, na pag DM type 1 kasi, na it's what? Juvenile, 'di ba? And of course, no, syempre nung kabataan mo, 'di ba? Even no, before you were born, 'di ba? May type 1 diabetes ka na kahit inside pa the womb of the mother, that's your type 1. Pag DM type 2 kasi brought about by sedentary lifestyle, brought about by obesity, na ayan, dahil masyadong ayaw mo ng exercise, kain ka lang ng kain. Ayan, pa-heart reaction nga sa mga diabetic dito. Ayan, pa-heart reaction. May mga diabetic po ba? Ako, I'm proud to say na diabetic ako. Wala na akong magagawa eh, 'di ba? Diabetic na ako eh. Kaya 'di ba, dapat may mga restrictions. Pero the more kasi guys na tumataas ang sugar mo, alam mo ba the more ka ding magki-crave. 'Di ba? Kasi pag the more po siyang tataas, feeling mo tuloy the more kang magugutom. Kaya lalabas po yung 'di ba, polyuria, polyphagia, 'di ba, polydipsia po natin. For sure familiar kayo doon. Next guys, we have the stroke. Kaya nga 'di ba pag may stroke, you are a walking time bomb. Anytime pwede kang sumabog, anytime pwede kang mag-collapse, At ang nakakatakot kasi, eto ha, just this morning kasi, I received a text ko coming from my friend. Sabi niya, Mark, nagpa-check ako kay mama. Sabi ko, tapos, anemic si mama. Sabi niya, Mark, di ba okay lang kahit anemic? Sabi ko, Diyos ko po. Yang anemia na yan, pwede kasing mahimatay ang isang tao. What if nahimatay siya at nabagok ang kanyang ulo? So delikado, di ba? A bigger picture, pwede siyang magkaroon ng hemorrhagic stroke. So mas nakakatakot yon. Bleeding, di ba? Mga internal hemorrhage natin, mga intracerebral bleeding po natin. So mas nakakatakot sa part po ng patient. Kaya wag mong ismulin ang anemia. Kahit sabihin natin, ang weird kasi ng anemia. Why? The most common and the most abundant kasi na mineral po na in the universe, guys, or let's say sa Earth, is iron. Pero bakit na iron na is common, 'di ba? The most common anemia is the iron deficiency anemia. Meaning to say, we lack the discipline, especially na in eating yung mga high iron rich foods. Yung mga green leafy vegetables, mga high iron rich food po yan. Next guys, we have the seizure po natin. Everybody say seizure.
Seizure.
Ayan, it's the seizure po natin. Ayan, next we have the shock. Next we have the bleeding. Dalawa po ang bleeding natin. Bleeding that is obvious and bleeding that is not obvious. Meaning bleeding you can see and bleeding you cannot see. We have the external bleeding, which is the bleeding you can see, and the you can see are the internal. Guys, anong mas nakakatakot? External or internal?
Internal.
Internal.
Yes, great. Malamang si internal. Kasi for instance, I have this close friend of mine. Nagkaroon po siya ng vehicular collision, nagkaroon po ng vehicular accident. All the while, hindi nga lang siya nagpa-CT scan. Alam niyo ba kung ano nangyari? After 1 week, nagulat na lang kami, may clumsiness na dizziness, tas biglang nahimatay, biglang na-comatose. Kasi nagkaroon ng intracerebral bleeding si patient. Diyos ko. Hanggang sa ayon, pumanaw yung, yung friend ko, college friend ko. So, nakatakot. Mas nakatakot ang bleeding that you cannot see or the internal bleeding. Next, we have the electrocution. Diba? Yung electrocution po natin kasi, yung mga high voltage kasi, yung mga biglang na-electrocute guys, na biglang na kuryente, yung mga lineman po natin, or pwedeng yung bata, 'di ba, naglagay ng let's say spoon and fork mismo sa let's say sa socket, let's say sa yung mga port po natin, electrical natin na mga port, just ko. Ayan, kawawa yung bata, So let's begin na po sa ating breathing problems. Let's have the video presentation. It's more of the video presentation na po tayo for a while. Okay. Guys, muna? Pa-full volume ako.
All heard.
You watch closely sa ating video.
Shuby. Ah! Oh.
Now let's cover allergic reactions. We've all heard stories of people who have died suddenly from a severe allergic reaction, and these stories are frightening. But fortunately, events like this are very rare, with less than 1,500 deaths from all different age groups and all types of allergies in the United States. Statistically, this is a very small number compared to approximately 50 million Americans that suffer from some form of allergy. But unfortunately, recent studies show that allergies of all kinds are increasing in developed countries. Nobody knows why for sure, but one prominent theory is that we've developed too sterile a lifestyle. With the constant use of antibacterial soap and this different hand sanitizers and airtight modern homes, our body's immune systems are not developing to fight germs in the same way as they did in the past. Now, this can lead to overreactive immune systems. Finding a balance between healthy living and clean living is a must. So other theories include overuse of antibiotics, excessive immunizations, highly processed foods, and environmental pollutants that have all led to the breakdown and confusion of the body's natural immune system. But whatever the cause, the reality is that more people are developing allergies than ever before, and we need to be prepared to handle those emergencies from allergic reactions. Now, you might find it interesting to know that food and insect allergies are the most common causes of severe reactions that happen outside of the hospital, with food allergies being the most prevalent. Children tend to be the most affected, and according to the Centers for Disease Control and Prevention, between the years of 1997 and 2007, in the United States, the number of children that have food allergies rose by 18%. Fortunately, most children outgrow their food-related allergies by adulthood, but peanut allergies, they tend to be lifelong. Now, you might be thinking to yourself, yeah, but what causes an allergy to develop? Well, the immune system normally defends the body against things that can be dangerous to your health, such as viruses and bacteria. A healthy immune system keeps a person from getting sick when harmful germs find their way into the body by attacking and destroying the germs. An allergy results when the immune system mistakenly targets and overreacts by attacking a normally harmless substance that's been eaten, inhaled, injected, or has contacted the skin. This substance that causes an allergy is called an allergen. An allergen may have been introduced to the body many times before without any trouble at all. But at some point, for some reason, the body flags it as an invader and triggers the immune system to attack the allergen. The body will remember that specific allergen by producing antibodies that will be ready to go into action to attack the allergen as soon as it enters the body. This is the reason that an allergic reaction is often more severe the second or even the third time when it happens. Now, when the immune system attacks an allergen, high quantities of histamine and other chemicals are released into surrounding tissues. And depending on the part of the body involved, the histamine and chemicals cause itching, hives, rash, sneezing, it can form wheezing, it can make swelling, a runny nose, nausea, and even more symptoms than that. Now, a serious allergic reaction that can be life-threatening is called anaphylaxis. This is a severe, sudden reaction that affects many parts of the body all at the same time. And it typically begins within minutes after an allergen is introduced to the body. This severe allergic reaction can cause the body's vessels all over the body to dilate. In other words, they open all the way up and cause anaphylactic shock. The full opening of the blood vessels causes a sudden drop in the blood pressure, and the brain and the other vital organs become oxygen starved. Anaphylactic shock will cause death if it's not treated. Now, the treatment is epinephrine, which helps constrict the blood vessels and open the airways. Now, the most common things that cause anaphylaxis are foods such as peanuts, tree nuts, fish, shellfish, eggs, and milk. Biting or stinging insects such as bees, latex, and medications. Now, food is generally the most common cause of anaphylaxis, with peanuts being the most common cause of fast, severe, and life-threatening reactions. Because severe nut allergies tend to affect children, a lot of fear is associated with nut allergies. It has become a very popular and emotional topic. This is the reason that many schools, airlines, food manufacturers, and other places have become nut-free zones. But more effective than banning nuts completely, there are precautions public facilities can and should practice, such as having nut-free tables at lunch for children to eat. Most importantly, children need to be taught what foods to avoid. Children with allergies need to carry an EpiPen. Schools, daycares, camps, and other places that typically serve food to children should have EpiPens for emergencies. Now, preventing an emergency is the best, but if an emergency happens, you need to know how to recognize it and be prepared to handle it. The following signs and symptoms would indicate a person is going into anaphylactic shock: trouble breathing, wheezing, tightness of the throat, an itchiness on the tongue, swelling of the face, eyes, lips, hives, itching, flushed or pale skin, rapid heartbeat, low blood pressure. Maybe they have nausea, vomiting or diarrhea, dizziness, fainting, or eventually unconsciousness. Now, children may describe their symptoms in the following way. They may say things like, "It feels like something's poking my tongue," or "My tongue is tingling," "My mouth itches," "My tongue feels like there's hair on it," "My mouth feels funny," "There's something stuck in my throat." They might say things like, "My lips feel tight," or "My body feels weird all over." And if you recognize any of the signs and symptoms of anaphylaxis, don't wait for signs and symptoms to get worse. Call 911 immediately. And if it's available, assist with or administer an auto-injectable epinephrine, such as an EpiPen. Keep the person calm. Have them sit down and be in a position of comfort while you're waiting for the ambulance. Let them sit in a position that's easiest for them to breathe. Typically, this is sitting up and leaning forward. And if the person feels faint or is not fully conscious, lie them down, elevate their legs, and keep the person warm. Talk to them, reassure them, and keep the person's airway open while monitoring their breathing, and be prepared to start CPR if the person stops breathing and becomes unresponsive. It is possible for a reaction to happen again after the initial reaction, so most people should be really cautious and be observed during the following 4 to 6 hours after they had their first initial event. Remember, the best way to help somebody in an anaphylactic reaction is to recognize their signs and symptoms early, activate EMS, calling 911 or a code, and then assisting them with their EpiPen to reverse their symptoms and help save their life.
Okay, questions po regarding sa allergies po natin. Questions po. Questions po. Bisaya dong. Questions po. Ayan, ito ha, I'll be presenting the ano po, the differences between the allergy and anaphylaxis. So ang pinaka-worst guys will be the anaphylactic reaction. A simple allergy kasi, expected po pag simple allergy, yes, you have that runny nose, no? Naalala ko dati, may isang patient dati, sabi niya, "Sir Mark, I have a running nose." Ha? Tumatakbo, no? Ang iyong ilong, hindi running, it's a runny nose, 'di ba? Makate, no? So may drainage po tayo, no? Ayan, like 'di ba parang may itchiness, no? So we have the itchy red na watery eyes, we have the hives na, or the rash na itchy rash po natin. Ayan, so that's the allergy. Usually kasi simple allergy guys na matitreat lang talaga yan ng mga antihistamine po natin. However kasi, like for example, Benadryl is also an antihistamine, di ba? Yung mga cetirizine mo, pwedeng-pwede yan. Ako kasi guys, na meron ako allergic kaya reaction sa itlog. So malamang allergic din po ako sa manok. Dati kasi ako kumakain talaga ako ng itlog. Ngayon dinidilaan ko na lang siya kasi syempre allergic ako sa itlog. Next, you have the anaphylactic reaction. So totoo nga, 'di ba? Pag allergic ka sa manok, malamang allergic ka sa itlog. Bakit? Saan ba nanggaling yung yung manok? Eh di malamang sa itlog. So ayun po, we have the anaphylactic reaction. This is the more severe one. Na severe po ang tinatawag na anaphylactic reaction natin. From anaphylaxis kasi, pwede siyang mag-lead to anaphylactic shock. No? So mas delikado na siya. Ayan, so we have the swelling, no? Pwedeng ang yung buong mukha mo, na we have the lips, we have the tongue, no? Tapos yung iba may difficulty of breathing na, may chest tightness na. So meaning to say, sir, ano yung pinaka the best na management dito? Kung kanina guys, pag allergic reaction, anti-histamine po natin. 'Di ba? To promote, no? Ayan, let's say yung mga vasodilation natin. Ito namang sa anaphylactic reaction, syempre, hindi na po kasi gagana ang mga antihistamine mo dyan. So you need to give, okay, epinephrine as your bronchodilator of choice. Lalo na pag severe na ang bronchoconstriction po natin. Severe bronchoconstriction are usually treated by giving epinephrine. Now, I'll be showing a video how to give EpiPen. You listen carefully sa video ng EpiPen or the auto-injector. No, this is the EpiPen po natin. Ayan, we have the 0.3 milligram EpiPen auto-injector. For a while pakita ko lang yung video po ng EpiPen po natin. Okay.
Can I have a piece? Mm-hmm. Try it. It's really good. Hey, Anthony, can you go help?
In all my years as a licensed paramedic working on the street, not many acute illnesses are as scary as a severe allergic reaction. We have a fancy word to call that. It's called anaphylaxis, which is the body's reaction to something that is causing them to have a number of different symptoms that could lead to a life-threatening emergency. In this scenario, we're going to teach you what anaphylaxis is, what it's doing in the body, and then how we may be able to treat them until emergency medical services arrive. So what is anaphylaxis? Anaphylaxis is an allergic reaction where the body does a couple different things at the same exact time. While the blood vessels are dilating and becoming leaky, allowing fluid to leak out into the tissues of the body, decreasing the blood pressure, something else is tightening, and it's the airways. The bronchioles, the alveoli sacs are filling with mucus and fluids, and basically we have these two mechanisms working together to create a serious life-threatening problem. So the signs that this person might be showing is not only the itchy, the hives, the scratchy, the itchy throat, the swollen tongue, the swollen lips. Those are all kind of superficial as far as the outside of the body, but what is happening inside is what we hear most of the time, and that's difficulty breathing, wheezing, gasping for breath, and not able to get it in. This is caused by those bronchial constrictions, as well as the fact that she might be feeling lightheaded and looking pale because her heart rate is trying to increase and she's also losing blood pressure. So these are some things that we're going to be aware of as we're dealing with this anaphylactic patient. Now in this scenario though, she was wise. She understands that she's having a problem and she told somebody who was a bystander to go get help. In this training scenario, she's already been prescribed epinephrine for these types of emergencies, but in this case, didn't know she had a food allergy. So her brother shared the candy bar with her. It might have had an allergen in it, obviously it did, and now she's reacting to it. So as soon as we could, we got to her EpiPen. A few points to think about here is we need to make sure that the date is still within the expiration range so that it's good. We're going to pull the cap off, the safety cap, and it's important to remember that we grip it firmly in our hand, but we do not put a thumb over the needle area or over the back of the EpiPen. Now that this has been readied, I'm going to hand it to this victim who's now going to auto-inject. She puts it into her big muscle in her thigh and holds it there for 3 seconds. She now takes it out of her leg and lays it beside her. While she does that, she massages the leg and tries to get the medicine to absorb into that deep intermuscular injection. This training is based on the EpiPen brand, so if you use a different brand, make sure you follow that manufacturer's directions. Now, while we're letting that get into the system, if we have not already called 911, we should be. So if you have a phone, dial 911 and get emergency medical services on the way. If you don't have a phone, send somebody to go call 911 immediately. If there's a delay in emergency medical services of greater than 5 to 10 minutes and the patient actually has a second auto-injector available, we can actually deliver a second auto-injector if the signs and symptoms of her anaphylaxis have not improved. Now, we're always going to be monitoring this patient for an increased problem, maybe a loss of consciousness, increased difficulty of breathing, or respiratory arrest, and then eventually cardiac arrest. And we're going to treat them accordingly while we wait for EMS to arrive.
Okay, so with your breathing problems po natin, always remember this. Now, you always observe is the patient okay breathing fast? Is the patient okay breathing slow? No? Is my patient okay having okay trouble okay in breathing? Or let's say may mga noisy ba tayo ng mga let's say respirations or noisy okay breathing? No? Is my patient okay having okay trouble okay in speaking? And then guys, if you think na meron naman pala siyang inhalers, pwede pong ipa-inhale ang client. If ever lang, kung baka na-atake pala siya ng asthma. So ang importante lang, ibigay mo yung inhalers niya, you stay with the client, and observe the patient. And that's for the breathing problem. Ayan, allergic reaction. Now, next topic guys will be the choking. In choking kasi, this is the universal sign of choking. Tama po? Ayan, kaya nga 'di ba, hey, are you choking? May nakabara po ba? Because that's the universal sign. Meron din kasi tayong universal sign for heart attack, and that's the Levine sign. Yung clutching ng kanilang chest, that's universal sign of heart attack. Pero pag ganyan, both hands po nakahawak sa kanyang neck, ang tawag dyan universal sign of choking. Now let me present to you a video from the American Heart Association choking discussion.
Oh, hey, Scott.
Hey, Sam. How you doing?
I'm looking forward to a few days of not being on call.
I didn't think you ever needed rest.
Oh, I'm not resting. I've got my whole family coming into town this weekend, and they're expecting me to provide the entertainment. What's wrong?
I think he's choking. Are you choking? I'm gonna help you. Sit down. Sit down.
Choking occurs when food or other items block a person's airway. In severe airway obstructions, the victim usually will have signs of poor air exchange and breathing difficulty, such as a silent cough, cyanosis or turning blue, and an inability to speak or breathe. The adult or older child may clutch the neck with both hands, making the universal choking sign. This is a signal to ask if the victim is choking. If the victim nods that he or she is choking and cannot talk, you must act. In a standing or kneeling victim, you'll perform an abdominal thrust often referred to as the Heimlich maneuver. Stand or kneel behind the victim and place your arms around the victim's waist. With one hand, locate the navel. Then make a fist with the other hand. Place the thumb side of your fist against the victim's abdomen, just above the navel and below the breastbone. Grasp your fist with your other hand and press your fist into the victim's abdomen with a quick, forceful upward thrust. Repeat thrusts until the object is expelled from the airway or the victim becomes unresponsive. If the victim is too large for you to wrap your arms around the waist, pregnant or overweight, for example, wrap your arms around the victim's chest and do chest thrusts instead of abdominal thrusts. If your attempts to relieve choking in an adult or child are unsuccessful or the victim becomes unresponsive, send someone to activate the emergency response system. Perform CPR using the CAB sequence with one exception. Each time you open the airway to give breaths, look for the obstructing object in the back of the throat. If you see an object that can be easily removed, carefully remove it, but do not perform a blind finger sweep as the object may become lodged further back in the airway. Choking is also a fairly common emergency among infants. The steps to relieving choking in an infant are quite different than those for older children and adults. If you find an infant choking and they are responsive, first sit or kneel with the infant in your lap. Hold the infant face down with the head slightly lower than the chest, resting on your forearm. Support the head and jaw with your hand. Avoid compressing the soft tissues of the infant's throat. Rest your forearm on your thigh to provide support. Deliver up to 5 back slaps forcefully between the infant's shoulder blades using the heel of your hand. Deliver each slap with sufficient force to attempt to remove the foreign body. Then place your free hand on the infant's back, supporting the head with the palm of your hand. This will cradle the infant between your 2 forearms as you turn the infant over while carefully supporting the head and neck. Keep the infant's head lower than the chest and deliver up to 5 quick downward chest thrusts the same way you perform compressions, just below the nipple line, over the lower half of the breastbone. Do this at a rate of about 1 per second. Repeat the sequence of 5 back slaps and 5 chest thrusts until the object is removed or the infant becomes unresponsive.
Okay, so let's move further na po. Ayan, our next topic. Guys, ano kaya ang next topic natin? Obviously, ano kaya to? Siyempre, tao yan. 'Di ba? And that's your the Levine sign kasi. So these are, okay, the warning signs na baka may heart attack po ang patient natin. Now, sir, when we talk of chest pain, everybody say chest pain.
Chest pain.
Ayan. Other term for chest pain, based on the medical term, it's your what? Angina. Diba? It's your the angina pectoris po natin. Now, there's a big difference kasi between angina pectoris, okay, and your myocardial infarction. Tama po? Lalo na in terms, okay, of, okay, let's say minutes na ng the duration of their pain. Let's say hindi pa rin nawala ang pain po ng less than 15 minutes, or let's say pag less than 15 minutes nawala ang pain, no, or let's say greater than 15 minutes, sir, hindi pa rin nawala ang kanyang pain. So that concludes na baka nga na may MI ang patient po natin. So these are, okay, di ba, mga signs ng mga, okay, heart attack po natin. So again, our next discussion will be more of chest pain, okay, and heart attack. So number 1, to determine if that's angina pectoris, guys, of course, this is, di ba, sudden, this is acute, no, stabbing pain. Ayan, acute and stabbing pain. So meaning parang what? Na parang sinaksak ng kutsilyo. And usually 15, no? Less than 15 minutes po, no? Pag less than 15 minutes na okay na ang patient natin, no, relieved, okay, by nitrates. Okay, relieved. Ayan, by nitrates. Aside from nitrates, na relieved by rest. Then guys, na that's your angina pectoris. However kasi, na, sir, what if ang pain natin dito, it's excruciating. Ayan. Excruciating. Okay, pain po. Aside sa it's your excruciating pain, guys. Ayan, sir, greater than 15 minutes na po. Unrelieved. Sulat lang natin. Unrelieved, okay, by rest. Unrelieved by nitrates. Then meaning to say, it's already your myocardial infarction. Your angina pectoris is reversible, meaning nagagamot pa yan, meaning makokorek pa yan. But your MI kasi, no, from ischemia, no, magkakaroon ng necrosis, no, of course, we have the infarction there, di ba? So mas malala to, na. Kaya careful po tayo. Guys, ano nga ang drug of choice natin pag may angina pectoris? Recall tayo, letter N. Mga nitrates po natin. Pero pag myocardial infarction, syempre ang gamot po natin dito, we have the morphine. Ayan, sulfate po. Okay? Sige, pakita ko lang ang video ha na regarding the acute coronary syndrome po natin. The warning signs of heart attack po natin. You listen carefully and pay attention po, especially sa mga Acls po natin dyan.
Promotional items coming in. We got to put them somewhere.
Okay, sounds good.
Oh.
You all right, Jack?
Yeah. Yeah, I'm fine. I think it's that stuff that everybody's got going around.
Okay.
Acute coronary syndromes, or ACS, may suddenly strike men and women, often after years of asymptomatic coronary atherosclerosis and plaque formation. As plaque forms within the coronary arteries, several clinical syndromes may also develop, with varying degrees of coronary artery occlusion. Two of these syndromes are non-ST segment elevation acute coronary syndromes, or NSTEACS, and ST segment elevation myocardial infarction, or STEMI. STEMI is generally considered to be more serious and usually develops after a ruptured plaque or an erosion results in an acute blood clot that significantly or completely occludes a coronary artery. Either of these syndromes can, unfortunately, manifest as sudden cardiac arrest and death. It's estimated that half of the deaths from these syndromes occur outside the hospital, making early recognition and rapid response essential. The best outcomes from ACS occur in communities where programs with strong public education, PAD programs, and STEMI systems of care exist. Watch how emergency medical services and hospital personnel use the STEMI chain of survival to provide a system of care that recognizes and rapidly treats the underlying causes of ACS.
What's going on?
I think Jack's having a heart attack. I'm going to call 911. You get the AED and first aid kit.
Okay.
911, what is your emergency?
I think my manager's having a heart attack.
I see you're located at 459 Commerce Avenue, is that correct?
Yes.
Where is the patient?
He's right here. He was wobbly on his feet, so we sat him down in the aisle. He's having chest pains and his left arm hurts.
Is he awake? Can you talk to him?
Yes, he's awake and able to talk.
I'm going to dispatch paramedics to your location. Stay on the line with me, okay? Don't hang up. I'll have a few more questions to ask you.
Okay.
The first step in the ACS algorithm involves the patient, bystanders, and medical personnel recognizing the warning signs of cardiac ischemia.
We all had basic first aid training and CPR training about 6 months ago, and when Jack said his chest was hurting and his left arm was hurting, that's when the alarm bells went off for me.
Our system uses priority dispatching protocols, which help identify the problem and determine what type of response to send. What the caller described fit the protocol for ACS, which required a high priority EMS response.
While waiting for EMS to arrive, dispatchers may advise patients to chew 160 to 325 milligrams of non-enteric coated aspirin. This recommendation should be in line with approved medical protocols, and only if the patient has no history of true aspirin allergy or gastrointestinal bleeding.
Okay, paramedics are on their way. Stay on the line with me until they arrive. Do you have a first aid kit with you?
Yes, and I have our AED too.
Great. Is the patient still conscious?
Yes, he is.
Okay, then we won't need to use the AED right now. Ask if he has an aspirin allergy or any recent bleeding from his stomach.
Jack, do you have an allergy to aspirin?
No.
Have you had any bleeding in your stomach recently?
No, I don't think so. No.
No to both questions.
Look in the first aid kit. If it has aspirin, have him chew 2 to 4 baby aspirins or 1 adult aspirin while you wait for the paramedics to arrive.
That brings us to the next step in the ACS algorithm: assessment, care, and hospital preparation.
What happened?
He's been having chest pains for about 10 minutes. The 911 operator said to give him an adult aspirin to chew.
Sir, how you feeling?
Not so good. It's my chest. I feel like somebody's squeezing it.
Okay, well, we're gonna help you out, reduce that pain. I'm gonna get a 12 lead. Go ahead and get his blood pressure and put him on a pulse ox.
When we arrive on scene, the clock is ticking. I know I've got to assess, but if he doesn't need immediate resuscitation,
My highest priority is to obtain a 12-lead ECG, manage the symptoms, initiate transport as soon as possible. Every minute matters. The longer it takes to get to the hospital, the poorer the outcome for the patient. In fact, half the people who die from ACS are dead before they even reach the hospital. So I follow the ACS algorithm closely just to make sure that doesn't happen.
Administer supplementary oxygen if the patient's oxygen saturation value is less than 90%. Give aspirin if the patient hasn't taken any yet and there are no contraindications. It's critical that out-of-hospital healthcare providers obtain a 12-lead electrocardiogram.
Looks like a STEMI.
This early ECG helps classify patients suspected of having an ACS into two groups based on ST segment deviation before they reach the hospital. It's preferred that patients with ST segment elevation be driven, if feasible, to a hospital that performs primary PCI. This initial ECG speeds the patient's diagnosis and shortens the time to reperfusion.
Recognizing ST segment elevation on a 12-lead ECG takes training and practice because different thresholds exist for patients depending on their age and gender.
If a STEMI is suspected, EMS should notify the hospital or transmit the ECG for interpretation.
The patient had ongoing symptoms of ischemia, so we administered nitroglycerin sprays every 3 to 5 minutes for a total of 2 doses. 3 is the max. We monitored the patient's blood pressure in between each dose.
Before giving nitrates in any form, make sure there are no contraindications, such as severe bradycardia, tachycardia, or hypotension. Also, confirm that the patient hasn't taken any phosphodiesterase inhibitors for erectile dysfunction in the past 24 to 48 hours. Patients with inferior wall STEMI on their 12-lead ECG can often have right ventricular involvement. This can be confirmed by a right-sided 12-lead. If RV infarction is present or suspected, nitrates in all forms are contraindicated. Clinically, it may be suspected in patients with hypotension, clear lungs, and elevated JVD. If the patient receives nitroglycerin but does not experience pain relief, healthcare providers can consider giving analgesics such as morphine while monitoring the patient's blood pressure and respiratory rate. Use morphine with caution for patients with unstable angina.
County Medical, this is Rescue 1. We've got a STEMI alert. 46-year-old male, chest discomfort started half an hour ago. Current vital signs are BP 104/78 with a heart rate of 96. Pulse ox 95%. He's chewed 325 milligrams of aspirin and received 2 rounds of nitroglycerin sprays, but still says he has chest discomfort. 12 lead shows ST segment elevation of 3 to 4 millimeters in leads V1 through V4. ETA to your facility is 10 minutes.
Rescue 1, we received your 12 lead and your initial report. We'll activate our heart alert system, contact the cardiologist and the cardiac cath team. We'll see you guys in a few minutes.
Let's get ready.
Getting this advance notice really helps us speed treatment of these patients, increasing their chance of survival. We can have the cath lab prepped and ready by the time the patient hits the doors of the ED.
The American Heart Association recommends that EMS personnel transport patients who have a STEMI to the closest appropriate facility that provides reperfusion without delay.
Hi, sir. I'm Dr. Taylor. We're going to take good care of you today.
After we last talked, his pain is down to 2 out of 10. Otherwise, he's stable.
Let's get him to bed.
Right. Studies show that ED evaluations are responsible for as much as 33% of the total time from symptom onset to treatment. We try to reduce delays by having everything ready when the medics arrive. After seeing the 12 lead that the medics had sent, I immediately activated the PCI team and alerted the cardiologist.
When the patient arrives at the ED, we move to the next step in the ACS algorithm. Reperfusion goals for STEMI patients include PCI within 120 minutes after the first medical contact, or fibrinolytics within 30 minutes from ED arrival. The appropriate therapy is defined by patient and center criteria.
Within the first 10 minutes after arrival, the ED staff should provide an immediate assessment of the patient. That includes taking vital signs, getting a brief, targeted medical history, completing a fibrinolytic checklist, and obtaining blood studies. If the early ECG shows no signs of ST segment elevation, then a repeat ECG in the ED is warranted. Staff should also get a chest x-ray within the first 30 minutes after arrival. Draw the STEMI panel. I've activated the STEMI pager and get him to the cath lab as soon as they're ready.
Adjunctive treatments include unfractionated or low molecular weight heparin, bivalirudin, P2Y12 inhibitors, IV nitroglycerin, beta blockers, and glycoprotein 2B3A inhibitors.
Hi, I'm Dr. Taylor.
Hi, how is he? Did he have a heart attack?
I'm afraid so, but his vitals are improving, and we're moving him to the cath lab. This is going to allow us to see inside his heart and his arteries and treat it as well. Dr. Abrams is an excellent cardiologist, and he'll be helping you through the next steps. You'll be in good hands with him, okay?
Thank you.
This patient presented with ST segment elevation of 3 to 4 millimeters in leads V1 through V4. Now, this suggests that his LAD artery is occluded. Immediately opening up the artery with PCI and restoring normal blood flow is my primary goal.
The final link in the STEMI chain of survival is treatment. The preferred reperfusion strategy for STEMI patients is PCI, when patients meet the 120-minute window from first medical contact or 90-minute window from ED arrival to balloon inflation in the catheterization lab.
Hi, Mr. Brennan, I'm Dr. Abrams, your cardiologist. How are you feeling?
Not so good.
Well, hopefully you'll be feeling a lot better soon. I just want to talk to you a little bit about what's going on. I've reviewed your ECG, and it appears you have a blockage in one of the arteries to your heart. Now, to open the artery, we need to perform a procedure called PCI that'll help reestablish blood flow to your heart. Basically, we insert a catheter into the artery with the blockage and inflate a balloon to widen the blocked area. We then place a stent to keep the artery open. And the sooner we can do this procedure, the less damage may be done to your heart. Okay?
Okay. I understand. I'm ready.
All right. Well, let's see what we can do to help you get better, okay? All right.
PCI opens the blocked artery with a tiny balloon. Then a stent, or metal scaffold, is inserted to maintain blood flow to the heart. When choosing between this reperfusion strategy and fibrinolytic therapy, hospital personnel must consider a number of factors. Studies show that treatment delays increase mortality in both groups, regardless of the reperfusion strategy chosen, but were more pronounced among those patients receiving fibrinolytic drugs. In these cases, the more time that goes by, the more heart muscle is lost. The better EMS systems and medical centers work together, and the faster they can deliver treatment, the more heart muscle and patients can be saved.
We had a great outcome with that patient, but we wouldn't have if every link in the chain hadn't been working cohesively.
All the pieces fit together perfectly, and it all began with a call from his coworker. The dispatcher assisted in the administration of aspirin prior to our arrival. We were able to get to him in time, identify a STEMI, and move him quickly to a hospital where they were ready to do PCI. He's back at work today because of it.
Okay, let's discuss na po. No? So again, pakita ko lang din yung mga signs po ng ating myocardial infarction. Usually, ang kino-complain po ng patient natin dito, no, yung squeezing pain, no, excruciating pain, na parang it seems like an elephant is sitting above their chest. No? So meaning parang may elepante na nakapatong sa kanila. Ganun ka-heavy ang nafe-feel po ng patient. And that's your myocardial infarction. Kasi kanina guys, na pag angina pectoris lang, pwede pong ma-relieve, no, by rest, ma-relieve by nitrates. Pero since nagbigay ka na ng 3 doses, no, 5-minute interval, wala pa ring nangyari kay patient, then, okay, most probably, no, and most likely, okay, myocardial infarction na po yan. Guys, what do you think is our next topic? Kasi upon assessment, no, biglang bumulaga ang patient po natin. 'Di ba? Ano kaya to? This is your the syncope or your fainting. Your fainting kasi guys na happens na number 1, kailan ba siya nangyayari, sir? It can happen, okay, like for example, there will be long standing, ayan, without, okay, moving. Long standing, ayan, without, ayan, moving. Tapos hot climate pa talaga, no? Like as in like mainit. So malamang magfi-faint talaga 'yan. Now, aside from long standing without moving in a hot temperature, pwede ring suddenly stands. Suddenly, okay, stands. Ayan, after squatting. Aside from after squatting, okay, or okay, bending down. Meaning to say, anong nangyari kay client? Nagkaroon ng orthostatic okay, hypotension. And yung iba din, no, ito, and that's your okay, receives. Ayan, receives okay, bad news. Tulat ko lang ha. So receives okay, bad. Ayan, bad news. Ano yung mga example ng receives okay, bad news? Like for example, dumating ang Shopee mo, dumating ang Lazada mo, 5 ang Shopee, 5 ang Lazada, pero wala kang pera. Masarap bang mahimatay doon? Diyos ko, bad kung bad news talaga eh, no? And Diyos ko, yun yung mga nakakatakot guys, no? Minsan nga, like, nagulat ako, ang dami ko palang in-add to cart, tapos wala pala akong pera. Kasi parang, siguro feeling ko, nasa hype ako ng kalasingan that time, na that happened mga a year ago. Like, alam mo yung sobrang lasing mo, like, tapos, sige, add to cart lang, add to cart. Tapos, Diyos ko po, 10 pala yung na-add to cart ko. Kinabahan talaga ako. Muntik na ako ma-heart attack, na nakakatakot. Pwedeng mag-add to cart, no? Pero ang problema, nasaan ang pera? So, we have long standing without moving, no? Suddenly, okay, stands, okay, after squatting or after bending. Ako fainting kasi, ano yung priority natin dito, guys? Of course, the safety of our patient. Yun talaga yung priority natin. Now, with fainting also, we usually, na, di ba, biglang nahimatay. So, dahan-dahan po nating slide ang ating patient sa floor, no? Lie on the floor, and then you raise po the legs of your patient. Why? Kasi ang patient mo nagkaroon ng vasodilation. Lahat ng mga dugo niya nasa legs niya. So, ibabalik po natin yan. Baka ibang isipin nyo ha kung anong pinagagawa nila. Siyempre, nilift niya lang po no, ang legs ni patient. Ito po yung pinakamagandang gawin kasi yung iba, pag may nahimatay po na pasyente, aba anong ginagawa? Nagpapaypay. Maling-mali yung paypay ha. Kaya siya nahimatay brought about by vasodilation. Hindi po siya nahimatay dahil sa sobrang like init na siya. No. Kaya ang pinakamaganda na management, you lift okay, the legs okay, of your patient po. Now, usually guys, ano ba ang height dapat? 12 inches dapat ang height niyan. Estimate ka na lang ng 12 inches. Pwede ka maglagay ng box. Pwede ka maglagay ng box dyan. Or if ayaw mo ng box, yung mga rolled, okay, na mga like coat. Di ba mga malalaki kasi yung coat? Di ba basta mga coat, like mga jacket, mga ganon. Basta anything na coat. Tapos i-roll mo yan. Pwedeng-pwede po yan. Ang importante, ma-raise lang po ang legs ng patient po natin. And while raising kasi the legs of the patient, this is the time also na you need to look for signs of injury. Diba? You need to look for signs of bleeding din dito. And then if ever kung na-okay na ang patient, guys, na you help the victim get up slowly. Diba? Dahan-dahan lang po na babangon ang patient. So ulitin ko. If ever kung may fainting, safety will always be the priority. You slide the patient to the floor, lying on his back, meaning to say nakasupine position. You raise the legs of the patient for about 12 inches po. Kung ayaw mong i-raise na ganyan, pwede ka mag-provide ng box or yung iba chair. Basta, naka-lift lang dapat ang legs ng patient natin for about 12 inches. You need to look for signs of injury and then help the patient, or let's say the victim, get up slowly. Now, to best, discuss that, I have actually prepared a video po about, about fainting po natin. For a while,
As a syncopal. Now let's talk about situations when a patient passes out. More specifically, it's known as a syncopal episode. Now, when a person passes out, it could be from a number of reasons, and many of those reasons do not have to be life-threatening. What we're really concerned about when a person goes unconscious is that they're unable to protect themselves from the fall. And if they can't protect themselves from the fall, there's any number of things that can go wrong. They can hit their head, they can hit their face, and they can even break bones. So when we come up to a person that has had a syncopal episode or has passed out, we still want to assess them for life-threatening conditions. We want to check them for the potential of having a concussion or a neck injury. Once we've ruled out those different possible side effects, we can begin to just see if the patient maybe just has a self-limited issue going on. They need to rehydrate, maybe they need to eat something, and they don't need to necessarily go into the hospital. So when I come across somebody who's had a syncopal episode and they're awake already, like in the case of this patient, she's beginning to respond. She doesn't necessarily feel all that well, but she's clearly gotten up to a sitting position on her own. Now we can kind of interview the patient and see what's going on. Hi, ma'am. My name is Roy. I'm trained and I can help you. What's going on today? She then responds back to me, I didn't feel well sitting at the desk and I started to get lightheaded. So I wanted to go and get a sip of water, but as soon as I stood up, everything went black. And that's the last thing I remember, and then I woke up on the floor. So there was no one in here to be able to watch her, so we have no idea if she hit her head or her face, and it's up to us to become a little bit more detective to find out if there's any potential injuries that need to be treated. So I want to ask her, did you have any headache, or how are you feeling? Do you hurt anywhere? She then shakes her head no. She says, I'm feeling okay other than just feeling kind of weak and dizzy. And so we then know immediately she's awake, she's responsive, she has a good airway, she's breathing, and she has a pulse. We're going to look at her skin, see if it's pink or pale, if it's dry or clammy or sweaty, and that could be a sign that she's still dealing with some of the shock symptoms and may be enough for us to say, you know, under circulation, this might be a bit of a compromise, and she's not feeling all the way well. Now is the time where I'm probably going to decide to err on the side of caution and activate EMS. Send a bystander, you in the plaid shirt, go call 911 and come back. If you can find an AED, bring it with you. Now, why did I say AED? Well, we have no idea what really caused her syncopal episode in the first place. Though it could be something simple as dehydration or a little sugar dip, we also might be dealing with a dysrhythmia of the heart, and we don't want to take that for granted. And so having an automated external defibrillator available in case she has another event or goes fully unresponsive is always a good idea. If she begins to recover, she doesn't have any pain, the concussion doesn't seem to be prevalent, or she seems that she's answering questions all fine, we can kind of work with the patient and allow them to begin to recover at will at their own power. But if at any time we notice that they are decreased level of consciousness, have airway breathing or circulation problems, signs of shock, a long bone fracture, or they might be coming in and out of responsiveness, that's immediately going to be an emergency call. Activate EMS, call a code or call 911, and now we're going to treat her symptoms accordingly.
Okay, after fainting po, ayan, so we have for the next topic, restoration. Ano kaya yung next topic natin? Na we need to have your first aid din dito po. Anyone from the group? Ano kaya ang next topic natin? Ayan, or the diabetes mellitus. Tama po si Sir Eliseo. Amazing si Sir. Ayan, sige po. So with your diabetes mellitus kasi, ano ba yung mga dapat natin gawin kay patient? Sige nga, anyone from the group? Anyone from the group? Ano mga gagawin natin kay patient? Anyone? Guys? Ha? Ayan. So of course, we need to monitor, 'di ba? Ito kasi yung mga tinatawag na low blood sugar po natin. So by definition po, na diabetes mellitus disorder, within the body does not produce enough, or normally, insulin. Pwedeng absent ng insulin, pwede ring may insulin resistance na po tayo. Now with diabetes mellitus kasi, na basta tandaan lang po natin that the normal blood glucose level should be 70. 'di ba, to 110 milligram okay per DL. Let's say sabihin natin na 70 and below, hypogly ang tawag doon. Pag 110 and above, hyperglycemic. However kasi pag hindi naman automatically like let's say less than 70 no. May mga ibang books kasi may mga ibang hospitals para masabi nilang hypoglycemic usually pag less than 60 and below na talaga. Yung iba naman less than 40 na para sabihin nila na and severely okay hypoglypo ang patient po natin. Now, my focus okay for this afternoon is of course na yung hypoglycemia. Sige nga. Wait lang ha, i-discuss ko lang si okay hypoglycemia. Sir, question. What are the signs okay of hypoglycemia? Hypo meaning a drop in your sugar level. This means a low blood sugar. Okay, level po. Meaning hypo. Meaning to say, sir, ano bang i-expect natin dito? Your patient here is actually sweating a lot. Na? Aside from that, na your patient is shaky and trembling. So pwedeng may tremors ang patient natin. Ayan, of course, we have the feeling tired. Ayan. Iba po ang feeling tired sa tamad talaga. Na may mga tao kasi na always feeling tired. Mga tamad na 'yon. Ito yung mga anak nyo. Ayan, pwedeng kapatid nyo, 'di ba? Ayan, aside from that, we have the dizziness po natin. We have the dizziness. Next, aside from dizziness, okay, feeling what? Feeling hungry all the time. Ako to. Kakakain ko lang. Hungry ulit, 'di ba? So, ulitin ko, sweating, shaky, trembling, feeling tired. Next, we have the dizziness. Next, we have the feeling, okay, hungry. And then, ito, common to, irritable. Guys, irritable. 'Di ba may mga tao, ang bilis na magalit. 'Di ba? And sometimes, and most of the time, pagbaba ang sugar mo, you tend to be moody in nature. Okay po? So ulitin natin. Signs of hypoglycemia or low blood sugar okay level po. We have the sweating. Meron tayong feeling okay tired na. Tapos we have the shaky, trembling. Ayan, dizziness. We have the feeling okay hungry all the time. Na they are irritable and they are moody in nature. So sir, ano ba ang dapat nating gawin if ever kung hypoglycemic ang patient natin? For patients, guys, na who are hypoglycemic, anyone, kung ano yung nawala, yun ba yung ibibigay natin? Yes. Ayan, magbibigay ba tayo ng sugar natin? Yes, you give sugar with the form of your regular, okay, sodas po natin. Regular, ayan, sodas. Sir, maliban na magbigay ka ng mga diet coke? Yes. Ano pa ang saysay? Nagbigay ka ng diet coke, 'di ba? May mga na sugar substitute 'yon na hindi naman sila helpful. So meaning kung nawalan siya ng sugar, edi bigyan mo ng sugar, wag mong bigyan ng diet coke. Baka magbigay ka ng Coke Zero. 'Di ba? Useless lang po. It should be regular sodas kasi may sugar eh. Sabi ko, you give sugar. Aside from regular sodas, guys, i-check natin ha. Pwedeng magbigay ng fruit juice. Ano yung pinaka-common na fruit juice na binibigay po pag hypoglycemic agents, hypoglycemic patients rather? We have the orange juice. Guys, sa orange juice po, grabe, very helpful po ito. Kasi us na ng mga diabetic dapat may mga baon kami mga juice from time to time. Lalo na syempre sa loob ng kotse mo, lalo na pag maglo-long travel ka. Usually ako may mga baon ako orange juice. Nabibili naman sa 7-Eleven yan eh. Next, ayoko lang to. Syempre, ayoko naman ng sticky like honey. Grabe, honey talaga eh, no? Next, we have the candies also. Usually sa States po, may mga tinatawag silang lifesaver candies. Lifesaver gum or the lifesaver candies po nila. Marami po yan. Gum, okay, or candies. Now, of course, nasa cashier po yan. Try mong tignan yung mga cashier po ng mga malls. May mga lifesaver gums dyan, may mga lifesaver candies. Ako nakabili ako ng Lifesaver gum, matamis nga siya, grabe yung sugar niya. Pero siyempre para yan sa mga ano, sa mga biglang nag-hypogly. Okay po? Aside from giving, okay, sugar like regular sodas, na fruit juices natin, to be specific, yung orange juice mo, so we have the honey, na, and then we have the candies like Lifesaver gums, na Lifesaver candies po natin. Aside from, okay, giving sugar, you need to assist the patient in lying down, na, assist, 'di ba? Assist, okay, the patient, ayan, in, okay, lying, or let's say in sitting. Basang importante, safety pa rin ng patient po natin. Guys, if the patient is, okay, if not responding na po, ayan, if not responding na si patient, you need to dial 911. Why? Kasi baka nagkaroon na po no ng irreversible brain damage ang patient natin. Sa sobrang high po ang patient mo. Okay po ba? So again, you need to give sugar. Na? Next, you need to assess, okay, the patient in sitting or in lying down. And lastly, if the patient is not responding na to your management, then that's the best time na you need to call, okay, 911. Okay, kamustahin po natin ang ating mga students, ating mga trainees. Can I see a thumbs up sign po no, as a heart, yung mga reactions po natin? Sige nga, explore natin yung Zoom natin. Can I see a thumbs up sign po? Or let's say heart reaction. Ayan. Kung sino pa yung mga buhay na buhay pa at hindi pa kailangang i-first aid. Ayan. Kasi naman, no, this is syempre online platform. Pwede naman kayong kumain dyan. Naka-off cam naman kayo eh. Pwede naman kayong uminom ng tubig, no? Pwedeng uminom ng coffee, walang problema. Huwag lang mabuhusan ang laptop natin, Diyos ko Lord, no? Mabuhusan na lahat, no? Huwag lang ang ating mga gadgets, no? Yun yung pinakaayaw natin. Now, next topic po, now we need to discuss for a while. Ayan, based sa picture po natin, guys. Ano kaya to? Ayan, ano kaya yan? Siyempre, yung picture na yan, pag wala tayong pambayad sa Shopee, puro Shopee talaga eh, no? Like, sasakit ang ulo mo, lalo na pag nag-text na siya, Sir, darating kami mamaya, about to deliver na yung package mo. Tapos, syempre, hawakan mo yung ulo mo sa sobrang sakit, like, stress is real. Tapos may nakalagay na amount, 3,500. Kasi yung sahod mo with all the minus na 1,500 na lang. So saan ka kukuha, guys? No? Dasal-dasal na lang talaga. Okay, let's have the ano po na let's say the video presentation okay, of your stroke. Listen carefully.
Are either blocked by. In this lecture, we're going to talk about stroke, and this will be our introduction to stroke. This is a really important lecture and a critically important topic. We see this a lot clinically and need to evaluate this in clinical vignettes. Let's start with, what is a stroke? Stroke is a disease that affects the arteries leading to and within the brain. Strokes occur when blood vessels that carry oxygen and nutrients to the brain are either blocked by a blood clot in the setting of ischemic stroke or become leaky and burst or rupture in the situation of a hemorrhagic stroke. Strokes are really important to understand. We're going to walk through the pathophysiology, the clinical presentations, the evaluation, and workup for patients who present with stroke. When we think about causes or types of strokes, there are two types of stroke. The first is ischemic stroke, and this develops as a result of a blood clot for any number of reasons. When there's a clot in an artery, there is reduced perfusion, and we can see that in the schematic here. Reduced perfusion in the lenticulostriate arteries leads to death of those cells, of those neurons and astrocytes, and loss of neurologic function. Patients present with that loss of neurologic function, and our evaluation with imaging and other studies are to find this area of ischemic or infarcted tissue and intervene as soon as possible. Once the tissue has died and the cells have been lost, function cannot be recovered,
And during the recovery process, we look to recruit other areas of brain to fill in that lost function. And that's ischemic stroke. The second type of stroke is a hemorrhagic stroke. This is the leaky blood vessel stroke, where bursting or rupturing of a blood vessel results in leaking of blood into the brain, and you can see that here in this schematic. The buildup of blood results in inflammation, and there's an inflammatory response that increases the total amount of water and cells that are in the brain. That can compress the nerves and blood vessels and result in secondary ischemia, as well as loss of nerve function and cell function, and ultimately cell death and that same loss of neurologic function. With hemorrhagic strokes, we see a greater likelihood of recovery because the ischemia that occurs is a secondary process, but we can still see substantial neurologic deficits. Our goal when evaluating either an ischemic or hemorrhagic stroke is to make the diagnosis as soon as possible and to intervene appropriately depending on the type of stroke that the patient is suffering. In general, we see that ischemic strokes are much more common. About 85% of patients who are presenting with a stroke will be suffering an ischemic stroke, a clot in some artery going to the brain, the cerebrovascular system. An important minority of strokes, about 15% of strokes, will be the hemorrhagic strokes, where weakening of the blood vessel results in rupture of the blood vessel, bleeding in and around the brain, and neurologic dysfunction for that reason. We're going to spend a lot of time talking about each type of stroke. When patients present, odds are we're worried about an ischemic stroke, but we need to be mindful of those patients presenting with a hemorrhagic lesion. And this is a good opportunity to talk about terminology. When we talk about hemorrhages in the brain, there are both intracranial hemorrhages, and that's bleeding anywhere inside the calvarium, the skull. And then there's intracerebral hemorrhage. That's bleeding inside the cerebrum, inside the cortex, the brain itself. So when we think about the types of hemorrhages that we can see in the nervous system, there's intracerebral or intraparenchymal hemorrhage, that's hemorrhage inside the brain tissue, and subarachnoid hemorrhage. Those are both strokes or types of hemorrhagic stroke. We can also see bleeding outside of the brain but inside the calvarial vault, and that includes subdural hemorrhage, epidural hemorrhage, and other types of hemorrhage. Those are not considered strokes, but are important types of intracranial hemorrhage. Some important terminology as we embark on learning about stroke.
And you have witnessed po na the video presentation of stroke. Pero to summarize everything, guys, na ano ba yung warning signs of stroke po natin? So before kasi, let's say with the American Heart Association, na 2020 guidelines, ang sabi nila doon, fast. Ayan. Ito yung mga warning signs daw natin. However, kasi with 2021, nilagyan na nila ng be fast para mas, 'di ba? You need to act quickly kasi you need to respond quickly. So what are the warning signs? So these are the warning signs of stroke. Before po natin, magkaroon ng mga clot busters, or let's say para 'di ba malusaw ang mga blood clots sa brain ng patient natin. So ayun, before tayo mag-start ng let's say management, you need to know the warning signs of stroke. Number 1, letter B. First letter, we have our letter B, we have the balance. So usually there will be a loss, there will be a loss of balance. Ayan na naman yung papansin kong pusa. Diyos ko. Akala ko natulog na to no? Nakarinig lang ng boses ko. Ayan, we have the loss of balance. Now, aside from the loss of balance, we have the eyes. So there will be the loss of vision. Guys, if ever po, 'di ba kung may loss of balance tayo, 'di ba, so ma-outbalance ang patient. Magulat ka na lang, biglang bumulagta ang patient mo. No, so careful po tayo. That can be a warning sign of stroke. Yung fainting na yan, baka kasi na-stroke talaga ang patient natin. Kaya lahat ng mga biglang bumulagta, you properly assess the patient. Next, there will be a loss of vision. Dahan-dahan din to. Biglang matataranta ang patient, but parang wala na akong makikita. But parang hindi ko na rin mararamdaman ang isang side ng katawan ko. Ayun na. Tapos, ang kanyang face, there will be facial drooping. Guys, when we say facial drooping, di ba, biglang na-paralyze ko ang isang side ng body, biglang nag-sag. Facial drooping, facial, okay, sag, di ba, nag-sag bigla, no? Ayan. So aside from that, we have the arm drifting. Okay, sorry. I-mute ko lang ha. Ayan, we have the arm drifting po natin. Guys, pag sinabi po nating arm drift, let's say, ma'am, na you elevate your both arms po. Tapos biglang nawalan ng strength ang kanyang isang arm, biglang nag-drift, biglang bumaba. Na biglang bumaba in short. No, ma'am, no, elevate ma'am, tapos biglang nawalan ng okay, strength. That's where the arm. Yan. Sorry po. That's where the arm, okay, drifting. Next, guys, we have the slurred speech. O, ito. Ang daming chismis sa slurred speech. Why? You need to identify if that's really a slurred speech or baka may okay, speaking problem or speech problem ang patient natin. 'Di ba? Guys, familiar with cleft lip and cleft palate? Na? Kasi nangyayari talaga yan eh. Ang dami ng nagkakamali ng mga paramedics or let's say mga, di ba, mga EMTs. Meron kasing pinapa-follow. Like for example, ma'am, repeat after me. You can teach old dogs new tricks. EMT sa Amerika, guys, ganun ang technique nila. You can teach old dogs new tricks. Sabi ng patient mo, you can teach old dogs new tricks. Ayun, pwedeng stroke yon. Pero pag sinabi ng patient mo, ayan, ma'am, repeat after me, you can teach old dogs new tricks. Sabi ng patient mo, you can teach old dogs new tricks. Guys, bayot ang patient nyo. Ayan. Or what if, nung sinabi mo, ako pala yung bayot. What if sinabi ng patient mo, ayan, ma'am, repeat after me, you can teach old dogs new tricks. Sabi ni patient, you can eat old dogs new tricks. Guys, iba po ang ngongo, no? Sa na-stroke. Tama po? Ibang-iba yan ha. Baka yung iba kasi, hala, na-stroke to. Diyos ko po, no? Ngongo pala si patient. Na? Hindi naman ako judgmental, pero nangyayari po yan. Sabi ng friend ko sa ERO, sabi niya, Mark, na may ngongo na, may na-stroke daw. Tapos nung tinanong ko talaga si patient, sabi ko, hi, good morning, sir. Sabi niya, good morning. Sabi ko, paano nagka-stroke to? Diyos ko, napahiya tuloy ako. Sabi ko, manda ka talaga mamaya. No? Jojowain ka talaga mamaya. Bantay ka lang. Ayun, naging jowa ko yung kasamahan ko sa hospital. We have letter T. Ayan, time. Ayan, to call. Okay, 911. Hindi ako judgmental ha, pero I'm just presenting the fact na yung mga facts po natin na nangyayari po sa hospital. Iba ang may cleft lip, iba ang may cleft palate sa mismong na-stroke na patient. Iba ang slurred speech na sa may mga speech okay, problem po. Okay po? Ayan. So again, it's your B fast. Letter B, out balance or loss of balance. Next, there will be a loss of vision. Next, we have the facial drooping, nagsag bigla. No? We have the arm drifting, nawala ng strength ng isang arm. We have the slurred speech. And guys, pag na-determine na po na may stroke ang patient, that's the time na we need to call, okay, 911. Are you still with me? Yes, na? So, ayun po, we have the stroke. Stroke occurs when someone blocks, okay, the artery papunta sa brain po natin. Siyempre, if there will be blockage, there will be a decrease in the oxygen and nutrients. Brain cells will die in minutes lang. Kaya nga ang sabi ko kanina, time is critical. Tignan mo, ito yung kagandahan ng brain din natin. Kasi ang brain po natin pwedeng mabuhay na less than 10 minutes na walang oxygen. Okay lang, pwede pa. Pero pag greater than 10 minutes na po, that can lead to irreversible brain damage. Kahit gaano pa kagaling ang doctor, kahit gaano pa ka-aggressive yung treatment, pag 10 minutes and above, ayan, brain dead na po ang patient natin. Clinically dead na din si patient. So ayun, irreversible pa. So pag 1 minute walang oxygen, yung heart mo, it will try to compensate. Biglang biglang, okay, bibilis ang pagtibok ng puso. Basta may gagawin ng heart po natin. Pag 0 to 4 minutes, guys, then, sige, wala pang brain damage dyan. Cardiac irritability pa rin. Pag 4 to 6 minutes po, then the brain damage is possible. Pwede. Ayan, pag 6 to 10, brain damage is very possible na talaga or very likely to occur or to happen. Posibleng mangyari na ang ang brain damage natin. Pero wag ka. Ito ang mas nakakatakot. Pag 10 minutes, okay, and above, that leads to irreversible brain damage. Again, kahit gaano pa ka-aggressive ang treatment, kahit gaano pa kagaling ang doktor na yan, pag 10 minutes talaga, 10 minutes is 10 minutes po. Lalo na pag above, sayang lang, ang pagka-aggressive ng treatment natin, it will all be useless. Ano kaya ang next topic natin? Anyone from the group? Nag-TikTok ba yan? Siyempre, hindi po siya nag-TikTok.
Seizure po.
Ayan, seizure. Great. Ma'am Mabel. Maybell or Mabel?
Mabel po.
Mabel. Hello, Ma'am Mabel. Ma'am, familiar po yung uniform? Sa Saudi ba yan, ma'am? Or sa Middle East?
Saudi po, sir.
Tama nga ako. Kasi yung ex ko, ma'am, ganyan. Diyos ko. Nabulgar tuloy eh. Kasi may ex ako na ganyan din yung lalaki naman yun, Siyempre lalaki, alam nga naman, hindi naman ako tomboy, Siyempre lalaki yung jowa ko, yung ex ko dati. Ganyan din yung itsura na para sila mga captain.
Military, sir, pag ganyan.
Doon siya sa King Fahad, ma'am.
Mga military hospital po pag ganyan, under ng defense.
Ay, kaya pala sabi ko, wait lang, parang ganyan ang itsura nun eh, Ayun. Tapos chinat niya ako, sabi niya magkikita daw kami. Sabi ko, huy, may asawa ka na.
Sana all daw may ex.
Sabi ko talaga sa kanya, huy, may asawa ka na, ano ka ba? Wag na, wala na. Ex, pass is pass, 'di ba? Pero kung may issue, edi pwede namang ungkatin. Kung wala, edi wag nang mag-ungkatan pa, Tapos alam niyo ba ang pinaka-worst nun? Ginawa niya pa akong ninong sa anak niya. Na dapat ninang talaga ako eh, grabe. So ayun po. So we have the word tonic, Pag sinabi nating tonic, guys, tonus, 'di ba? Meaning to say, that's the rigidity. Pero pag sinabi ko namang clonus, clonic, ito yung jerky movement ng patient natin. Ano kaya ang pinaka-importante pag nagsi-seizure ang patient? 'Di ba? Anong first letter ng seizure natin? Letter S. Tama po ba? So, safety ni patient. Tama po? Now, of course, you can slide the patient sa floor. You can turn the patient to sides in case lang na wala po siyang mga spinal cord na mga problems na pwede pong iside ang patient. Guys, question. Are we allowed to suction the patient? Yes or no? Yes. So you can suction the patient if ever lang kung suction device is present. However, 'di ba, pinagbabawal na po na maglagay ng mga padded tongue depressor, lalo na yung mga 'di ba, yung mga may mga terms na mga epileptic na mga patients. 'Di ba, from time to time po, nagkakaroon ng seizure sa kanila. Bawal maglagay ng padded tongue because that can cause secondary trauma to the patient. Bawal din maglagay ng mga spoon. Mas worse ang fork. Siyempre, yung iba kasi naglalagay ng spoon bawal na po because that can cause secondary injury, secondary harm to your patient. Baka what if may mga tooth injury, tas na-aspirate ang patient mo. So, delikado po yan. So, meaning to say, our next topic will be your seizure. So, therefore, with your seizure, guys, safety is always a priority here. No need for you to copy that. Sila Mr. Amandi nagka-copy bigla. Sila Mr. Guzman, parang mga masunuring mga estudyante to Feeling ko, nung kabataan nyo, ang babait nyo ng mga estudyante, feeling ko, nasa may unahan kayo yung mga matatalino. Kasi yung iba hindi na nagsusulat yung tipong, alam na namin yan. Sige, next slide. Sila yung tipong yung parang nasa harapan talaga, sulat, Sulat kung sulat. And that's nice we need to be hungry for knowledge talaga. Kahit ako din, from time to time, I need to read books para may ma-share naman din ako sa students ko. And gusto ko guys, updated yung books dapat. Na? Like for example, right now, I'm selling actually yung mga NCLEX books. Na? Yung mga NCLEX books ko kasi ang dami kasing mga magpupunta ng states, hiring po ang states ngayon. Kaya if I were you, mag-NCLEX na kayo. NCLEX ang pinakamabigat guys na review or let's say na title. Kasi pag USRN ka na, hindi ka na pwedeng mag-take ng HAAD, no? Automatic, no? Automatic i-shoulder na ng NCLEX 'yan. Na hindi ka na magte-take ng Prometrics, no? Ayan, yung sa mga yung mga Dubai Health Authority na yung mga ganon, na mga DHA po nila ng mga examination, mas powerful ang NCLEX. Kaya ngayon pa lang, no, planuhin niyo na mag-NCLEX kayo para while waiting, pwede kang pumunta ng Middle East, 'di ba? Basta NCLEX, na. Ayan, sige po. Let's have the video presentation of your seizure. Okay, for a while. Saan na ba yung seizure po natin? For a while Burns kasi to eh. Wait lang. Andito yun seizure. Okay, let's have
4 times the cheese on a flame grilled beef patty. Burger King 4 Cheese Whopper Jr. 99 lang.
May muna tayo, may ads muna tayo.
Relax. Don't panic, just move back.
Move any potentially harmful object out of harm's way to prevent injury. Do not restrain the person and give him or her head support. After the seizure ends, move the person onto the side. Tilt his or her head back to protect against choking from possible vomiting. How to give emergency medical aid to seizure patients. Move any potentially harmful objects out of harm's way to prevent injury. Do not restrain him or her from moving. Provide head support and wait for the attack to end. After the seizure attack eases, move the person onto the side and tilt his or her head back to prevent choking.
Okay, so with your seizure po, again you need to ease the client to the floor. no? And then you need to remove no yung mga harmful objects po na pwede kasing pwedeng mag-cause ng injury kay patient po natin. Like for example, yung mga furniture po natin, no, kailangang tanggalin 'yon. Okay po? Ayan, sige. So let's have no our next topic. Ano kaya ang next topic natin, guys? Obvious naman, no? Na na-shock ang patient po natin. So our next topic will be the shock, management. So shock is actually a life-threatening condition. Now, what are the signs na baka may shock na ang patient natin? So we have the weak na pulse po, na or let's say weak na ang feeling ni patient, tapos about to faint na ang patient natin, tapos may dizziness na po tayo, na mga signs of shock na po yan. Next, we have the pale skin, and yung iba din po ay gray skin na sa sobrang pale na ni patient. Next, expected po ang tinatawag na the restlessness, na. And then si patient din po natin is agitated. Okay po? And then sometimes, no, and most of the time rather, confused na ang patient mo. And ito cold and clammy, diaphoretic patient. These are the warning signs, no, or let's say sign na nagkaroon na ng shock ang patient po natin. Ulitin natin. We have the weak, na faint, dizziness plus grabe din yung sweating niya, diaphoretic patient. Pale skin, gray skin, restless ang patient nyo, balisa ang patient, and minsan tulala ang patient, no, confused. Tapos nanlalamig ang patient nyo. And that's your shock natin. May na-ready po ako na video regarding shock. For a while lang ha. Ayan. Para mas maganda, dapat may mga video talaga. For a while. Ito pala dapat yung seizure natin. Sana naman yung shock ko. Wait lang. Wait lang ha. Okay. Nawawala ang shock. Anyhow, sige lang, utang ko na lang yung shock na guys na video po natin. I-discuss ko na lang kung ano yung mga gagawin po natin in case lang na may shock ang patient po. So with all the signs and symptoms like weak, faint, no, cold, clammy, restless, agitated patient. So the management for your shock, number one, na you need to verify the scene safety. Kasi bakit na-shock ang patient natin? Na? Pwede kasing baka ang patient mo ay naka-inhale ba, or let's say baka ang patient mo may mga nakaaway ba ang patient po natin. So always determine for scene safety. Next, you need to phone for help. Simply you call 911. Next po, you help the victim lie on his back. Help victim. Ayan, help the victim lie on his back. So meaning nakasupine position ang patient. Pero again, you need to raise legs of the patient. Now, in order for you to raise the legs, you need to make sure na there should be no pain from the patient. Kasi habang nagli-lift ka, baka sabi ng patient mo, aray. So, wag mo nang i-lift po kasi baka may mga leg injuries ang patient. You're simply allowed not to raise the legs if there will be no pain. Tapos may mga, let's say, wala po siyang leg injuries. So, no leg. No, leg, injuries po. Ayan, you are allowed not to raise the leg. So meaning to say, pwede kang gumamit ng box. The same lang po sa pag-manage ng fainting natin. 'Di ba? Or the syncope, you're allowed to raise the legs. Now with the use of the box, na roll coat po natin, pwede. And then if ever guys, kung may bleeding pala si patient, you will be wondering bakit may bleeding siya. Shock, sinaksak pala to. Kaya may mga shocks na tayo na if ever kung may mga bleeding po, use pressure for bleeding. Use, pressure, for, bleeding po natin. Okay po? And then lastly, guys, no, you cover, okay, with blankets po. You cover the patient. Ayan, cover the patient, okay, with blankets po natin. Why? Siyempre, we need to preserve kasi na the temperature, okay, of your patient, na yun talaga yung pinaka-goal po natin doon. Na kasi ang patient mo nanlalamig eh. Edi painitin po natin ang patient natin. Okay po? So again, these are the management in case lang na may shock na. So we have the scene safety. Now you need to call for help, no? Or let's say phone for help. Help the victim, okay, to lie on his back or simply supine position. You can raise the legs of the patient. Kasi upon raising the legs of the patient, ibabalik po natin yung mga nawala na dugo na pumunta lang po sa kanyang lower extremities, ibabalik po natin yan sa heart niya. And from the heart, ipapump po yan towards the systemic circulation. If ever kung may obvious na bleeding, guys, na pwede po tayong mag-apply ng pressure. And then if ever kung may mga blanket tayo, sa States kasi may mga silver blanket yan eh, parang mga foil na mga thermal blanket po nila. Ayan, na para mag-cause siya ng tinatawag na mga syempre vasodilation kay patient. Na? So mas maganda din 'yon, no? Somehow mag-a-add din siya ng warmth rather, kay patient po natin. Wait lang ha. Ayan, so we're done na sa ating shock. Next topic po natin, guys, will be your hindi siya nosebleed, but rather your bleeding as a whole. However, kasi what's the other term na for nose bleeding? Anong tawag dito, guys? It's your letter E, epistaxis, 'di ba? Or the nose bleeding. 'Di ba may mga joke tayo na pag grabe yung English ng isang professor po natin, nag-nosebleed tayo, na? But the proper and the medical term for nosebleed na is your epistaxis. Sige nga, sabay-sabay tayo. Everybody say epistaxis.
Epistaxis.
Ayan. Thank you so much na. Ayan, pakita ko ng video ha ng epistaxis po natin. Not ng epistaxis but rather ng bleeding po. Okay, nasaan yung bleeding ko dito? For a while, guys. Burns. Ayun.
What happened?
You listen carefully.
My name is Riley. I'm training first aid. Can I help you?
Yeah.
What happened?
He slipped.
Okay, I need you to hold pressure as hard as you can. Is anyone else hurt?
No.
Keep holding pressure. Activate emergency response protocols for a conscious adult female that is bleeding profusely from the leg.
Calling 911 now.
Keep holding pressure. You're doing good. Hands off. I need your help. I need you to come and grab gloves out of the first aid kit and put them on. Good. I need you to help her lay down. Watch her head. Good. I need you to come to the other side of me and take over pressure. Hand over hand, as hard as you can. Okay, I'm gonna add a second one on top here. Hands back on. Good. What's your name?
Brooke.
Brooke? 911's been called. Help is on the way. Can you feel your forehead? Good. I'm looking for any other injuries. Let me know if anything hurts, okay? Good. Keep holding pressure. Okay, Brooke. I'm going to have to apply a tourniquet. You're going to feel pressure on your leg. Holding pressure. You're doing good. Okay, you're going to start to feel pressure, Brooke. Okay, add another layer here. Good, hands back on. Looks like we can bandage now. I'm gonna slide this under. Hands off.
Ayan. So let's discuss, okay, bleeding. Now, with bleeding kasi, there is the loss, okay, of blood. Now, with active bleeding din, no, meron kasi tayong pinaka-common na ginagawa po. And that's your, okay, the letter P, R, I, C, and letter E. Ito talaga yung pinaka-the best na management, guys. Letter P stands for what? The pressure dapat. Na maglagay tayo ng pressure. So if ever kung magbi-bleed na naman, sige, another pressure na naman po. Pero lalagyan natin ng gauze. Bawal na kasi ang cotton ngayon. Kasi 'di ba pag ang cotton na soak sa blood, magulat ka biglang mawawala ang cotton. Same with na nakakatakot din yung mga gauze po natin. Kasi pag once yung gauze po, kaya 'di ba, ang dami mga chismis na let's say sa OR, no, na wait lang, but parang may mga naiwan na mga gauze kay patient kasi once na na-soak na sa blood, mahirap na po silang hanapin din. So again pressure is important. Next, of course, na rest. If there is actually an active bleeding, dapat ipa-rest po ang patient natin. Aside from that, we have the immobilization. Ayan, immobilization. Kailangan din. The more mo kasing immobilize, the more mo kasing, let's say, i-move ang client, the more magbi-bleed ang patient. Kaya dapat pressure should be there. Rest dapat, ipa-rest ang patient. Immobilization, importante din yan. Next, we have the cold compress. Ayan, dapat may cold compression po tayo. Kasi guys, ano ba ang ginagawa ng ice natin? Vasodilation or vasoconstriction? Sige nga. Is it vasodilate or vasoconstrict?
Vasoconstriction.
Yeah, so we have the word vasoconstriction. So pag may vasoconstriction guys, hindi magbi-bleed thoroughly ang patient natin. Masa-stop siya. Whereas kung magbibigay ka ng warm water, Diyos ko po, ng hot compression, let's say warm compression rather, mas lalo magbi-bleed ang patient at mas lalo siyang namamatay. No? Yung tipong piso na lang, mamimit niya na ang Panginoon. Ayan, next, lastly po, we have your letter E, elevate. Ayan, or elevation. Tama po, ma'am. So again, name the price. If there's a bleeding, you name the price. Pressure, okay, rest, immobilization, cold compression, and then we have your, okay, the word, okay, elevation po natin. Elevate, okay, the affected. Okay, affected, okay, area or the affected part po natin. Okay, and that's your, okay, bleeding. So we have the bleeding, okay, you can see. Guys, obvious naman nakikita naman po ang bleeding dyan. Pag ganyan ang itsura ng patient nyo, pupuntahan mo ba or wag muna? Ayan. Bibigyan mo ba ng first aid or pipicturan mo lang? Siyempre, pupuntahan po natin. But then again, siyempre, wag ka dire-diretsong pumunta. Bakit kaya may dugo sa kanyang ulo pwedeng binaril? 'Di ba? Or pwede na aksidente. Mas nakatakot yung binaril. Kasi bakit siya binaril? baka yung mga nagbaril din ay nasa paligid niya lang din. Baka ikaw yung next na babarilin. Kaya dapat safety is important. Na huwag matakot na malalaman naman natin na whether okay, safe ba ang area na yan or not safe. Naalala ko pag sa Manila, pag sinabing Tondo, Manila, 'di ba sir, no? Pag sinabing Tondo, nakakatakot agad, no? Pero napuntahan ko naman ng Tondo, hindi naman siya ganoon talaga nakakatakot. Ang dami kayang gwapo doon. Yan, ang dami kayang mga artistahin sa Tondo, Manila, no? Amazing nga. Eh. Ayan. So we have the bleeding you can see, which is really obvious. Next, we have the bleeding you can't see. Guys, internal bleeding po ang mga ito. Di ba? Mga hematomas po natin. Ayan, the hematomas. Or these are the pooling or the collection of dead RBCs. Now, bakit kaya may mga pooling? No? Kasi baka may mga blunt trauma na nangyari. Di ba? Ayan, no? So wala lang exits ng blood pero may impact. No? May hard impact talaga. So nakatakot to. Okay po. Now, next topic po natin, guys. Mamaya na yung electrocution natin. I'll be presenting burns. No? Burns na yung next topic natin, ha? Ayan, for a while lang po. Sa burns po natin, I have prepared a video po regarding burns. Ayan, burn discussion muna tayo. For a while lang po.
$85,000 ED visits. Hello, now we're going to talk about burns and smoke inhalation. Burns are a very common phenomenon. There are 85,000 ED visits per year in the United States related to burns, and fortunately the vast majority are minor. Only 2% of burns seen in United States emergency departments cover more than 40% of the body surface area. There are 34,000 deaths per year in the world. Case fatality rate is directly correlated with how much surface area is covered by burns. So the greater the surface area, the more likely you are to die from it. And once you get up to 60 to 70% total body surface area covered by burns, half of the patients are going to die. We see scalding or liquid burns more commonly in children, whereas we see flame burns more commonly in adults, although obviously both groups can experience both types of burns. Burn severity is classified according to 3 factors. One are the patient factors. The patient's age and comorbidities are a major determinant of how well they're going to do following a burn. Burn depth and location is another feature of the classification. So how deep the burn is and where on the body it is going to change outcomes. And then lastly, how big the burn is or how much of the total body surface area or TBSA it covers. There are no hard and fast rules here. So when we stratify burns into mild, moderate, and severe, we should always be sort of looking at the big picture of the patient's overall health and thinking about the impact of this burn on their life. And when in doubt, you should always treat a burn as a major burn. But there are some general guidelines that help us decide whether a burn should be treated as a mild event, a moderate event, or a severe life-threatening event. So mild burns are those that cover less than 10% of the total body surface area in adults, or less than 5% in extremes of age. In general, less than 2% of body surface area should be covered by full thickness burns. Provided the patient meets these criteria and they're reasonably healthy, they can generally be managed on an outpatient basis. Moderate burns are those that cover 10 to 20% of the body surface area for adults and 5 to 10% at extremes of age. To have a moderate burn, you might have a higher percentage of full thickness involvement, and generally any burn that's sustained through high voltage exposures, is associated with inhalation injuries, is circumferential, meaning it goes all the way around one part of the body, or if the patient has any significant underlying comorbid disease, we should consider their burns to be at least moderate, and these patients generally merit admission to the hospital. For severe burns, we're looking at greater than 20% of total surface area or greater than 10% at extremes of age, and we're looking at greater than 5% deep burns. We're also looking at any high voltage injury, burns in sensitive areas like the face, eyes, ears, genitals, and over joints. And we're also looking at patients who have significant associated trauma. These patients should really be managed in specialty burn units as their risk of morbidity and mortality is quite high. When we think about burn depth, we classify burns into 4 groups: superficial burns, which had previously been known as first-degree burns; superficial partial thickness burns, which previously had been known as second-degree burns; deep partial thickness burns, which were also part of second degree in the past; and then full thickness or third-degree burns. When we think about burns, the clinical exam is really, really important. So the appearance of the burn, whether or not the patient has sensation there, what it feels like when you palpate it, these are all the things that help you figure out how deep the burn is. So generally, superficial burns will look just like a sunburn. They'll be red, but not blistering or with minimal blistering. They'll blanch with pressure. They'll be very sensitive to pinprick or any kind of light touch will be quite painful. The tissue will feel soft, and generally these are going to get better within about a week. For superficial partial thickness burns, that's where we're going to start to see blistering begin. Again, these burns will blanch with pressure, they will be sensitive to pinprick or light touch, and the tissue should be soft and pliable. So the real difference between the superficial partial thickness and the superficial is just the presence of blisters. It takes a little bit longer for those blisters to heal, so generally you're looking at about 2 weeks of healing time for these patients. Deep partial thickness burns have a different appearance compared to the more superficial burns we've already discussed. So these can be red, but they're more commonly white and non-blistering. They don't typically blanch with pressure, although red areas might. They do retain some degree of sensitivity to pinprick, but the thing that's really different about them is the consistency of the burn tissue. So while the superficial burns, the tissue feels soft and pliable, just like normal tissue, now the tissue is going to feel more tense. That's because this tissue has literally been cooked, resulting in chemical changes to the connective tissue and the protein structures inside of the tissue, which you can actually feel the difference compared to normal soft, pliable tissue. Your deep partial thickness burns take longer to heal and typically do require some degree of excision and skin grafting to heal completely. Full thickness burns are very striking and very easy to identify. These will actually appear leather-like and charred. They are insensate, non-blanching. You can touch them, poke them, do whatever you want, and their patient's not going to feel anything, and that's because the nerve endings are actually burned away. They're not pliable at all. They feel like hard, stiff leather, and these take a significant amount of time to heal and do almost invariably require excision and grafting, again, for coverage. So let's offer some visual examples of the different burn types. This is a superficial partial thickness burn, which, like I said, is going to be red. It's going to be shiny in appearance. It's going to be blistering, and it's going to be very, very sensitive. So even light touch on this baby's skin is going to probably produce some significant screaming because these are very painful. By contrast, here's a deep partial thickness burn. So you can see some redness across the knuckles and fingers, but note the whitening in the area on the dorsum of the hand. That's very characteristic of a deep partial thickness burn. And if you're able to touch that, you'll appreciate that the tissue's not pliable, it's actually tense and firm, again, because of the chemical changes that have occurred with the connective tissue proteins. There are no blisters in that area, although there are some more superficially burned areas farther up on the wrist and forearm. The dorsum of the hand is non-blistering. So that's very characteristic of a deep partial thickness burn. And then here's an example of a full thickness burn. So this child has had both feet burned, and I want to call your attention to the central area in each burned region where you can see that the tissue is yellow, and you can almost imagine that it's tense and contracted and thickened. And that's going to give you that sort of leathery texture when you go to palpate that skin. These burns, as awful as they look, are insensate because, again, the nerve endings have been damaged in the course of burning.
Okay, guys, our last topic will be the spinal cord po natin, yung mga cervical na ano po, let's say trauma or injury. Pakita ko lang yung video natin ha.
Oh, wow. What happened?
I fell.
Don't move. Help! I need first aid.
Hi, my name is Brooke. I know first aid. What happened?
He fell off the ladder.
Is anybody else hurt?
No.
Hi, my name is Brooke. Don't move. Can I help you?
Yes.
Activating emergency response protocol for an conscious adult male who has fallen from a ladder to the balcony. Can you reach
Calling 911 now.
Can you reach into that first aid kit and grab some gloves and put them on, please? I'm just gonna put some gloves on and help hold your head still, okay? Can you come on over here and kneel down beside me? And you're gonna take over holding his head still, okay? So elbow by my elbow, hand over my hand, and I'm gonna slide my hand out.
Okay.
And we're gonna do the same thing on the other side. Elbow by my elbow, hand over my hand, and I'm gonna slide my hand out. You got him?
Yes.
What's your name?
Earl.
Earl, help is on the way. I'm just gonna do a circulation check. And I'm gonna check for any other injuries. If anything hurts, let me know, okay? We're gonna put a blanket on you, Earl, to keep you warm. Please let me know if you get too warm. The ambulance is on its way.
Okay, that's the last topic po. Questions? Questions po? Wait lang ha, i-ano ko lang. Stop ko lang yung screen sharing po natin. Let's entertain let's have the Q&A portion po. Sino yung mga Acls po namin dito? Yung mga Acls only, yung kakapasok lang, meron po ba? Okay, meron po. Ayan, hello Miss Griarte. Ayan, sino pa? Yung mga wala kaninang morning. Si Miss Griarte lang ba? Okay po. Pero Miss Griarte, andito ka naman ng mga 1 o'clock na nung pag-start ng ating first aid. Tama po? Tama ba, ma'am? Okay. Sige. Sige po. So, that's all, no, for today. Ayan, kasi for sure yung iba ay na-drain talaga ng sobra. Nag-start tayo ng 8 o'clock na. So, guys, tomorrow po, 'di ba, it's a Sunday. Pero kasi itodo-todo ko na ang ECG, no, and pharmacology po natin. Expected po tomorrow siguro mga mag-i-end tayo na mga 3 o'clock, no? Or on or before 3 o'clock. Okay po? So basta mag-start na ako ng ECG pharmacology morning pa lang. Ayoko kasing magturo ng ECG paghapon kasi malamang hindi ma-absorb talaga ng student 'yan. Gusto ko ma-absorb na ang ECG. Like for example, wait lang, pakita ko lang yung kung paano po tayo magdi-discuss tomorrow. Para naman, para inviting naman siya at para yung mga nag-BLS only gusto na tuloy mag ACLS din. Okay, in the course of your ECG kasi, tomorrow po, I'll be demonstrating, okay, how to read an ECG into 4 easy steps. Number 1, you're going to tell me the heart rate, to be followed by the rhythm, whether if it's regular or irregular. Next po, you're going to determine the P wave of the patient. And lastly, for the QRS of the patient. Para ma-excite ka lang tomorrow. Let's say, sir, please analyze the rhythm on screen. The heart rate is 70, which is normal. The rhythm, okay, of the patient is regular. I can see P waves, they are clear and upright, followed by QRS, which is normal in nature. The patient here is having a normal sinus rhythm. But again, according sa American Heart Association, di porket NSR na yan, no, if forever healthy ang patient, no. Who knows later, baka biglang, okay, magkaroon ng what? No, ng dysrhythmia, arrhythmia ang patient natin. Kaya you always na continue to monitor your patient. What if ganito ang itsura ng patient natin? Guys, na tignan natin ang kanyang heart rate. 'Di ba 38? Normal heart rate kasi 60 to 100. If that's less than 60, malamang it's a bradycardic na patient. And then tignan mo naman ang kanyang rhythm. It's regular. The P waves po are clear and upright, followed by QRS, which is normal in nature. Now, the patient here suffers from what? Sinus bradycardia. So tomorrow, pag sinabi kong sinus bradycardia, automatic iti-treat agad natin yan. Now, 'di ba, ang treatment po for adult, ano nga yung treatment for adult po? It's what? Atropine sulfate. Pag pediatric naman, epinephrine po. Okay? So again, ganyan po ang mangyayari tomorrow. So questions before I end the topic. Hindi na kasi tayo nag-break, no? Dire-diretso na po tayo. Ayan. So announcements po from WePump. Ma'am Joy, may mga announcements po ba tayo?
Hello, madam.
Hi, ma'am.
Opo.
Yes, ma'am.
So
Yes,
wala
ma'am.
naman pong announcement. Yung mga BLS only po, kung gusto niyo po mag-attend tomorrow, pwede po kayo mag-attend tomorrow until ACLS.
Yes po.
In case po na mag-decide kayo na mag-upgrade ng training, pwede naman po, contact nyo lang po yung coordinator na nag-a-assist sa inyo.
Yes po.
And again
For
po,
me
yung
kasi, yes po. And for me kasi guys, for a complete experience, kailangan whole package na i-grab niyo na ang opportunity na mura pa ang training ngayon. Kasi pag nag-face-to-face na, hindi na po kami bababa ng 4-5. Na usually 4-5 and above na po. So if I were you, i-grab nyo na. Sayang po ang opportunity na to. If you want to go abroad, hindi lamang BLS ang kailangan nila. Kasama po ang ACLS. Kasi you will be analyzing ECG tomorrow plus yung administration ng drugs natin. And then meron kasi tayong parang mega code na via a video po. Yan po.
Yes, madam. Kasi naka 70% off tayo ngayon kasi online tayo.
Yes.
Pag face-to-face na, nasa 5,599 na po ang BLS, ACLS, and First Aid.
True.
So, yan. And 2 years din po ang expiration nito. Kaya if ever na mag-abroad kayo in 2 years, magagamit nyo. Di ba, madam?
Yes. Kasi may mga ibang estudyante kami na nagsisisi talaga. Sir, sana pala nag-ACLS na din ako, sir. Kasi bound for, let's say, Middle East. Alangan naman doon pa siya magti-training. No? So, i-grab niyo na opportunity. This is a once in a lifetime. Kahit, 'di ba, kahit si Sir, let's say si Sir Ariel, pwede po siya mag-ACLS kasi para matuto din siya sa ECG. In case baka ang nurse niya nakasama niya sa ambulance, baka let's say nagkaroon ng amnesia. Si Sir Ariel na ang mag-analyze. Ako na mag-analyze nito. Ako na din ang magti-treat nito.
Saka madam, mas mura po pag bundle. In case na next year, mag-avail sila ng ACLS only, iba po ang fees ng BLS only and ACLS only sa bundle BLS and ACLS. Mas makakamura po kayo.
True. Ayan po. So, kayo na mag-decide.
Oo.
Basta
So, see you
kami,
tomorrow, madam.
yes po.
At 8 a.m.
Yes, ma'am. Yes po. Thank you, Ma'am Joy. Thank you po, doctors, nurses, midwives, na ambulance driver, allied health professionals, medtechs. Mag-ingat po and enjoy the rest of the day kasi it's a Saturday, no? Mag-bonding po. na with your family. Ingat po.
Yes po. Thank you so much po.
Thank you po.
If you have any questions po or concerns, kindly message our page, WePump Center for Learning. Yan, message lang po kayo. Thank you so much po. You can leave our Zoom meeting po. Pag below 25 participants na po yung Zoom meeting natin, i-end ko na po yung Zoom. Thank you so much po and God bless you.